যাও না কিছু
লাইন করে হুঁকে লইব
সুদীপ
স্টার্ট করব
হ্যাঁ স্টার্ট
okay respected members of Bangladesh Association of Urological Surgeons and dear residents, good morning. I am Dr. Shudip Dashgupta, Scientific Secretary of Bangladesh Association of Urological Surgeons. I welcome all of you to BAUS-AUA Lessons in Urology course 2020. This time we all know that we are in COVID pandemic situation. So at this time we are not physically present, but this is a virtual meeting. And since 2015, Bangladesh Association Urological Surgeons and American Urological Association are arranging lessons in urology course for the residents. So with the permission of the President, Dr. Mohammad Habibur Rahman, President of Bangladesh Association of Urological Surgeons, I want to start today's morning session. I request Dr. Juhurul Islam Mia, who is joining us from Faridpur, with recitation from Holy Quran. I would like to start the session. I request Dr. Juhurul Islam Mia for recitation from the Holy Quran.
জোর স্যার আপনাকে আনমিউট করেন আনমিউট করতে হবে জোর স্যার ওকে
শোনা যাচ্ছে হ্যালো
হ্যাঁ শোনা যায় আপনাকে
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم
হ্যালো মিউট হয়ে গেছেন শোনা যাচ্ছে না
জোর স্যার আপনি
ঠিক ছিল আবার ইয়া করে দিয়েছি
ছিল হ্যাঁ
এখন ঠিক আছে
يا أيها الذين آمنوا هل أدلكم على تجارة تنجيكم من عذاب أليم تؤمنون بالله ورسوله وتجاهدون في سبيل الله بأموالكم وأنفسكم تؤمنون بالله ورسوله وتجاهدون في سبيل الله بأموالكم وأنفسكم ذلكم خير لكم إن كنتم تعلمون يغفر لكم ذنوبكم ويدخلكم جنات تجري من تحتها الأنهار ومساكن طيبة في جنات عدن ذلك الفوز العظيم صدق الله العظيم. Now I am reading the meaning in English. Oh, you who have believed, shall I guide you to transaction that will save you from a painful punishment? It is that you believe in Allah and His Messenger and strive in the cause of Allah and your wealth and your life. That is best for you if you only knew. He will forgive for you your sins and admit you to garden beneath which rivers flow and pleasant dwelling in garden of perpetual residence. That is the great attainment. Sadaqallahul Mawlana al-Azim. Finish, Shudip. Dr.
Thank
Shudip.
you. Thank you. Now I request for welcome speech from Secretary General of Bangladesh Association of Urological Surgeons, Dr. Tauhid Mohammad Saiful Hussain. Dr. Tauhid Mohammad Saiful Hussain.
Thank you, Dr. Sudip Das Gupta, Scientific Secretary, Bangladesh Association of Urological Surgeons. Honorable President, Bangladesh Association of Urological Surgeons, Professor Habibur Rahman, today's chief guest of this inaugural session of the virtual AUA BAUS lesson in Urology course 2020. My senior teachers, my respected teachers, mentors, senior members, executive committee members, today's viewers, and my teachers who make the bridge between the American Urology Association with the Bangladesh Association of Urological Surgeons, particularly Professor M.S. Salam, and all the past president, Professor M.A. Wahab, Professor S.A. Khan, Professor Rafiqul Abedin, and our late Professor S.M. Ghulam Kibriya, and my dear resident for whom this today's course. First of all, I pay my deep condolence and homage to the father of the nation, Bangabandhu Sheikh Mujibur Rahman and his family, who murdered in this month of the August. And I acknowledge all my teachers and mentors. You know, the COVID-19 pandemic changed our day-to-day life in every aspect. So many of our doctors in Bangladesh are died, and so many of our urologists are infected, and we lost our great mentor, Professor S.M. Ghulam Kibriya, Dr. Manjur Rashid Chaudhary, our senior brother and dedicated urologist in this country, Dr. Abdul Mabud Chaudhary, who is our member, he is our foreign faculty and son of this soil. I remember them in this inaugural session. You know, this is for the travel restriction, social distancing, all scientific activities are now in virtual media. And you see, all the international meetings are postponed in this year. So in this regards, I must thanks to American Urology Association leadership, particularly John Danstead, Ashim Shukla, and their officials, Laurie, Leslie, and other so many AUA team for their extreme efforts and supports to make this today's lesson course really happen as a part of their activities for advancing urology globally, particularly in Asia and particularly in Bangladesh. Hope our members and the residents are immensely benefited by joining this 2 days course. You know, we have the 2 days course and the highlights are carcinoma prostate, pediatric urology, andrology and infertility, and female urology. And this year we introduce, you saw our so many students, they not doing well in written exam. So this year we introduced the how to write written answer question, and that will occur tomorrow. And today we have with us 4 eminent faculty, particularly 3 from the AUA and 1 our own faculty, Professor M.A. Chaudhary, who is the mentor of our mentors and who is a dedicated teacher. You know, he is the professor of and head of the urology in the New York Medical College. He is also the honorary professor of Bangabandhu Sheikh Mujib, honorary professor of urology in Bangabandhu Sheikh Mujib Medical University. And you all know he is the son of this soil, and he is the ex-student of Sylhet M.J. Osmani Medical College. And I appreciate him I acknowledge him and I give him salute for his agreement to develop the Bangladesh Association of Urology more and more, and for for accept our warm invitation of today's inaugural session as a chief guest. So thank you very, very much. And we have three eminent faculty from the AUA. You all know the Ashim Shukla. He is a renowned pediatric urologist, and he is also the Assistant Secretary of the American Urology Association in the South Asia, Australia, and Africa region. And another faculty is the Tavis Kohler. He is a renowned andrologist. And another is Priyanka Gupta. She is a female urologist. Hope you all enjoy their lecture. And for these three sessions, we have a very eminent three urologists from Bangladesh. They are the BAUS faculty of today's session, today's scientific meeting of today. All of you know the Professor A.K.M. Khurshidul Alam. He is the now chairman of urology in Bangabandhu Sheikh Mujib Medical University. He is a renowned urologist and transplant surgeon of this country, and he had a he is a very extensive educational background. He did MCPS, FCPS, MS in urology, and he got training from the Singapore General Hospital, and also he had more than 60 publications in Bangladesh and abroad in so many journals. He was a former editor of Journal of Bangladesh Association of Urological Surgery, and he worked in various positions in urology. So he will moderate one session in female urology. We have another moderator, Professor A.K.M. Istiaq Shamim. He is the professor of pediatric urology in Bangabandhu Sheikh Mujib Medical University. He is the scientific co-chair of Bangladesh Association of Urological Surgeons. He did his job in various positions in Bangladesh Association of Urological Surgeons and various positions in urology. He had a lot of publication. He did PhD from the Japan in urology, and he had a lot of publication in home and abroad. He will moderate the pediatric urology session. And another eminent faculty is Professor Nurul Huda Lelin. He is the professor of urology and the director of National Institute of Kidney Disease and Urology, who will moderate the session of the andrology. And he got training from the various from the Germany, from the Japan, and he was the former secretary of the BAUS, and he did his job in urology in the various positions from the Dhaka Medical, Salimullah Medical, National Institute of Kidney Disease, and he also did his academic qualification, FCPS, MS, and so we congratulate all the moderator. I invite all the audience and participant. If you have any question, please you give the question in a chat box. And particularly all the moderator will, after concluding the session, they will moderate the question answer session. They will give their answer. As you know, that today's scientific program is mostly all the three AUA faculties lecture is pre-recorded. Due to travel restriction and the time difference, they cannot join us with us today. They delivered all the lectures by pre-recorded. We will deliver it from here. So after concluding the session, all three moderators will conclude concluding speech by giving their speech over the topics. And if you have any question, you raise your hand or you give your question in the chat box. And if the moderator think they can include any person, senior person, any senior teacher from the audience. So there is no more talk. And lastly, I must say to our members to ensure this collaboration with the AU and our ongoing friendship. Dear participants, we must continue our renewal of the membership with the AUA, both our member and both our resident. This is mandatory, and this is I request all our members and all residents to become renewal the membership. So with these words, I welcome you all in this today's AUA BAUS lessons in your virtual AUA BAUS lessons in urology course. Thank you very, very much. Thank you for the patience hearing. Assalamu alaikum.
Thank you, Dr. Tauhid Muhammad Saiful Hussain. We all know that this is a virtual lesson in urology course, And I hope all the members of the association and the residents have a guideline how to enjoy today's program. Now, this is a virtual lesson, and you have already heard that there will be a welcome speech from American Urological Association, and this is a pre-recorded speech. I request Shumon now to publish it in the web. Welcome speech from AUA, Dr. Oshim Shukla, who is Assistant Secretary of American Urological Association. No sound. Hello.
The screen shows the last part of the speech. I think it should start from the beginning.
But I cannot hear. Shubho?
হ্যাঁ সুমন হ্যাঁ শোনা যাচ্ছে না তো? এখানে আমরা কেউই শুনতেছি না। আচ্ছা দেখতেছি স্যার।
হ্যালো, আমরা শুনতে পাচ্ছি না আমি। We cannot hear.
এটা টেকনিক্যালটা সলভ করতে করতে নেক্সট স্পিকার লাইভ যে আছে সে দিতে পারে। টেকনিক্যাল ইস্যু বোধহয়। স্পিকার দাও তারপর ওটা ঠিক করে এটা
সুমন কই কি ব্যাপার?
ওকে ওকে
একটু সাউন্ড চালানো কিন্তু সাউন্ড দেওয়া যাচ্ছে না।
যদি এটা নেক্সটটা ই করো।
Then can we move to the next speech? Okay. Thank you, President. Thank you, Mr. President. Now I request Professor Jamanul Islam Bhuiya, who is the chairman of the scientific subcommittee and member IMC AUA. I request Dr. Jedai Bhuiya.
Mr. President, Professor Habibur Rahman, Secretary General of BAUS, Dr. Tawhid Mohammad Saiful Hussain, and AUA Secretary Dr. John Danstead, faculties from AUA, Dr. Oshim Shukla, Dr. Tobias Kohlar, Dr. Priyanka Gupta, and moderator from Bangladesh, Professor Akam Khurshidul Alam, Dr. Istiaq Ahmed Shamim, and Professor Nur Huda. And chief guest, our mentor, our teacher, Professor M.S. Chowdhury, and our different level teachers and my students. Very good morning. This BAUS and AUA lesson course, we are running it since 2015, and the key of this program was who is established. This is today's our chief guest, Professor M.S. Chowdhury, and I must thank him for this endeavor and for going the Bangladesh urology far and far ahead. Dear residents, particularly this program is for residents, although we will also become benefited from this, no doubt. But this program is assigned for residents, and there is definite lectures and definite question answer and thereafter examination. And tomorrow already you have heard it from our Secretary General that there will be another session by our national faculties. I think this will be very fruitful for you all, these residents, and you learn a lot. We are running various courses with AUA as well with SIU. And this is regionally and internationally, and these will develop our urology in various ways, from higher technology to our technology, which is applicable to our society. And that's why I think this is also very important for us. And I must thank Professor M.S. Chaudhuri and another guys who are coming, Professor Mukhtar Ahmed, for their endeavor and for their taking trouble to go the Urology of Bangladesh to go ahead. I will welcome you to come to the session and to enjoy. I think, thank you very much.
Thank you, Professor Jamalul Islam Bhuiya, for your speech. Now I request our today's session chief guest, Dr. M.S. Chaudhuri, who is the professor and chairman, New York Medical College. We all know that Mr. Chaudhuri has good support for Bangladesh Association of Urological Surgeons. And we always become grateful to him for our cooperation and relation with the American Urological Association. I request our chief guest, Dr. M.S. Chaudhuri, to address to the members and to the residents of today's program. Chaudhuri, sir.
Sure. Thank you, Shudip.
Thank you, sir. Sir, we cannot hear.
Okay.
Yes, sir.
I'm
okay,
unmuted.
okay. No, sir.
Okay.
Now we can hear.
Very good. Shudip, thank you very much for the kind introduction. So let me first of all start by saying salam, namaskar, good morning, and very hearty greetings from New York on behalf of myself and Dr. Mutahar Ahmed. Both of us, myself and Dr. Mutahar Ahmed, were really looking forward to joining all of you in person, really to be in this meeting, because I truly enjoyed every time I was in Dhaka, because nothing replaces the human interaction when you are face-to-face, in person, in a meeting. But this pandemic really has created a major havoc worldwide. And our meeting today, the in-person meeting at least, is a victim of that. But that being said, I think all of you have done a wonderful job in putting together this outstanding virtual course with the help of AUA and Bangladesh Association of Urological Surgeons. You know, one thing I truly miss is the annual meeting of the AUA, because during the annual meeting, we all were able to meet many of you who would come to the States. And this time, both myself and Dr. Ahmed were looking forward to greet all of you in Washington, DC. Unfortunately, this is the first time in 100 years the AUA meeting was canceled because of this pandemic. I want to really say a few words about some of the people we have lost, especially Professor Ghulam Kibriya. As many of you know, he's a fellow alumni of mine from Osmani Medical College. He was 1 year junior to me, but you know, I always enjoyed his company, and he was almost one of the most supportive person, at least in my life. And let me just tell a brief story in that time. In 1971, you know, after the Liberation War, at that time, both myself and Ghulam Kibriya, he was fourth year and I was fifth year. I finished passed in 1972. And I passed ECFMG the same year and was planning to come to the United States. But at that time, you needed a no objection certificate from the health ministry to get out of the country. And first of all, to get a passport at that time was almost an impossible task, especially if you did not have connections, and I had none. I found out, I was talking to Ghulam Kibriya one day, and he said, listen, my brother is the head of the passport office in Sylhet. I'm going to take you there. I had the passport within the next 1 week. And that's what brought me to the United States. So I've always been ever grateful to Ghulam Kibriya for the thing he had done. But over the years, we have kept in touch, and I really was eternally grateful to him for many things he had done for me. I want to say a few words about Dr. Abdul Mabud Chowdhury. As you know, he is from Sylhet, but graduated from Chittagong Medical College in there. He was really an outstanding urologist, and I only had met him, as a matter of fact, through BAUS during the annual meeting. And I always enjoyed talking to him and his family, and we feel terribly sorry for the loss. Again, Manjur Rashid Chowdhury, again, it was, I was in the 5th batch, and Manjur was in, I believe, was in the 13th batch in there. He's from Sylhet, and I know his family very well. And again, all these 3 losses, I think they will all be sorely missed in that. I want to congratulate really BAUS, the executive committee of BAUS, the scientific committee, for a wonderful job they have done despite all the challenges. We could have given up and just sat at home. But, I think the executive committee did a wonderful job in putting together all these webinars, the Zoom meeting between various international organizations. And I tell you, that is something which will be remembered by all the membership for a long time. We could have just given up, but we did not. So I want to congratulate you for this. I want to thank AUA, really. I think they have been, as you know, the most helpful, even under the challenging circumstances. I think Dr. Asim Shukla, Dr. Kolar, Dr. Priyanka Gupta, they deserve a great deal of thanks and gratitude for putting together the virtual conference, because it takes a lot of effort in putting together these conferences there, and they have done a great job, and we should all be grateful to them. I want to say a few words for the Bangladeshi faculty, who will be doing the moderation as well as talking. I think this is our next step. I think it'll be wonderful to listen to them, and I congratulate them for joining and doing what needs to be done for BAUS in there. Lastly, just a few words of advice. I will never dare to advise the senior members, but I definitely will feel free to advise the junior residents and many of the junior faculty who are in the audience. First of all, stay involved, engaged, and always keep learning. We know this pandemic is going to be over, inshallah. At some point, it might be 3 months, it might be 6 months, it may be a year, but it'll be over. But we don't want to fall behind in the world of urology. So keep doing what you do and keep learning, because that is the only way we can stay above. And I think join in all the meetings. I think one of the things the pandemic has done really is really see how many people has joined in this Zoom meeting. We didn't do this before. So I think this really gives us another opportunity really to learn. So I will always urge all of you to be involved. And obviously, we'll always be ready to do whatever we can. Certainly, we look forward to be in Dhaka next year, both myself as well as Dr. Ahmed. And in the meantime, whatever we can do from here, we'll be happy to do. I want to thank all of you, and please stay safe, and hope to see you soon. Thank you.
Thank you, Chaudhary sir, and all for the residents. I request you to keep in mind the quote from Chaudhary sir that we don't want to fall behind in the world of urology. And you all pray for good health of Chaudhary sir so that we can continue his support for so many days. Now I request Dr. Mutahar Ahmed.
No,
who-
Sudip.
Yeah.
Sudip, welcome speech, Ashim Shuklar welcome speech ta dao.
Oh, okay. If it is ready, so we can go to the recorded speech of Dr. Ashim Shukla. Shumon and Shubho, please. Okay.
এই সুমন শোনা যাচ্ছে না তো?
সেম শোনা যাচ্ছে না। দীপু ভাই আপনিও মিউট আছেন, আপনি আনমিউট করেন, আপনাকেও শোনা যাচ্ছে না।
সুমন?
Hello and salam to all of our friends at BAUS. Greetings. I hope this message finds you and your family safe and in good health during this very difficult time. On behalf of the American Urological Association, it's with great pleasure that I welcome you to the 2020 AUA BAUS Lessons in Urology program. While in every way we would have preferred to be there in person, I'm pleased that we are still able to continue this programming due to the strong bond that we have developed between the AUA and BAUS that has truly been a highlight of my time as an assistant secretary in the AUA. The exchange of knowledge is critical to the continued success of urology around the world, and now more than ever, especially in these difficult times. I want to thank the BAUS leadership and the program organizers for your unstinted efforts in pushing this relationship forward and making this program happen today. Before we begin the scientific program, I'd like to remind our AUA members that you have free access to the AUA Live program, which you might have missed held earlier this year, where you can find over 24 hours of online education from what would have been the AUA 2020 annual meeting. If you are not yet an AUA member, I encourage you to apply today to receive a 50% discount on your 2020 dues and free access to AUA Live. I really hope all of you will take us up on that, and the membership categories and prices are listed there. I want to thank our current AUA members for being part of the AUA family and look forward to hopefully welcoming even more new members today. And now, without further ado, let's begin the 2020 AUA BAUS Lessons in Urology program.
Thank you. And now, vote of thanks from Dr. Mutahar Ahmed, Director, Center for Bladder Cancer, and he is in New Jersey. I request Dr. Mutahar Ahmed to address, and we all know him, and he is providing his support for so many years to our association. Dr. Mutahar Ahmed.
Assalamu alaikum. Shubho Shakal and good morning to all. First, we'd like to thank BAUS for inviting us and all the local and foreign faculties, especially Dr. Shukla, Dr. Kohler, Dr. Gupta, and of course our beloved Dr. Chowdhury, for making this program possible and successful. And of course, we also have to thank Wi-Fi and the Zoom, because that has taken over, our live sessions. It's great pleasure to be with you all, although not in person, like many other past years. And of course, no live surgery workshop, which I enjoy the most. But spiritually, it is still very much uplifting. It has been very difficult time for all of us in Bangladesh and in abroad here in the US. We have lost colleagues and friends to COVID, and especially our beloved professor, Dr. Ghulam Kibriya. I remember him fondly because every time I came, he was always there talking to me, chatting to me. And Dr. Manzoor Rashid Chowdhury, and of course, Dr. Abdul Mabud Chowdhury Faisal in UK. They have contributed immensely to the field of urology in Bangladesh, and may Allah give them Jannah. However, inshallah, with time and effort, as Dr. Chowdhury said, we'll overcome this. And again, great to be able to join all of you, and many thanks to BAUS and the executive committee, President of BAUS, Dr. Habibur Rahman, and Secretary, Dr. Tawhid Hussein Dipu, for putting the program together even in this difficult time. And congratulations to all the participants. This is going to be a great session and a UA course, and you have great faculties, and I'm pretty sure you'll benefit immensely. And once again, congratulations for being a participant, especially to the resident. And so get ready and start your engine. And until next time, Assalamu alaikum. Allah Hafiz. Thank you.
Thank you, Dr. Mutahar. And we hope your continuous support to us. And we pray for your good health. And now addressed by Dr. Muhammad Habibur Rahman, who is the President of Bangladesh Association of Urological Surgeons. I request Dr. Muhammad Habibur Rahman for his talk.
Thank you, Dr. Dash Gupta, Scientific Secretary, Bangladesh Association of Urological Surgeons. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and good morning to everybody. Honorable Chief Guest of this course, Professor M. Chowdhury, our great teacher, dear members and all the participant residents. Hope all are fine in this COVID situation. On this occasion, we pray to Allah for our great teacher, late Professor Sam Ghulam Kibriya, Dr. Manzoor Rashid Chowdhury, and Dr. Abdul Mabud Chowdhury, and for Jannatul Firdaus. And also pray for early recovery, those who are suffering from COVID-19. This BAUS and AUA lecture course is a prestigious and a valuable course. In this year, we are obliged to run it virtually. I think during these 2 days, all of us will be enjoy the most of the events of the course happen, and everybody will be benefited from this course. We are very much grateful to the American Association of Urology for the generous support. This source of collaborative support will be strengthened in future. Today, we are very grateful the persons who make this relation, especially Professor M.A. Chowdhury, our past president, Professor M.A. Salam, and all others who make this collaborative support to us. And we are very grateful to the executives and the staffs of American Association of Urological Association. During this COVID situation, they tried their level best to continue this session. We are also thankful to the concerned people for making a successful lessons course. Also thankful to our regular scientific partner, UniMed, UniHealth Pharmaceuticals. We hope the lesson course will be a successful one. And finally, I am very thankful to the speakers and the moderators. Khuda Hafiz.
Thank you. We are listening to the talk from our president of association, Dr. Muhammad Habibur Rahman, and we all wish the success of virtual lessons in urology course 2020. Now, the session on overview of carcinoma prostate, and it is from Dr. M.S. Chaudhary, sir. Now I request Dr. M.S. Chaudhary to give his talk on overview of carcinoma prostate. I see that about 91 members are joining this session, and hope more members and more residents will join today's session. Dr. M.S. Chaudhary on overview of carcinoma prostate.
Thank you, Sudeep.
Thank you, sir.
Can you share the screen, right? You are sharing the screen, correct? So let me just, okay. Let me just. Okay, can you all see my screen?
Yes, sir.
No, sir. No, sir.
No, not yet, sir.
No, sir. We can see you, but not the presentation.
Okay, the presentation. So let me just see. Hold on 1 second, because I thought let me just make sure. Are you sharing the screen?
Stop sharing of other screen. Shubho, are you sharing the screen still now?
No, sir. No, sir.
Okay.
Sir, you should share your screen, sir.
Yeah,
Chaudhary,
okay.
Chaudhary, sir, you should share your screen.
That's what I did, but let me try again. Hold on. Okay. Okay. Can you see the screen now?
No, sir.
No.
Not yet, sir.
Any other should not share screen except Chaudhary sir. Otherwise it will not be seen.
Yeah.
Chiraj bhai, do you have the presentation?
দাদা শুনতে পাচ্ছি
Yes, sir. Now it is seen.
Yes. Now we can see.
You can see the screen?
Yeah, we can see prostate cancer and overview in 30 minutes.
Very good. Can you see the screen now?
Yes, sir. We can see.
Okay, very good. Okay, so we'll start. You know, so Dr. Dipu wanted me to give an overview on prostate cancer. So it is somewhat challenging to give an overview in what I wrote. I made the talk as an overview in 30 minutes. So that's the plan. We'll try to do the best. So what the topics we'd like to cover, number one, we'll start with prostate biopsy, because that is the fundamental in the diagnosis of prostate cancer. And we'll talk briefly about prostate cancer. So that will be followed by multiparametric MRI of the prostate. And we'll talk briefly about the fusion biopsy and the role. I know Bangladesh may not have the platform to do the fusion biopsy, but we can do pretty good fusion biopsy even without the platform. And that is the cognitive biopsy of the prostate. And I will talk about that one. The fundamentals of the treatment of prostate cancer is based on risk stratification. How do you stratify the prostate cancer in various risk category and decide about the treatment? And we'll talk briefly about the treatment of prostate cancer. And lastly, hopefully if there is time, we can talk about metastatic prostate cancer as well as castrate-resistant prostate cancer. If not, we'll finish because there are 51 slides up to treatment. So we might end there because I think you want to get your rest of the courses started on time. Okay, that's being said, what are the biopsy-related complications? Almost most patients will have some degree of perineal discomfort, usually for about 24 hours. Many of them have hematuria. Most of the hematuria is self-limiting, that will go away. Occasionally people will pass some blood clots, but usually of no consequence really. Some people have rectal bleeding, usually it is minor, unless the patient has significant hemorrhoid. So if the patient has significant hemorrhoid and you are doing a prostate biopsy, you want to be extra careful in those cases. And you always want to, we talk about the hematospermia. This one, most of this is self-limiting, and the severe rectal bleeding is quite uncommon. We talk about infectious complication, which is increasing over time. And the most common reason the infectious complication is increasing is because of multi-drug resistant E. coli infection in there. And the patients who have infectious complication, they will usually present with fever and chills. They require intravenous antibiotic and hospitalization. So we always want to make sure we tell the patient ahead of time that they have a risk of sepsis. And for that, it cannot be treated at home. Most of these has to be treated in the hospital with intravenous antibiotic. Many patients will complain of lower urinary tract symptoms. Usually this is mild in about 25% of the men who had the biopsy. And the risk of urinary retention is less than 2%. However, if you do transperineal biopsy, and one of our fellow Bangladeshis, Dr. Hashim Ahmed, has published extensively that in his series where he did transperineal mapping biopsy of the prostate, the risk of urinary retention was quite high. The mortality, though, is quite rare. But again, we have to be very mindful about treating sepsis at a very early stage. Otherwise, the patient can become very, very sick. So the antibiotic prophylaxis, the goal is to avoid sepsis and hospitalization. The standard patient, no history of prior urosepsis, immunosuppression, active UTI are considered the standard patient. High-risk patient will be patient with recent hospitalization, recent antibiotic, healthcare workers, people like us, physicians who have prostate biopsy. We are at a higher risk of getting urosepsis, mainly because we might carry multi-drug resistant organisms. And whenever you are trying to treat sepsis related to prostate biopsy, is always going to look at the local antibiogram, that what is the local organism causing the infection and which antibiotic works the best. So just what I'm telling may not be good enough. You may have to really find out in your own community what is the most common organisms and what antibiotic works the best. And we should try to minimize the use of the antibiotic, usually approximately 24 hours in the perioperative period may be a good enough coverage. Minimizing urosepsis. How do we minimize urosepsis? The conventional antibiotic we use is oral ciprofloxacin or Bactrim double strength. When you use the augmented approach, that you want to use more than that, we use conventional antibiotic plus parenteral antibiotic, usually gentamicin, ceftriaxone, or something like this. We use the pre-biopsy rectal swab. Now, I do not use it routinely, and many urologists in the States do not use it routinely, but there are significant number of urologists in the States who will do a rectal swab culture and see what organism there is and what the antibiotic it is sensitive to. I'm not sure it is very practical doing it in Bangladesh, but that's one of the things you can do. So you can direct the antibiotic to by the culture. If you really want to avoid sepsis, the only way to do it, transperineal biopsy probably has the minimal risk of getting urosepsis. However, transperineal biopsy is much more What is the current AUA guideline for antibiotic use? The antimicrobial of choice is fluoroquinolone or trimethoprim sulfamethoxazole, or we can use first, second, or third generation cephalosporin, either intramuscularly or intravenously.
So,
alternate antimicrobials will be aminoglycoside, either intramuscularly or intravenous, plus minus metronidazole, which is flagyl, or clindamycin. The rate of urosepsis after transrectal ultrasound-guided prostate biopsy is between 2 and 3%. And the baseline prostate biopsy-related hospitalization is about 1.26%. And 92% of the hospitalization is due to infection, and 79% of the cultures identifies a fluoroquinolone-resistant organism. This is a group from Michigan Urological Surgery Improvement Collaborative, and they have done an excellent job in putting together some quality improvement project. And one of the projects they looked at is use of antibiotic during prostate biopsy. And what they did is the culture-specific antibiotic. If they did a rectal swab culture, and if the culture organism is sensitive to Cipro, they will use the Cipro. If it is resistant to Cipro, then they will either go to Bactrim, which is trimethoprim sulfamethoxazole, or cephalosporin if it is sensitive to that. If the culture is resistant to Cipro, cephalosporin, or trimethoprim sulfamethoxazole, they will use either gentamicin intramuscular or intravenous, or clindamycin intramuscular. If they have no culture, if they did not do a rectal swab culture, they will go into the second line antibiotic. They can use the fluoroquinolone, which is Cipro-PO plus gentamicin, both. The alternate will be fluoroquinolone Cipro plus cefazolin or ceftriaxone zolphin based on the local antibiogram. If the patient is allergic to penicillin, fluoroquinolone, and cephalosporin, they will use gentamicin intramuscular or clindamycin intramuscular. There are some special circumstances, risk factors for infectious complication. The patients who are obese, patients who have diabetes mellitus, patients who had pre-op catheterization for urinary retention, let's say, the patient who traveled outside, especially we are talking about what were the other patients at risk? Patients with UTI and urosepsis. Cover the bacterial sensitive if recent, document negative urine culture prior to biopsy. If the patient has chronic catheter, indwelling Foley catheter, they are at a higher risk. They need extended prophylaxis, and you start the coverage drip before the biopsy and continue it for at least 4 days. So who are the patients more at risk, more than the standard risk? Obese patient, patients with diabetes mellitus, the patients who had a catheter in the bladder, patients who had chronic catheterization, let's say neurogenic bladder, they're at a higher risk. Keep that in mind. Transrectal biopsy. So when you're doing the transrectal biopsy, obviously you insert the probe, and usually you try to push away from the prostate. So you have the gel between the probe and the prostate in there. Either you can have a side fire or an end fire probe, whatever you're used to. Giving adequate local anesthesia around the prostate, I think, will be critically important in there so that the patients are comfortable. They're not terribly uncomfortable. Let me just move this. So whenever we are doing the prostate ultrasound, we should measure, I am sure all of you do it, measure the height of the prostate, the width and the length of the prostate. And if you get all three measurements, you multiply that by 0.52, which is pi over r, you get the volume of the prostate. If you know the PSA, which I'm sure you know before you are doing the biopsy, because most of the biopsies you are doing is because of the elevated PSA. If you divide the PSA by the volume of the prostate, you get what is called the PSA density. And the PSA density sometimes can be helpful in the sense that if the PSA density is over 0.15, that means it is more likely to be benign. If the PSA density is under 0.15, it is more likely to be malignant. But again, this is not an absolute, so do not. Yeah. So when you're doing an ultrasound of the prostate, how many biopsies should we do? The minimum standard is that we do a 12-core biopsy of the prostate. We do 2 biopsies from the base of the prostate. We are talking about doing 6 biopsies from the right side and the 6 biopsies from the left side of the prostate. On each side, we are doing 2 biopsies at the base, the mid gland and the apex, both lateral and medial, and you do the same thing on both sides. So you end up with 12 different cores of tissue for the biopsy. At least in the States, many people will put each of these specimens leveling appropriately in a separate core, but at the least you should separate out the left side and the right side and at least use 2 different cups to send out the biopsies so you know where the biopsies came back positive. My own preference is to put each of those 12 core in 12 separate containers, so leveled appropriately so you know exactly where the biopsies are coming from. I think we already talked about this. We've talked about this. No, unfortunately, I think I have the wrong slides, a deck of slides, but be that as it may, I think it's too late to change, but I'll go. The pathology is very important, how we fix the pathology. So when you get the pathology, there are 3 things you can go. There is a positive biopsy of the prostate. We'll talk about it later on. But you might get what is called high-grade prostatic intraepithelial neoplasia. These are precancerous, similar to carcinoma in situ, but not really positive for carcinoma. What do we do when you find high-grade prostatic intraepithelial neoplasia? Usually, if you find it only 1 of 12 biopsies, we don't do anything. You can follow that with a PSA digital rectal exam like you will do. But on the other hand, if you find high-grade prostatic intraepithelial neoplasia in multiple biopsies, in more than in 2 sites, then they are at least a 20% risk of having a positive biopsy at a later time. And those patients should be followed closely and have a repeat biopsy done, usually in about 6 months' time. So if you have monofocal PIN, we don't have to do anything. If it's a multifocal PIN, we really need to follow this patient more closely because they are at least a 20% risk of prostate cancer and they should be rebiopsied in about 6 months. What about atypical small acinar proliferation or ASAP? What do you do with that one? Their risk of prostate cancer is significantly higher at 40%. And this patient should have a routine biopsy in 6 months' time, usually in 6 months' time. So there should have a, where the ASAP or atypical small acinar proliferation came, let's say it came from the left lateral base. then I will focus the repeat biopsy to that area. And that's why it is important to put the specimens in separate container so you know where it came from. The second, if there is PIN with atypia in the biopsy specimen, they are similar to a typical small cell proliferation, and they need to be biopsied, a repeat biopsy focused to that area. I think this slide is important for the residents to take a look. So what you're looking at here, that right now there are only 3 grades, grade 3, grade 4, and grade 5. There is no grade 1 and 2. So if the glands are not even in size, different size and shape, they have cribriform pattern, that will be 3. If the glands are barely making up glands, there are a lot of sheets of cells, that will be 4. And grade 5 will be that you can only see sheets of cells that some are trying to form glands, but mostly very undifferentiated cells. That will be grade 5. So Gleason grade 3, 4, and 5. And if you see in a specimen, mostly 3, and then some 4, that will be 3 plus 4. If everything is 3, it will be 3 plus 3 equaling 6. So 3 plus 3, 6, Gleason score is called grade group 1. 3 plus 4 equaling 7 is called grade group 2. If it is mostly 4 and some 3, that will be called 4 plus 3 equaling 7, grade group 3. If everything is 4, that will be called 4 plus 4 equaling 8, grade group 4. If some 4, mostly 4, some 5, that will be 9, and that will be grade group 5. If everything is 5, it will be 5 plus 5 equaling 10, grade group 5. So nowadays, instead of telling Gleason score, a lot of the pathologists will call grade group. So keep in mind, the lowest grade group is 2. This 2 is the second, 3, 4, 5, and 5. So 1, 2, 3, 4, and 5, that's the grade group. The higher it goes in the grade group, the more aggressive the cancer is supposed to be. And this is a biopsy report, which many of the pathologists will provide at the time they report on this one. This is a busy slide, so it'll be hard to go over that. So I think we talked about it, the preparation for the prostate biopsy, the technique of the biopsy, giving local anesthesia, usually use 1% xylocaine in the periprostatic area. We talked about the technique and the template. What is the minimum number of biopsy core you need to take? Is 12. So what is the problem of prostate biopsy? So I think this slide shows the problem of prostate biopsy. So what happens is over-detection, meaning there are small areas of cancer, and when we put the needle in, accidentally we hit those areas. And these small areas are very unlikely to be clinically significant or cause any kind of damage or death or real problem to the patient. So we end up with a lot of over-detection. About 20% of the patients we biopsy for elevated PSA, we end up diagnosing these very small areas of cancer, which are clinically irrelevant, then end up treating them and giving them the potential side effects of treatment. That's one problem, over-detection. The second problem of random prostate biopsy is incorrect risk stratification. So let's say this is an area of cancer, but when I do the biopsy, I only hit the edges of this tumor. And we come up with Gleason score 6 or grade group 1. But in the middle of this one could be a grade group 8 disease. So when I'm doing the biopsy, I'm missing the real problem areas and hitting the edges, which may not give us the true characteristic of that tumor. And lastly, misdiagnosis, that there may be areas of cancer, which this is an area of cancer, which I can miss completely and biopsy something else and we may not find any cancer. So when you're doing random sampling of 12, One, we can over-detect by accidentally hitting the small areas. We can hit the edges and get a wrong risk stratification, wrong grade group, or we can miss the tumor altogether. So that's the limitation of the current systemic, not systemic, systematic, that's the type of systematic prostate biopsy. So what is the role of the MRI in this area? Okay, so the role of MRI really, why use MRI to good biopsy? That we can direct the biopsy at regions suspicious of tumor. We can avoid that, let's say you do an MRI for elevated PSA of 5 nanogram per ml. The digital rectal exam is not suspicious. You do an MRI and the MRI shows it's a normal MRI of the prostate. There is no suspicious lesion in the prostate. Can we avoid biopsy that patient? It is possible, but at this point of time, that is not recommended. If you think the patient needs a biopsy because of elevated PSA, even if the MRI is negative, we go ahead and do the biopsy. But I think there will be a time, hopefully there will be enough data within the next few years that a lot of people with an elevated PSA and a normal MRI, maybe we can skip the biopsy. Avoid biopsy in patient with a negative MRI altogether. Can we avoid it? You know, I think that's a possibility, but right now, patients should have a biopsy if there's an indication. What is the goal of the prostate MRI? The main goal of the prostate MRI, we are trying to find out detection of clinically significant prostate cancer. Remember those cancers we missed at the time of biopsy, maybe we can see them in the MRI and we can biopsy those areas and make a diagnosis of clinically significant cancer. And what is the definition of clinically significant cancer? Cancer 3+4 or above will be considered clinically significant. We may be able to reduce unnecessary biopsies. If you have elevated PSA, a normal MRI, maybe some of these patients may not need the biopsy. We can stage prostate cancer. That MRI is very good if you want to see if the tumor going beyond the capsule of the prostate, is the tumor involving the seminal vesicles, and those things we can stage the disease. We can tell it is going into the seminal vesicle, it is T3. We can tell it is going into the bladder, T4, or we can tell that it is within the capsule. There is no seminal vesicle invasion, no extracapsular extension. So those things, the MRI can be of great help. Surveillance with PSA or follow-up MRI. If we did treatment with radiation therapy and the PSA is going up, we can do an MRI to see if there is recurrence in the prostate. Or you can use the MRI for image-guided biopsy, which we'll talk about. What MRI ultrasound-guided fusion biopsy, how important that is. So what are the different types of fusion biopsy? So the fusion biopsy means that we did an MRI and we found a suspicious lesion in the prostate. And suspicious lesion will be graded as pyrite 3, 4, or 5. Now, how do we biopsy that area? Instead of doing just a systematic biopsy, we'll still do the 12-core systematic biopsy. But for the area which is suspicious, we can identify that area during the ultrasound by 3 different ways. So the first way is the cognitive. Cognitive meaning that you did the MRI, you reviewed the MRI with the radiologist very carefully, you read the report very carefully, you looked at the MRI yourself, and you know exactly where that suspicious lesion is. That suspicious lesion, let's say, maybe in the right mid-gland peripheral zone, or it may be in the left anterior transition zone, or it may be near the apex of the prostate. You know that from reviewing the MRI, by talking to the radiologist who did the MRI. And then when you do the biopsy, you focus on that area by knowing where it is, even though you do not have a platform such as UniMed or Qualis or anything else. But just by reading the MRI carefully, you can do a cognitive fusion biopsy. And you do not need the platform, which might cost $500,000. we can do probably as good a fusion biopsy by reviewing the MRI and doing a cognitive biopsy. So I encourage all of you that many patients with elevated PSA, if you can get an MRI done, and if you see there's a lesion in the MRI, you review the MRI with the radiologist, review the MRI yourself, and then when you are doing the biopsy, pay special attention to that area, biopsy that area, put in a separate container as a target lesion, and send it for histopathology. You don't need the platform. You can do that without that. The second way is by doing the MRI transfusion biopsy using a platform. In this one, I really think we use a platform right now. I think I could do as good a cognitive biopsy for most good size lesion. It will be hard to do for small lesion a cognitive biopsy. Other than this, most 1 centimeter higher lesion, even 7 millimeter lesion, you can do a good cognitive fusion biopsy without needing any of the platform. MRI in-bore biopsy is done by radiologist while the patient is in the MRI machine, and they put a needle under the MRI guidance for their biopsy. Urologists are not involved, and very few radiologists are now doing it. So it's nowadays it is mostly cognitive or platform fusion biopsy. So when you do a cognitive biopsy, this is what I'm talking about. So let's say this is a 2D weighted image. This is the peripheral zone of the prostate, and you see a lesion right here. That's hypoechoic area. That's the suspicious area. Now you know it is on the right side of the prostate. It is in the middle of the prostate. It is in the peripheral zone. So when you're doing the biopsy, focus in this area. So you can take multiple biopsies from this area, send it for a separate container for pathology. In this patient, the lesion, see this, the peripheral zone is normal. Peripheral zone is normal. The lesion is right in the anterior transition zone. So if you know this, if you did not know, you will do biopsy of this, and you will miss this area. Once you know this, you're going to advance the needle further into the transitional zone before firing the needle so you can catch that area. That's the significance of getting the MRI done ahead of time. You look in this area, this is a sagittal section of the prostate. There is a lesion right at the apex of the prostate. There is a lesion right in here, and you focus in those areas, and you can get a very good biopsy without needing any platform. That's the importance of doing the cognitive biopsy. And I know in Bangladesh, Dhaka, there are outstanding, excellent MRIs being done right now, and there is no reason that the urologist should not be doing the cognitive fusion biopsy without needing any platform. I'll move this one. So what is the summary? The ultrasound helps guide biopsy location. MRI makes it possible to identify the suspicious area and find out the tumor. And when you use the combination of MRI and ultrasound, it improves detection and increases the sensitivity. Risk-stratified approach to prostate cancer. I'll talk a little bit about that one. So we have talked about this in the past. But this is so important. I want to go over this again. What are the currently available tools? What do we have right now when we risk stratify prostate cancer? Not all prostate cancer are the same. Some prostate cancer will never kill a patient. Other prostate cancer are little within a short time. And we need to make sure in which category or which bucket the patient falls. So we look at the PSA level, digital rectal exam of the prostate, clinical stage of prostate cancer, and prostate biopsy grade. And we'll talk a little bit about it. We don't have a lot of time, but we'll talk. Tools under investigation is multiparametric MRI of the prostate, which we talked about. I don't have to tell you much about the PSA. PSA is a glycoprotein, which is produced by the prostatic epithelial cell. Most of these are excreted in the urine and the semen. A small amount of the PSA leaks into the bloodstream, and that's what we detect as a PSA biomarker. Okay. So this is what we did, a while ago, and just to show you that when the PSA number is 0.0 to 4, which a lot of people consider normal, even in those cases, there was a 13% incidence of prostate cancer. The PSA goes up between 4 and 10, the incidence of prostate cancer increases to 33%. If the PSA goes above 10, the incidence goes up to 56%. That means the higher the PSA, the higher is the chance somebody having prostate cancer. So use PSA as a risk stratifier. We look at the digital rectal exam. So the vast majority of the patients who have prostate cancer nowadays have a non-palpable cancer. It's called T1. When there's a small palpable nodule in the prostate on one side or the other is T2. T2 could be T2A. It only involves one side of the prostate. T2B might involve both sides of the prostate. T3 is the hardness is extending beyond the prostate, outside the capsule, into the seminal vesicle. And T4, if it's involving the adjacent organ. So we have the PSA, we have the digital rectal exam now. And the most important thing we have is the prostate biopsy grade. So we did the prostate biopsy and we have the grade. So let's look at this one. So this is a biopsy report. And if you look at the biopsy report, that number of them are positive. Some of them are 7, 2 of them are 7. And the rest of them are Gleason 6. And the percentage tumor involvement from 20% to 30%. There are some 5 and 10%, but mostly between 20 and 30%. So you have this information in this patient. You have the information that what is the level of the PSA? What is the finding of the digital rectal exam? And you have the finding, how many biopsies are positive? What is the Gleason score? And what percentage are positive? If you have this information, you can risk stratify that patient. And the AUA, the risk stratifies at a very low risk, and we'll define what is very low risk. It defines as low risk, intermediate risk, and high risk. The only difference in NCCN, they also have a very high risk category. So whenever you have a prostate cancer, the first thing you're going to think, which risk category does it fall? Is it a very low risk? Is it low risk? Is it intermediate risk? Or is it high risk? What are the information we need? We need the information on the PSA, digital rectal exam of the prostate, and the Gleason grade, and how many biopsies positive, what percentage are positive. So let's look at this one. We are kind of running short of time, so I'll try to finish up quickly. Very low risk prostate cancer is, the PSA has to be under 10. The digital rectal exam has to have no palpable disease in the prostate, that means T1C. The Gleason score has to be 6, nothing else. The 6 is grade group 1. And less than 3 code has to be positive. And no core more than 50% positive. So if you have all of those things in a patient, that's a very low risk prostate cancer. And you call it very low risk because the chance of his death from prostate cancer in that patient is extremely low. The chance of metastasis is low. Chance of death is low. So that's why it is very low risk. What is a low risk prostate cancer? Little different. When the PSA is again under 10, the clinical stage could be T1C non-palpable cancer, or it could be a small palpable nodule, that means T2A, and the Gleason score still has to be 6. If you have those 3 things, that means if there's a palpable disease, Gleason score is 6, PSA less than 10, that will be considered low risk prostate cancer. Go to the intermediate risk. Now the PSA is a little further up, between 10 and 20. So if the PSA is above 10, but under 20, or it's T2B, that means involving both lobes, or the Gleason score is either 3 plus 4 equaling 7, or 4 plus 3 equaling 7, that means grade group 2 or 3, if any of those 3 things are there, that will be an intermediate risk. That means their risk of metastasis and death from prostate cancer is higher than the other groups. So they need to be treated. The high-risk prostate cancer, the PSA is over 20. Digital rectal exam is T3, that means beyond the prostate. Or Gleason score is between 8 and 10. If any of those three things are there, that's a high-risk prostate cancer. That means they are aggressive disease. So always keep in mind, what's a high-risk prostate cancer? Any one of those three, it's not N. PSA over 20 or T3 or Gleason score is 8 to 10. Any of those three, it's a high-risk prostate cancer. And they should be treated aggressively. The only category which NCCN have, if it's a clinical stage T4 and primary Gleason pattern is 5, over 4 core is positive, that is considered very high risk group. Obviously, they're even more aggressive. Okay, we'll try to finish this up. Low risk prostate cancer, what is the treatment option? Watchful waiting is a good treatment option for many of these patients, especially if they are older. If their life expectancy is less than 5 years, or they have multiple comorbidities, it is very unlikely these people will die from prostate cancer. They will die from other comorbidities, and you do not need to even surveil them. You just follow them along. Active surveillance means that you're going to do a PSA, digital rectal exam, and every 6 months, and repeat the biopsy in 1 year. And if the grade changes or the volume of cancer changes, then you might switch them to active treatment. And active treatment could be radical prostatectomy or radiation therapy. Intermediate risk prostate cancer. So remember, these are patients where the PSA is between 10 and 20. The clinical stage is T2B, and the Gleason grade is 3+4 or 4+3. Most of these patients should be treated, especially if they are young and healthy. And you can treat them either by radical prostatectomy or radiation therapy, and hormonal therapy will be optional in many of those cases. And many of these patients will do extremely well with radical prostatectomy or radiation therapy. Younger, healthier patients, especially with voiding symptoms, are probably better with radical prostatectomy than with radiation therapy. A small number of patients where it's a favorable intermediate risk, the Gleason grade is 3+4, not 4+3, may be candidate for active surveillance. Watchful waiting will be good only in patients who are older with comorbidities and life expectancy is less than 5 years. High-risk prostate cancer always need multimodal treatment. They should be treated. Single mode treatment such as radical prostatectomy or just radiation therapy is not going to do the trick. If you do radical prostatectomy, many of these patients will need adjuvant radiation therapy with it. If you gave external radiation therapy, you must give hormonal therapy in those patients because they have a much better success rate. So high-risk prostate cancer, multimodal treatment. Watchful waiting only in those patients with short life expectancy and multiple comorbidities in there. So risk stratification is essential in the appropriate management of prostate cancer. Most low-risk prostate cancer can be placed on active surveillance. Most intermediate risk prostate cancer can be treated with single modality treatment, such as radical prostatectomy or radiation therapy. High-risk prostate cancer requires multimodal treatment. You need to treat them with multiple. If you did radical prostatectomy, most likely they did radiation therapy. If you giving radiation therapy, they should have hormonal therapy for at least 1 year, preferably up to 3 years. This one. I think I'll finish in here because I think I took more time than I should have taken. I think we'll finish in there. Shudip, I think I'll finish in there and you can start the next.
Sir, there was some question in the chat box.
Okay, please.
One question is, one wants to know explanation about tertiary Gleason's grade.
Tertiary Gleason's, yeah, right.
Yes,
right.
Sir.
Sure. So what had happened is it was used at one time by the ICU of International Society of Urological Pathology. It's no longer used very widely. tertiary Gleason score means, let's say you have a code of prostate biopsy. The most common grade is 3. Second most common is 4, but there's a small percentage of that is 5. So that's the tertiary Gleason grade. Tertiary Gleason grade. It
Yes, sir.
does not
Another
seem
question.
to be very effective in deciding what. Yeah, go ahead.
Sir,
Yes, go ahead.
another question from a resident. What is the role of PSMA and PET-CT in case of
PSMA and
prostate
PET-CT.
cancer?
Yeah. So the great question really in this one. So let's say you have a low risk prostate cancer, very low risk prostate cancer, even intermediate risk prostate cancer. I don't think there is much of a role for PET scan, PSMA scan, or Axumin called flucyclovine PET scan. But let's say you have a high risk patient. His PSA is over 20. The digital rectal exam is, let's say it's not suspicious, but the Gleason grade is 8, 9, or 10. You did a bone scan, you should have metastatic workup in those patients because their risk of metastasis is about 30%. So you did a bone scan, it is negative. You did a CAT scan, it does not show any lymph node, but there is still a suspicion that this patient may have metastatic disease. The way to find that is to do those PET scan, either an 18 flucyclovine PET scan, which is called the Axumin PET scan, and that is good for both lymph node as well as bone. But the better one, probably more specific and more sensitive, will be 68 gallium PSMA scan. So PET scan will be useful for high-risk prostate cancer. That's one. The second, let's say the patient was treated with radiation therapy for prostate cancer, now has rising PSA. You did a bone scan, which is negative. You did a CAT scan, which is negative, but the PSA is still rising. So you don't know where the disease is. The PSMA or Axumin PET scan can be very helpful in finding disease which is not visible in bone scan or CAT scan. Sudeep, any other question? Sudeep? Did we?
Sir,
Yes,
proceed,
sir.
sir.
Yes, sir.
Chaudhary, sir, proceed.
Sir,
Yeah.
there is a question from a resident. Should we use flutamide, bicalutamide in 2020? This is the question from the resident.
Okay,
In case of metastatic carcinoma of the prostate.
In case of metastatic carcinoma of the prostate. Okay, so that's a great question. So the short answer is there is some use for that one, and I'll tell you when we use it. So let's say there's a patient with metastatic prostate cancer, and there are some spinal mets, and you are going to start an LHRH injection on that patient. There is going to be a flare at the beginning, and there is always a risk of cord compression. There is a risk of urethral obstruction. There may be a risk of urinary retention. In those patients, if you are trying to prevent the flare phenomenon, then a short-term use of bicalutamide 50 milligram once a day, or even a larger dose, will be justified. Okay, will be justified. Now, if the patient has metastatic prostate cancer, the total androgen blockade, which is basically LHRH injection, let's say if you are giving, it's going to block 80%, over 90%, which are coming from the testicle. But a small percent which is coming from the adrenal gland will not be blocked. So some people will use it for metastatic prostate cancer for total androgen blockade. The thing though is nowadays you have much better drug than bicalutamide, right? Like enzalutamide, Xtandi, is a much more powerful androgen receptor blocker than bicalutamide. So nowadays the use are much more limited than it used to be in there, but there is still some use to that.
Thank you, sir. There is another question. What PSA level is significant after radical prostatectomy?
After radical prostatectomy, great question. Okay. So after radical prostatectomy, the PSA should become undetectable. That means it should be less than 0.1 nanogram per ml, right? So it should be undetectable, really. So if the PSA level is lowly well detected, let's say it's 0.2, I will be concerned, but I think it'll be more concerning if the PSA is increasing rapidly. If the doubling time of the PSA is less than 1 year, that's very concerning after radical prostatectomy, right? So first of all, after radical prostatectomy, the PSA should be 0, less than 0.1 nanogram. Any detectable PSA, especially if it's rising, will be concerning. I think that's the case. So let's say you did a radical prostatectomy, the PSA is slowly rising, you did a bone scan, you did a CAT scan, is negative. That may be a good case for a PSMS scan or Exumin PET scan, right, to detect metastatic disease.
Sir, continue your lecture, sir.
Okay, so what I have done, because I think my slides are finished in there, I can always do it later on. If I have questions, I think it'll be better I answer the questions.
Sir, there is no more questions, sir, in my chat box, I see. So,
Okay.
sir, okay.
Okay, so, when is the next talk starting?
Sir, now the next session of pediatric urology will be moderated by Istiaq Ahmed Shamim.
Okay,
This
is it time?
yes, sir, recorded lectures.
Okay, so
from Dr. Ashim Shukla.
Okay, so I think you can start with that lecture, and I can always come back.
Okay, sir. Okay, sir. Dr. Dippu, can we move to the next session? Which will be moderated by Dr. Istiaq Ahmed Shamim. Shubho, Shumon.
Sir, yes, sir.
Yes, the session of pediatric urology can be started now. Dr. Istiaq Ahmed Shamim, yes, sir. Dr. Istiaq Ahmed Shamim is the moderator of the session.
Oh,
this is
thank
a
you, Dr.
recorded lecture. Yes, sir. This is a recorded lecture. Thank you, sir. Okay.
Yeah. Thank you, Dr. Shudip. Now we have a very important session. Before that, I'm very thankful to Professor Habibur Rahman, President of BAUS, and Dr. Tawhid Muhammad Saiful Hussain, Secretary General of BAUS, for giving me this opportunity to moderate this important session, which will be presented by Dr. Ashim Shukla. So Dr. Ashim Shukla will be giving talks on 4 different topics like antenatal hydronephrosis, UTI and VUR, posterolateral valve, and undescended testes. We are going to run all the 4 videos one after another. And at the end of the presentation, I will try to pick up some few key points to share with the audience. And in the meantime, the residents can put their questions on the chat box. And if time permits, we'll take few of them and discuss the answers. So before that, I'd like to talk a little bit about Dr. Ashim Shukla. Can I have this slide, please, Mr. Shubho? Shubho, can you share the screen? Yes, sir. I'm sharing. Actually, when I have to talk about Professor Ashim Shukla, he has a very cherished career. So it's very difficult to complete in a few words. But I have picked up some important achievements of his, and will put forward to the audience. Is Dr. Ashim Ravindra Shukla, MD. He is presently the Associate Professor of Urology, University of Pennsylvania, Perman School of Medicine, Philadelphia. He's a recipient of many awards and honors from different societies like AUA, AAFP, Pfizer, and was elected to Best Doctors in America. also awarded Best Reviewer for the Journal of Urology. And he has held many editorial positions as reviewers in BJU, JPU, and Journal of Endourology. So as from the profile, we can see that he's a very distinguished pediatric urologist, and he's going to speak on 4 topics now. So I'll request Mr. Shubo to start the video presentation, which is a pre-recorded one.
Okay, next I'd like to talk about prenatal hydronephrosis and offer a step-by-step guide. This is a talk I've given a few times in the subcontinent, but I think it's very important for the residents to learn, and for those who have seen this talk, I think it's another opportunity to have this and think about some of the concepts and how we are thinking more and more about prenatal hydronephrosis in the United States. So, in general, we know that fetal urological anomalies is a common finding. If you look at all children, all prenatal ultrasounds, depending on the study, up to 5% of these can have prenatal hydronephrosis. And since such a large number of prenatal scans can find hydronephrosis, it becomes incumbent upon us as pediatric urologists to know which ones are physiologically not significant, which ones are significant, which ones show obstruction, which ones indicate reflux.
Please remain muted, all other viewers.
We know that we do not want to be offering treatment. We want to avoid unnecessary tests, antibiotics, and surgery. On the other hand, if treatment is necessary, we want to know what surgery. Is it going to protect renal function? Will it permit growth and development? And will it avoid complications? So physiologically, if you look at kidneys, they become first visible at 12 weeks of gestational age. Oftentimes, very early on, the kidney can become visible. At that time, hydronephrosis is quite uncommon, but mild hydronephrosis can be seen by 24 weeks and up to 8% of all pregnancies. So with a good antenatal screen, complete screen, you might see mild hydronephrosis in 8% of patients at 24 weeks. The bladder becomes visible first at around 14 weeks, and by 30 weeks, there will be a 10 cc bladder, which can increase to a 50 milliliter bladder at term. The genitalia, as you know, can be determined by about 24 weeks, just for comparison. Now, when we look at a prenatal scan, yes, we're interested in what the kidney looks like, we're interested in what the bladder looks like, but we're most interested in the amniotic fluid index. The early transudate that we see is amniotic fluid is just amnion. Later is fetal urine plus lung fluid and the swallowing of the baby of that fluid that leads to urine production. By the 5th week of gestation, urine is possible, though this is a very poorly concentrated liquid. By the 20th week, that volume can be 5 milliliters per hour. By 40 weeks, it can be 50 milliliters per hour. The amniotic fluid, normal amniotic fluid, is about 380 milliliters at 20 weeks, and by term, about 600 milliliters. If you have more than 1.5 liters, we call that polyhydramnios. And if it's less than 500 milliliters, we call that oligohydramnios. Now, polyhydramnios, as I mentioned, it can be seen in 1.5. It's when you have more than 1.5 liters, and it's diagnosed when the uterus is too large. It can be when the uterus is too large. It can be indicative of esophageal obstruction, multicystic dysplastic kidney, mesoblastic nephroma. We're not sure why some of these conditions cause polyhydramnios, but there is a correlation with that. Now, oligohydramnios is much more substantial and something that is significant. When you have less than 500 ml of amniotic fluid, that's a rare finding, 0.5% of all pregnancies, but it can indicate amnion nodosum, an amniotic fluid leak, or of course, renal anomalies, dysplasia, obstruction, etc. The consequences of oligohydramnios, of course, is pulmonary hypoplasia, which can lead to neonatal demise. Potter syndrome, if you have renal agenesis, bilateral renal agenesis, these children will have very classic findings, probably due to uterine compression, and these are not viable births. So, hydronephrosis and pulmonary hypoplasia, this correlation, this connection is very important, because oligohydramnios, due to bilateral hydronephrosis, can cause pulmonary hypoplasia. Now, why is that the case? I used to believe when I was a resident, much as many of you are, that it must be that these kidneys are very dilated, they're pressing on the diaphragm, not allowing the lungs to expand, and that's why these lungs have pulmonary hypoplasia. But in reality, the reduced amniotic fluid pressure, when you have less amniotic fluid, it allows the lung fluid to drain out of the lungs. And that causes a negative pressure against the amniotic pressure, which increases the alveolar to the amniotic pressure gradient. And so the lungs just simply cannot expand. The alveoli cannot expand because when you have oligohydramnios, you have a pressure gradient being created between the lung fluid and the amnion, and that causes the problem that we call pulmonary hypoplasia. We also know that other factors are at play, decreased expressions of extracellular matrix, TGF-beta, PDGF. So it is much more sophisticated than just the fact that large kidneys are pressing on the diaphragm. By 30 weeks gestational age, oligohydramnios becomes an important finding. If you have oligohydramnios prior to 30 weeks, you will often have severe pulmonary hypoplasia. If the oligohydramnios develops after 30 weeks, pulmonary hypoplasia is less common. So remember that 30-week is an important pivot point in the health of a pregnancy. Now, fetal compression is an important finding because we can consider fetal decompression. If you have severe bilateral hydronephrosis with a keyhole sign consistent with valves, vesicoamniotic shunting can work well in a favorable patient. So if it's found by before 30 weeks, when we know that pulmonary hypoplasia risk is high, you might consider vesicoamniotic shunting. If you find it afterwards, it's already too late. It's already, luckily the lungs will probably be safe, so you don't need to be doing shunting and putting the infants at risk. So if you are going to do fetal compression, these are the common findings that you should have, the favorable indicators, that it should be valve bladder, that the karyotype should be confirmed. The female is not going to have a valve bladder. You need to have a normal systemic anomaly, no other systemic anomalies, a male fetus, singleton, the oligohydramnios before 25 to 30 weeks, and all of these other findings that you can read in the chapter as well. If fetal decompression is going to be considered, there has only been one trial to really give us an indication whether it actually helps. Because when you do this, what we see in the picture on the right, you are putting the pregnancy at risk. When you incise a fetal bladder with a trocar like that, you can cause a premature contraction, cause a premature delivery, you can damage the baby, you can cause an injury. And so it really needs to be done under very careful circumstances. When one study was attempted, the Pluto trial in 2013, it was hurt by poor recruitment. But when they did look at a very small cohort, they found that of those children that survived to 2 years of age, renal function was unchanged by doing the vesicoamniotic shunting. So whether you did it or not, you did not improve renal function. But it did reduce the incidence of pulmonary hypoplasia and increase the chance of a live birth, a viable fetus in viable lungs. So the point of this trial would be that if you do a vesical amniotic shunt, do it under very controlled circumstances. It can reduce the risk for pulmonary hypoplasia slightly, but it can, in the near term, 28 days, you can have better survival by doing a shunt, but there is no proof that long-term renal function is improved. So if we think of antenatal hydronephrosis, the basic problem is, of course, that you can have a significant uropathy. But the basic problem to remember is that dilation is not equal to obstruction. Just because you're dilated doesn't mean you're obstructed, and just because you're dilated doesn't mean you have renal damage. And there are very few prospective or none correlating risk of pathology with the degree of antenatal hydronephrosis. So what is normal? At 16 to 27 weeks, an anterior-posterior diameter of less than 4 millimeters would be normal. At 28 weeks, less than 7 millimeters. And at birth, less than 10 millimeters you would consider normal. But that's not good enough to just say anterior-posterior diameter, because we know that calyceal dilation is important. Is there central dilation? Is there peripheral dilation? Is there parenchymal thickness? What's the parenchymal appearance? Are the ureters dilated? Is the bladder dilated, thick-walled? What's exactly going on? Is there oligohydramnios present? All of this, how do we put all of this together in one scale? Because otherwise you're really going through a checklist, you know, who has this, who has that, who has this. So if we again look at, and so as we get to that, let's just again review a prenatal image. This is a normal prenatal ultrasound. And you can see that the dilation there is only 4 millimeters on the anterior posterior diameter of 4 millimeters. And in that case, that would be normal. And this is a normal looking kidney, minimal pelvic splitting. You can see good corticomedullary differentiation. The cortex is not echogenic. This would be a normal kidney. These things are not dilated calyces, but rather hypoechoic medullary pyramids, which is normal in an infant ultrasound. Postnatally, same thing, less than 10 millimeters, you would consider this normal. You can see very healthy, normal fetal lobulations in the kidney. You can see the medullary pyramids that are really lighting up and mild dilation. So, you've heard me use the word stratification of risk in my other talks. How do we stratify this? What is the risk we're worried about? Well, we're worried about UTI. Who needs surgery? Is there going to be a risk of renal deterioration? Is there going to be stone formation? These are who needs more imaging, who needs a DMSA, who needs a MAC3 renal scan or DTPA, who needs an MCU. And so based on that, there was a recommendation strategy that has been come up, that has been agreed on by multiple pediatric urologists, pediatric radiologists, and that is the UTD system, urinary tract dilation. And this is slowly supplanting or replacing the SFU system, or the Society of Fetal Urology system. So prenatal presentation, 16 to 27 weeks, a AP renal diameter 4 to 7 millimeters, or at greater than 28 weeks, 7 to 10 millimeters, central calyceal dilation alone, and those numbers, normal. Low risk, UTD A1, so antenatal hydronephrosis level 1. And this would be a normal, some of the pictures that we saw before. You have some central calyceal dilation, but the dilation is 4 to 7 millimeters before 27 weeks and 7 to 10 millimeters after 28 weeks. We would consider that low risk, and that would be just monitored. Now, higher risk is when you have the dilation at 27 weeks more than 7 millimeters, or at 28 weeks more than 10 millimeters. And you have peripheral calyceal dilation, you have a parenchymal thickness abnormality, you have ureteral dilation, bladder thickness. These children are at more increased risk. And here's central calyceal dilation with those parameters, as you can see there, peripheral and central calyceal dilation, less than 7 millimeters or 10 millimeters. And you can see also that they're more echogenic. Remember those medullary pyramids? They seem to be gone here. you see a color that's echogenic. These are all indications that something more serious is afoot, and this is why we would put them UTD-A 2 to 3, increased risk. They don't break down 2 and 3 because that gets more complicated. But this is a child who otherwise the kidneys look good. You can see medullary pyramids, but the ureter is dilated. That could indicate something else, so that would go into higher risk and is going to go into a different follow-up protocol. So what do you do postnatally? At 48 hours of birth, if you have a renal diameter of 10 to 15 millimeters, so you do an ultrasound, there's some central calyceal dilation, everything else is normal, we would consider that low risk. This is an infant that might have an ultrasound postnatally. Yes, there is dilation, but you can see these are just the major calyces that are dilated. The minor calyces are not dilated. This is going to be low risk. Here's one with central calyceal dilation, less than 10 millimeters. Again, only the major calyces are dilated. The minor calyces that would be here are not dilated. On the other hand, postnatal presentation with peripheral calyceal dilation and ureteral abnormality, low risk, intermediate risk. So here's a child with peripheral dilation. You can see the calyces are dilated, and ureters might be dilated. We don't see it here, but those are children we're going to put into an intermediate risk category. Remember, the bladder is still normal. The parenchyma otherwise looks quite normal. You can see good medullary pyramids here. So this is a different category. And then P3, postnatal 3, UTD, urinary tract dilation, postnatal 3 is a child who has peripheral calyceal dilation. The thickness is abnormal. The ureters are abnormal. Bladder is abnormal. You can see a thick-walled bladder here. This goes under the high-risk category. So what are you going to do about this? Well, antenatal, low risk, we're going to not do much. We're going to just see that baby after birth, get an ultrasound somewhere around 3 to 4 weeks of age, and then maybe 1 to 6 months later, no need for a MCU, no need for a MAC3 renal scan. If you have 2-3, UTD antenatal 2-3, then we're going to follow these babies initially for 4 to 6 weeks, then get an ultrasound at 48 hours to 1 month of age, depending if it's unilateral or bilateral, and then consider a further workup. Okay, so when do we do a ultrasound 48 hours birth? Mainly if it's higher risk, if we've seen bladder dilation, ureteral dilation, bilaterality, then we're going to get an ultrasound at 48 hours of age. If it's just one kidney, bladder is normal, just wait for 1 month of age. Now, the postnatal protocol, if you have 1 to 6 months, we're going to leave it at the discretion of the clinician. If it's intermediate risk, we're going to do a follow-up ultrasound 1 to 3 months later. MCU is going to be at the discretion of the clinician. Is there ureteral dilation? Is it a boy? Is he circumcised? Is he uncircumcised? Is it a girl? These are all going to play into deciding who gets a MCU. In my practice, a boy who is going to be circumcised or a boy who has mild dilation, intermediate risk, is not going to get an MCU. Even girls are unlikely to get an MCU unless I see severe ureteral dilation. So unless I see high risk, that we talked about earlier, significant level of dilation, then I am going to get a MCU, I am going to start antibiotic prophylaxis, and I am going to get a MAC3 renal scan with Lasix. And so these are all of those laid out for you there. And so what you can see there is that if I have a child with greater than 15 millimeters dilation and all of these things, I am going to get an MCU, I am going to get a MAC3. If I have these findings up to greater than 15 millimeters, but you have no ureteral, you have no parenchymal thickness problems, I might be a little more careful. But if I think there's obstruction, I'm going to get a MAC3. But if I don't think there's obstruction, you might not. So there is still a lot of room here for training. This is not an algorithm-based workup, but it gives you some guidance as to what's significant. More than 15 millimeters, less than 15 millimeters, 10 millimeters of 15 millimeters is probably okay. So I think those are useful guidelines to keep with you. Now, if we look at this prenatal hydronephrosis, then Obstruction is a risk. And what kind of obstruction? You might see a UPJ obstruction or PUJ. You might see a ureterovesical junction obstruction, a ureteroceal, a ectopic ureter, a multicystic dysplastic kidney. You might see posterior urethral valves, a urethral atresia, megaureter, prune belly syndrome. All of these things are going through our mind as a list of a differential diagnosis. What's more common? Well, UPJ obstruction is probably the most common. Reflux 10 to 30%, UVJ 5 to 10%, and you can see the rest of the numbers there. What study should you order? I principally order the MAG3, the first one that you see there, because this is principally cleared by the proximal convoluted tubules and also secreted. So it gives you an idea not only of function, but also clearance. DMSA is going to give you function, but won't give you very good clearance. A DTPA will give you clearance, but won't give you function. So if you got a DMSA and a DTPA, you'll get the same information you can get with a MAG3. Now the DMSA, this is for your exams, and it binds to the renal tubular cells. It scans for at 4 to 6 hours, and it'll pick up damaged tubular cells. And so after pyelonephritis, it can help you in deciding whether that person has pyelonephritis, whether there's tubular cells or nephrons that have been injured, and it can take time to recover. It's very good for scarring. A MAG3 renal scan is a radioisotope that is excreted like DTPA, and it can give you relative function, drainage time, and so it is helpful. Now, diagnosis of obstruction is controversial. Hydronephrosis, again, is not obstruction. Serial imaging is required. If you see increasing hydronephrosis, a decreasing relative renal function, then that's a reason to think about maybe an intervention. But remember, you can have a false positive, so you might need to repeat that MAG3. In some cases, an MRU may be very helpful. An MRU will tell you if it has increased sensitivity. It vertically integrates the anatomy. You can see the kidney, you can see the ureter, the bladder, and also improves functional analysis. When to operate? Well, these are the easy ones, right? This is a child who has a curve that goes towards infinity, severe hydronephrosis, you have parenchymal thinning, no drainage, preserved renal function. You're going to want to go ahead and intervene on that type of kidney. On the other hand, here, you have moderate to severe hydronephrosis, you have symmetric renal function, you have a curve that drops. Remember, T1/2 means nothing in these cases. It depends, where you're drawing your areas of interest. You really want to think about looking at the renal function more than the curve itself. Nearly 60% of non-obstructed severe hydronephrosis cases will show an obstructed tracer on washout curves. So even if they're non-obstructive, but they have a lot of dilation, you will see a delayed drainage, and that can make you think you have obstruction when in fact you don't. And if you watch them long enough, you'll see a downgoing curve. So you have to be careful, look at the renal function, and only then look at the curve. Don't get caught up looking at the curve saying, oh, that's obstructed or that's not obstructed. The one thing to remember, I think very important, is that those children who have unilateral renal agenesis, you do a prenatal hydronephrosis, a prenatal study, and there's a missing kidney. In those kids, first of all, make sure there isn't a pelvic kidney or an ectopic kidney. But remember, in such situations, the ipsilateral ureter will be absent in 50%. You can have a contralateral UPJ obstruction in 11% to 30%. And genital anomalies are very common. If you have unilateral renal agenesis, 40% of the girls will have genital anomalies affecting the Mullerian tract. They can have a unicornuate uterus, which is the most common finding. They can have Mayer-Rokitansky, which is renal agenesis, vaginal agenesis. So these children I keep on a close watch, and I will consider doing a cystoscopy when they're a little bit older, just to be sure that they do not have vaginal agenesis and that they have a normal uterus. Very commonly, you might even see a bifid vagina, a duplicated vagina, duplicated uterus. So these kids need to be watched carefully as they approach puberty and their menses. 50% of boys with unilateral renal agenesis, 50% can have a vas deferens that's missing, a seminal vesicle cyst, ejaculatory duct obstruction. So these kids need to be watched very carefully. If you have a duplex system due to your two ureteral buds, the lower bud is absorbed rapidly and the ureter ends up more lateral, while the terminal one, the upper tract one, can end up sometimes causing epididymitis if it ends up in the epididymis, in the vas deferens, or the seminal vesicle. So remember, the upper bud absorbs slowly with a long mucosal tunnel, so it can end up in the posterior urethra if it's ectopic, or in females in the urethra or the vestibule, and so these children can present with constant leakage. So if you have continuous incontinence in a girl or epididymitis in a prepubertal boy, get an ultrasound. You might have renal agenesis, or you might have a duplex system in an ectopic ureter. So the ectopic ureter can insert aberrantly into mesonephric duct structures. So this is a classic where you see a normal urethral orifice, you see a normal vaginal orifice, and just between you have an ectopic ureter. You can sometimes see it just lateral in Gardner's duct, but these are the common things that you might see in a child with a duplex system with a dilated upper pole. So again, going back to that unilateral renal agenesis picture, this is a child who presented later in life with abdominal pain. Came to the ER, abdominal pain. It turned out that the child had a unicornate uterus that was obstructed, causing a large amount of menses trapped. And on a CT scan, you can see that the child had unilateral renal agenesis. So if I see this, I want to avoid this, which is a very painful presentation to the emergency room, and that's why I'll do a cystoscopy closer to puberty just to evaluate, get a pelvic ultrasound, and sometimes a pelvic MRI to be sure that, to see if there is any abnormalities before just letting the child go into puberty. So what I hope I have discussed with you today here is that prenatal hydronephrosis is common, but it's rarely of clinical significance. But when it is, proper counseling and family reassurance is critical. Heroic antenatal interventions, vesicoamniotic shunting, doing other types of procedures are rarely efficacious. They don't help renal outcomes. They might reduce a risk of pulmonary hypoplasia, but this needs to be carefully monitored. And do not underestimate unilateral renal agenesis. If you see that, watch these kids very carefully. Thank you once again, and we'll be open to questions.
Please play the next video. Mr. Shubho, please play the next video.
So this next talk is entitled Evaluation and Management of Urinary Tract Infections and Vesicoureteral Reflux. And what I aim to do here is to review some of the core concepts of both UTI and VUR, discuss their correlation, and how our modern treatment regimens are dealing with both of these very related issues. Now, we all know that urinary tract infection and reflux are intimately connected. You can get a UTI regardless of whether you have reflux, but if you have reflux, you can increase that chance of bacteriuria going to the kidney and, of course, causing pyelonephritis. The UTIs generally are very common in children. 5% of all children under 6 years of age living in the United States might experience a UTI, which works out in the US to 200,000. In India and Bangladesh, of course, those numbers are manifold higher. White children have a 2 to 4 times higher prevalence of UTI than black children. And girls have a higher prevalence than circumcised boys by a significant margin. And there are certain race and ethnic factors that play into this. White girls with a temperature of greater than 39 degrees will have a prevalence of a UTI of 16%. So at least in our practice, we do have to think about these, and you can make a risk stratification that we'll talk about a little bit later. Now, whether in the United States or any part of the world, we know that a UTI can cause kidney damage in a few patients, and dialysis or transplant due to kidney damage in a much smaller percentage of that, a subcohort. The 2011 American Academy of Pediatric Guidelines tried to look hard on these concepts, and it said that if a urinary tract infection is going to be treated, it is suspected based on the presentation, then a cath urine culture is important, because bag specimens alone, when a bag is taped to try to collect urine on an infant, has an 88% false positive rate. Now, there are some high and low risk factors that we're going to discuss, and a UTI can be called only if you have a urine culture greater than 50,000 and a UA with pyuria and bacteriuria. So you really have to have both. Just having pyuria and bacteriuria and no urine culture is difficult to call a urinary tract infection, as is often done in the pediatrician's office, where a quick urinalysis is done, shows pyuria, bacteria, and they're labeled as a UTI. Now compare the 2011 guidelines to the 1999 guideline, which is really how we used to think about this. We used to say that if you had an infant or a child between 2 months to 2 years of age with an initial urinary tract infection, they should undergo a VCUG or a nuclear VCUG, nuclear cystogram, radionuclide cystogram, to detect the presence and severity of reflux. And this was based on what was considered a fair level of evidence. Now that, of course, has changed recently. And why did it change? Well, it was changed on this risk stratification that was published in 2011 that showed that individual risk factors in girls shows white race, a certain age, temperature, a fever, being very significant risk factors for girls that might indicate a UTI, while the same risk factors for boys would be non-black race, temperature greater than 39 degrees, again similar, fever of 24 hours is significant in a boy, and an absence of another source of infection. And if you looked at all of these risk factors, then if you had no more than one risk factor, then your probability of UTI was less. If you had more than two, then the probability of a UTI increased. What was also significant is that the probability of UTI increases substantially, and the risk factors necessary are lower if it is a circumcised infant rather than an uncircumcised infant. An uncircumcised can have a significant risk factor for UTI even without other risk factors. And based on this, the 2011 AAP, American Academy of Pediatric Guidelines, changed to say that if you suspect or if you diagnose a urinary tract infection, 7 to 10 days of antimicrobials, oral or parenteral, a renal and bladder ultrasound is necessary, and no VCUG after the first febrile UTI in the setting of a normal ultrasound. If you have a normal ultrasound, no thickened bladder, no ureteral dilation, no pelvic ileectasis, then we can wait and say, let's not jump to a VCUG, all things being equal, unless you have substantive risk factors that indicate the need for that. So again, that's the 2011 guidelines, and compare that to the 1999 guidelines, at which time we had talked about that 2 months to 2 years with a UTI should get a VCUG right off the bat. So that changed in the 2011 guidelines. Now, as we think about that, which to us pediatric urologists was a substantive change in practice, let's go through the history a little bit. In the 1960s, Hodges first described the connection between reflux, bacterial infection, and renal scarring. Victor Politano in 1972 came up with the, along with Ledbetter, described the tunnel reimplant and discussed that, discovered that that surgery could be successful in eliminating reflux. And around the same time, CIC was discovered as a very legitimate treatment for bladder emptying. 1980, the concept of antimicrobial prophylaxis. And into the 1990s, we have discussion saying that, wait a second, you know, all these children with antenatal hydronephrosis being treated with VCUGs and then finding reflux that was asymptomatic. We know that antimicrobial prophylaxis works. We know we have a surgery that works. Hold on a second. Who needs this and who doesn't need this? Because VCUGs are a terrible experience. That started to become more of the narrative. So in 1964, we understood that reflux plus bacteria could lead to renal scarring. That was a very strong indication and a strong correlation, and felt that we had the answer. You eliminate, reflux, you can eliminate that scar forming, which was a terrible appearance. So if you look at it, think in terms of a UTI. You know, here's a population of children. Here's a population of children who might have a urinary tract infection and happen to have reflux, right? So if you get a UTI and you have vesicourethral reflux, which is about a 40% chance, what is the chance you're actually going to get renal damage? A much smaller number, right? Scarring is going to occur in a much smaller number than the population that's going to have a UTI and reflux. So if we know that it's only a small number of patients who get scarring, how do we decide which child needs a VCUG? Because a VCUG is a big deal, as we talked about. It's not just, or an MCU, I'm sorry, as we might say in India or Bangladesh, a micturiting cystourethrogram. Who needs that? So again, looking back to the fact that in 1972, Politano came up with his anti-reflux operation. So now we knew how to eliminate reflux. You still have bacteria. You can't eliminate bacteria unless you put them on prophylaxis, but you could eliminate reflux. And so the feeling was we are now going to have more normal renal scans. And we knew that the ureteroneocystotomy is effective with almost 99% success rate, depending on which study you look at. It can be safe, very low rate of obstruction. It has a low morbidity. Here we have an operation that works, that eliminates reflux, should eliminate renal scars. But let's look at the cost. If you look at the cost in today's dollars, if you do 200,000 VCUGs on children with reflux, out of that you do reimplants on 50,000 and you use 3,200 gallons of Bactrim, say antibiotic prophylaxis, the cost is $1.3 billion. So can we do better? The cost, putting these children through this operation. And so that led to the concept of antimicrobial prophylaxis. Jean Smelly in England very nicely described that you can put these children on prophylaxis. It works, it prevents infections, and VUR would resolve with age. So between 78 and 1985, antibiotic prophylaxis became very commonly utilized. Now we could get rid of the bacteria. However, the reflux is still there. That's okay. So if we can get rid of the infections, guess what? Maybe we can preserve the renal scans and let the kidneys continue to look good. But what does this require? An annual VCUG or an MCU, because when do we know that we can stop the antibiotic prophylaxis? When the reflux is gone, right? And so that led to the concept of a lot of annual MCUs. Every year a child gets an MCU, every year the child is continuing antibiotic prophylaxis. Well, in the annual cost, if you look at just that, even that is very substantial. $600 million, all this Bactrim, gallons and gallons of Bactrim. Is this really the best we can do? So in 1982, that there was a widespread use of antenatal ultrasonography. And started noticing that, you know what, some of these kidneys don't look very good to begin with. Whether they have reflux or not, right from the beginning, right out of the box, these are not very good. And that led to the concept of spontaneous resolution. That if you look at grade 3 reflux in the second chart, you can see that just about 50% will resolve in 5 years. But it does resolve. Grade 1 and 2 can resolve at a much higher percentage. Grade 4, even grade 4 can resolve in almost 60% of the cases or 70% of the cases. So guess what? You can have reflux and it spontaneously resolves. And if you look at resolution rates by the worst reflux grade, we can see, as I mentioned, even 50 to 60% of grade 4 reflux resolves spontaneously. Grade 1, 2, and 3 resolves almost into the 80 to 90% range as you follow these patients out. So the longer you follow them, the longer it gets better. And so that's when the concept came up. So it really changed how we started thinking about reflux, that yes, reflux can cause UTIs, can cause renal scarring, can cause end-stage renal disease, hypertension, and preeclampsia. But guess what? That's a rare combination of events, because renal scarring associated with UTI is less common than reported in older studies. We know that renal scarring is observed in children who have UTIs and don't have any reflux. So whether you have reflux or not, we can see renal scarring. And there's a paucity of evidence that interventions for children with reflux are effective. There's so many different interventions. Which one is the most effective? Which isn't? We haven't done very good studies to really evaluate this. And we know that MCU and treatments for reflux have potential harms and definite costs. So again, if we think about renal scarring with reflux, it turns out that it could be less common than we even thought before. So if we look at these studies with follow-up anywhere between 6 months and 2 years, they found that renal scarring could be a very rare phenomenon. Some of these studies, Garin study, they show 2%, 3% of patients with VUR actually develop renal scarring after febrile UTIs. So are we making a big decision based on a low risk of renal scarring? And even when they get renal scarring, the chance that they go on to renal transplant, much lower. We also know that better treatment is helpful. So DMSA results in the acute phase and day of treatment. If we look at the percentage of abnormal DMSAs as you go on days out, the earlier you treat them, you can lower the risk of a positive DMSA. So we have to be mindful of beginning treatment early. But if we are more rigorous in identifying a potential UTI and intervening and not letting the pyelonephritis continue for 4 days, 5 days, 6 days, we can really prevent abnormal DMSA findings. As I mentioned, renal scarring can occur in the absence of reflux. So VUR is not necessary for reflux reflux is not necessary for renal scarring to occur. And reflux may not be the most important risk factor for renal scarring in children with UTI. There might be other things that are causing renal scarring and not just reflux. If we look at some of the ecological evidence, if you look at the analyses of dialysis and transplant registries, you would expect, with all of this aggressive treatment of reflux and antibiotic prophylaxis and diagnosis, that we should be seeing a drop in renal transplants attributable to reflux, but that data is not there. So the potential harms and costs of reflux and nuclear cystograms are invasive, cause physical discomfort. It involves exposure to ionizing radiation. Diagnosis of reflux and perceived risk causes great anxiety. Prophylactic antibiotics contribute to antimicrobial resistance in the patient and the community. And the costs of diagnosis are potentially very high. These are some fundamental studies that led to the AUA guidelines recommendations that UTI and reflux causes more scarring than UTI alone. True, if you have reflux plus a UTI, it does increase the risk by some percentage, by a measurable percentage, and the odds ratio of scarring with reflux increases if you have UTI and reflux. We also know that abnormal bladder function is associated with more UTIs if you are on continuous antibiotic prophylaxis. So if you have a child on prophylaxis, it's so important to work on the dysfunctional elimination syndrome, the voiding dysfunction, because the UTI incidence is much higher. You can see 45% in a patient who has dysfunctional elimination syndrome versus about 18% if you have controlled the voiding dysfunction, the daytime urgency frequency, constipation, and other risk factors. You do want to reduce the number of UTIs. More even than important than the reflux is the number of UTIs. So if reflux is causing UTIs, nephritis, which is true, then you do need to think about that reflux. But reflux alone isn't the problem. It's the number of UTIs, the severity of UTIs, and the length of UTIs. And abnormal bladder function not only is associated with increased risk of UTIs, but it also prolongs the time to reflux resolution, as you can see here. If you have no dysfunction, you can have reflux resolution approaching 65%, and that number can drop to 30% if you have voiding dysfunction. Abnormal bladder function is associated with reduced success for even endoscopic therapy, but open surgery seems to be able to do well. Now, abnormal bladder function is associated with an increased incidence of UTI after surgery. So if you have abnormal bladder function, you really need to be thinking about that. Even if you have a successful reimplant, your risk of UTIs, as I have found in my own robotic reimplant series, your risk of UTIs can approach 25% if you have continued voiding dysfunction after the case. And the incidence of postoperative UTIs is correlated with baseline UTI prevalence. So as the prevalence of the UTI increases, the post-surgery UTI incidence increases. So it's really a logarithmic curve there. You really have to be thinking about both of those things in terms of UTIs. A child who had UTIs before surgery is going to be at risk for UTIs after surgery. The key is you might reduce the risk of pyelonephritis, so febrile UTIs. Higher grades of reflux can be detected because of prenatal hydronephrosis. And if you have prenatal hydronephrosis, you work that child up, you might find higher rates of reflux, and it might be associated with an abnormal DMSA. But again, this is out of the box. These children don't need surgery for their reflux if they're not having UTIs. So we know in general that UTI and reflux causes more scarring than UTI alone, a greater number of UTIs associated with more scarring, abnormal bladder function heightens all of these problems, lowers reflux resolution, and reduces the success of surgical therapy, especially endoscopic therapy. Continuous antibiotic prophylaxis may not protect against UTIs or scarring in all children, and higher grades of reflux detected with prenatal hydronephrosis are associated with more renal abnormalities. So what's our goal of management? We want to prevent recurrent febrile UTIs. We want to prevent renal injury. We want to minimize the morbidity of treatment and follow-up. How can we do that? Children with voiding dysfunction must be treated differently. Think about them as a completely different cohort. It has an impact on UTI risk, surgical outcomes, and UTI risk after surgery. Not using antibiotic prophylaxis can be an option in the low-risk child with very careful observation. The long-term health implications are possible, but usually with children demonstrating significant scarring. So if they already have significant scarring, they're at higher risk and may end up in a situation where they need a transplant, but this was already congenital. It had happened before the baby's birth. So we want to assess the risk of scarring in patients. We had to risk stratify individually based upon clinical factors such as age, grade of reflux, dysfunctional elimination, scarring, UTI history. The intervention should be appropriate to the risk profile. Reflux is a clinical challenge. It may be a wolf in sheep's clothing or a sheep in wolf's clothing, and our challenge is to determine which it is, okay? Which is the problem? Is it the reflux? Is it the UTI? Which way is it going? Is the reflux there as a problem beforehand, or did it become a bigger problem afterwards? We cannot simply treat based on grade, and there's no code to manage reflux. Understanding of reflux continues to evolve. Guidelines are not going to be cookbook. significant need for better research in this area. And that's what led to support for participation in the RIVER trial. So let's talk about that. We know that continuous antibiotic prophylaxis may not protect against UTI or scarring, right? You can have on prophylaxis and you can still have UTIs, you can still have scarring. Voiding issues have a big part to play in this. And we know that, hey, we got to put these kids on antibiotic prophylaxis because that's what we have always done, but does it really work? And that was the goal of the RIVER trial that many of you may know about, the randomized intervention for children versus with reflux. This is a trial of children being randomized to either placebo or sulfa, 600 children with reflux, and the outcome was recurrent UTI, kidney damage function, and antibiotic resistance. These were the primary outcome study. Sorry, the primary outcome was a recurrence of febrile UTI, and the secondary outcomes are listed there. And if the child developed 2 recurrent febrile UTIs within the study period, or there was new kidney scarring on DMSA, then they were considered treatment failures and followed a different path of treatment. And what did that study show? This is the first randomized blinded study that showed that children with febrile or symptomatic UTIs could be reduced by taking antibiotic prophylaxis. So antibiotic prophylaxis works. It reduced the risk of a symptomatic febrile UTI by 50% compared to children on placebo. So 111 of 607 children had 171 recurrent UTIs. Bactrim or sulfa reduced the risk of recurrent UTI by 50%. But there was no difference in renal scars, and that's important to keep in mind because some of these children, from baseline, there was no change. So they already had a baseline change that's different, but there was no difference in new renal scars. And remember, even with this 50% risk reduction, 8 children had to be treated for 2 years to prevent 1 recurrent UTI. So recurrent UTI and UTI. So it is reasonable to prescribe prophylaxis for children with reflux and a history of febrile UTI and who have bowel and bladder dysfunction. We should consider that 8 children had to be treated to prevent 1 recurrent UTI. So that is a lot of antibiotic prophylaxis. So we really need to be treating those children who need this treatment, who we think are at high risk for a recurrent UTI. A circumcised boy with grade 3 reflux, you probably don't need to be treating that child with antibiotic prophylaxis. So just something to keep in mind as we'll talk about. So how do I do reflux management? If I have a child with reflux after a follow-up of antenatal hydronephrosis, I consider this a benign course disease with a high rate of spontaneous resolution. So I stop prophylaxis early, depending on the grade. If they have VUR without scarring, diagnosed after a UTI, if they're low grade, they don't have scarring, I continue them on prophylaxis until toilet training. And then I will stop it and see how they do. If they have high grade of reflux, if they get a breakthrough UTI, I'm going to consider surgery. And I might keep them on prophylaxis right up to toilet training and then make a decision based on the risk. Consider surgery if it's a girl who has a history of a UTI, still has grade 4, grade 5 reflux at toilet training age, we're probably going to get surgery. A boy who has not had a UTI in several years likely may not get surgery. So it really depends. If you have VUR with scarring diagnosed after a UTI, okay, so with scarring now, low-grade reflux, again, same thing, prophylaxis until toilet training and see how they do. Grades 3 to 5, we're going to consider surgery if it's persistent after toilet training. So I hope that's a helpful algorithm on how many of us will take care of urinary tract infections in children. I hope we've gone through some of the concepts connecting and correlating reflux, UTI, bowel and bladder management, and how all of these things function together. They interplay in increasing the risk and who needs and how to risk stratify these patients. Thank you. for this opportunity once again. And we're going to talk about one of my favorite topics, and one in which I've delved deeply at different parts of my career. If you have access to Campbell's, I did write the chapter on posterior urethral valves. Whatever I speak about here is based on a lot of the research I did for that chapter, and I encourage you, of course, to read it for a more detailed description of some of the concepts I'm going to discuss here. So if we think about posterior urethral valves, I often mention that this is an operation, that this is a condition that's intriguing in that the initial therapy is the initial therapy is inversely proportional to the long-term consequences. By that I mean that taking care of this by going in there and ablating the valves or creating a vesicostomy is actually quite simple. What's more difficult is the long-term care of these patients. And what's more difficult is the long-term consequences of the damage that often has already happened. And based on different estimates, there are 2,000 new cases per year in India. So this is a common condition seen by many people throughout the subcontinent, India, Bangladesh, Pakistan, lots of publications from these countries due to the rather high prevalence and incidence. Evolution of valve bladder is a profound event in bladder devolution, because the valve bladder really, if that occurs because of our treatment or treatment failure, or because it was meant to happen, it really is the most devolved place that a bladder can be. And very often, we end up focusing on the kidney. And we focus on the kidney to the extent that it distracts from the central role of the bladder in the disease process of posterior urethral valves and pulmonary hypoplasia. Because pulmonary hypoplasia is the situation that leads to immediate mortality in these children. So if we think of valves and voiding dysfunction, we know that the bladder goes through three different patterns in the evolution of the bladder. There is the uninhibited contractions, which we see in infancy and small children, multiple uninhibited contractions. Sometimes it can be a small capacity bladder, poorly compliant, and that can continue into the younger age. And then as the child gets older, you can end up with a compliant bladder with contractility, but with significant dyssynergia. And what often happens is that contractility will begin to diminish. And then they might start getting a concentrating defect and end up with diuresis. And we're going to talk about this in more detail, but it's that diuresis, that large production of urine onto a bladder that's trying to keep up with improving compliance, that ends up putting it into low contractile bladder, because now the bladder is being overwhelmed by the urine production. And we're going to talk about this much more, because in this talk, I'm not going to talk as much on who needs a ablation, valve ablation, who needs a vesicostomy, what does reflux mean, what does that foretell. We're going to talk about all of those in a different talk, and that would be a much longer discussion on posterior urethral valves. But I think for all pediatric urologists, my message for many years on this, speaking about this subject, has been the crucial, critical importance of monitoring for the evolution of the valve bladder syndrome. And what is the valve bladder syndrome? What you get, as I mentioned, is a child who is who is starting to develop some continence. But what can happen is that because these bladders have been under a large amount of stretch, they're starting to hold urine, they've been holding, it's causing increasing stretch, they can develop collagen and filament changes. And this happens even before, when they were diagnosed with posterior urethral valve.
কি হলো ইসে?
Hey,
সুমন
Shuman.
ট্রান্সমিশন।
Shuman.
সুমন তোমার ব্যাটারি বোধহয় লো হয়ে গেছে কম্পিউটার।
স্যার দিয়ে দিচ্ছি স্যার।
পাওয়ার কানেকশন।
আচ্ছা ঠিক আছে ঠিক আছে।
Ishaq sir, good session, excellent session.
হ্যাঁ, it's continuing.
ইস্তেক ভাই সবাইকে একটু ভার্বালি বলে দেন মিউট করার জন্য।
Jahid.
হ্যাঁ, আমি অনেকবার বলেছি, লিখেও দিছি।
আবার এই মুহূর্তে ভার্বালি বলে দেন।
Situation that leads to
SMS এ কাজ হচ্ছে না।
সবাইকে অনুরোধ করব যে আপনারা মিউট থাকেন প্লিজ।
So if we think about valves and voiding dysfunction, we know that the bladder goes through 3 different patterns in the evolution of the bladder. There is the uninhibited contractions, which we see in infancy and small children, multiple uninhibited contractions. Sometimes it can be a small capacity bladder, poorly compliant, and that can continue into the younger age. And then as the child gets older, you can end up with a compliant bladder with contractility, but with significant dysenergia. And what often happens is that contractility will begin to diminish. And then they might start getting a concentrating defect and end up with diuresis. And we're going to talk about this in more detail, but it's that diuresis, that large production of urine onto a bladder that's trying to keep up with improving compliance that ends up putting it into low contractile bladder, because now the bladder is being overwhelmed by the urine production. And we're going to talk about this much more, because in this talk, I'm not going to talk as much on who needs a ablation, valve ablation, who needs a vesicostomy, what does reflux mean, what does that foretell. We're going to talk about all of those in a different talk, and that would be a much longer discussion on posterior urethral valves. But I think for all pediatric urologists, my message for many years on this, speaking about this subject, has been the crucial, critical importance of monitoring for the evolution of the valve bladder syndrome. And what is the valve bladder syndrome? What you get, as I mentioned, is a child who is who is starting to develop some continence. But what can happen is that because these bladders have been under a large amount of stretch, they're starting to hold urine, they've been holding, it's causing increasing stretch, they can develop collagen and filament changes. And this happens even before, when they were diagnosed with posterior urethral valves. The bladder was so stretched in utero and shortly after birth, because of the valves and the pressure that it causes in the bladder, and that causes significant collagen filament changes. And those filament changes can increase the risk of bladder wall hypoxia. Because of those collagen filament changes, there's less room for normal architecture within the bladder body. And that increases bladder storage pressures. And when bladder storage pressures are increased, that pressure can be transmitted to the renal pelvis. And so now you start getting the hydronephrosis that you start seeing in a valve bladder syndrome in a child who's getting further out in their bladder management. That can lead to renal tubular damage. And once you've had the renal tubular damage, you start getting polyuria, because now you have a renal concentrating defect because the renal tubules are damaged. So what does that do? Creates a large amount of urine coming into the bladder. Now this child attempts to void at increased voiding pressures, because now to pee, he has to really push down and sometimes Valsalva. And what does that do? That can force urine into the hydronephrotic bladder. It can push urine, cause reflux, push urine up into an already hydronephrotic kidney. And then that child urinates. And what happens? That urine that was sitting in the hydronephrotic kidneys drains into the bladder and leaves a hypovoid residual. That again, the increased residual increases that stretch injury that already occurred congenitally. That causes more collagen filament changes, more hypoxia, and you can see how this vicious circle will go. So how do we manage this? How do we interrupt this process? So as I mentioned, you have this problem of a large amount of urine coming into a bladder, and then after the child urinates, all of this urine that was stored in the upper tracts comes pouring down into the bladder. So the child has this big bladder, voids, maybe leaves a residual because their filaments are weak, and now all of this urine that was in the upper tracts immediately comes crashing down into the bladder. You also have a concentrating defect, so the kidney is now draining even more, and that urine fills up the bladder, and we start getting the problem of a valve bladder. And so time voiding becomes critical very early in these children. As soon as they're toilet trained, one of the most important things that I stress to the families is the need to keep bladder diaries, to really make it second nature that they need to urinate every 2 hours. So for me, you know, when I see a child with posterior urethral valves, I cut the valves, or I do a vesicostomy and then close the vesicostomy and cut the valves when they're a little bit older, depending on the indication. If their kidney function is maintaining, the focus really is on bladder emptying. I see them every 6 months with an ultrasound, and once they hit about 3 years of age, we start thinking about toilet training gently, and then once they're toilet trained, we really work on time voiding. We might do some biofeedback to encourage that, so that they stay on a strict bladder voiding regimen. We do a frequent renal ultrasound, and oftentimes, if despite this we start seeing the bladder starting to fill or the kidney starting to get dilated, then nocturnal bladder drainage will be of help. Leaving a catheter at night makes a big difference in allowing the bladder to be fully empty. It really allows those bladder filaments that have been stretched all day long to have 8 hours or 10 hours of complete emptying, allowing the urine to pass, letting the upper tracts empty. And sometimes, because these children can have a very sensate urethra, we will consider a Mitrofanoff procedure for these children to facilitate bladder emptying and to help in that regard. Now, the Mitrofanoff principle, as we know, is taking a channel, the appendix, connecting it to the bladder. Different ways that this has been done over the years. Now we've gone mostly to a laparoscopic way of doing the Mitrofanoff procedure, and this is a Mitrofanoff being done in a child with posterior urethral valves and a valve bladder. So, you know, here's that bladder being mobilized. We will often drop the bladder down and so allow an anterior positioning of the appendix, so it allows a straight line. You can also do it into the posterior bladder if it's not long enough, but I have found that reflecting the bladder brings it closer to where we need to be for this procedure. And you can see then you make a incision in that wall, just like you might be doing a reimplant, an extravesical reimplant, allowing an incision in the trusser muscle, exposing the mucosa, and then making an opening into the base right there. Once we've passed a feeding tube, we'll make test the appendix. This is just like you might do it open. Here's a hit stitch being put in to hold everything up, to stabilize it. And then here's the 8-French feeding tube being passed through the appendix, the anastomosis being completed, and then advancing it into that mucosal trough that we've created. So very similar, hoping to mimic exactly how all of you do it open. You can do it laparoscopic, but this is a very fundamental procedure in my hands and very commonly used for a child with posterior urethral valves who starts developing a valve bladder. So not for most children with posterior urethral valves, but those that do develop a latter stage procedure, latter stage complications such as posterior urethral valves. So once you've done this and you really try to manage the posterior urethral valves and the valve bladder, and if we've understood the valve bladder physiology, which I hope I've been able to do, we can start thinking about the prognostic indicators for posterior. So, if we know in general that if a child is born with end-stage renal disease, if a child is born with posterior urethral valve, their lifetime prevalence of end-stage renal disease is between 20% and 50%. So that's for all comers. In general, we quote a number of between 30 to 45% is the most common range of children who will require renal replacement therapy. And what's going to impact that? It's going to be the age of diagnosis. Did we diagnose this very late when renal damage had already occurred? Did we diagnose it prenatally, and so we were able to intervene with therapy very early? It depends on the renal dysplasia, with or without reflux. Now remember, having reflux with posterior urethral valves is not an independent risk factor for renal disease. Yes, you can have significant dysplasia, but that dysplasia is the driver, not the reflux. So having reflux is not an independent risk factor for having the likelihood of renal replacement therapy. But what is also very important is a nadir creatinine during the first year of life. And there are different proxies that one might look at: 1 month nadir or 1 year nadir. And what we tend to look at CHOP at the Children's Hospital of Philadelphia is what was a nadir creatinine during the first year of life. There are other risk factors such as recurrent urinary tract infections, bladder dysfunction, and what's a renal parenchymal area? This is an emerging marker, so we'll talk about that a little bit. So again, looking at nadir creatinine at 1 year of life is more accurate than the nadir creatinine obtained at 1 month of life. So I think it's important that we look at that number as a better risk factor than the 1 month value that was also very popular. Now, in countries such as India, Bangladesh, where valves can be diagnosed much later. In fact, up to 40% of posterior urethral valve series that come out of AIMS and other institutes will often show a late diagnosis, that 40%, 50% came after age 5 and were diagnosed with valves, and were only diagnosed because they were having some hesitancy, incontinence, or UTIs. Those are a little different way of evaluating. You're going to have to look at different proxies. But if you look at those children who were diagnosed at birth or prenatally, and then had the valves ablated shortly after birth, then a nadir creatinine value at 1 year of life is going to give you some indication as to renal outcomes. And if your creatinine stays less than 0.8, we consider that a minimal risk of needing renal replacement therapy. That doesn't mean these children will have perfect kidneys. They may have a risk of dysplasia. They may have risk for UTIs. They may have hypertension, but in general, renal replacement is much lower. And those that have a 1.2 or higher are at significant risk of developing end-stage renal disease. But what's not very clear is what happens to that population between 0.8 and 1.2, and what can we do about those children? So those are the ones that we really spend a lot of time on, which is, how can we really try to figure out how these kids are going to do, what are the therapies that I can initiate? And sometimes there isn't any therapy that you can initiate. All you can do is really be on top of their voiding, be really on top of their voiding dysfunction, watch their blood pressure and proteinuria, and make sure a nephrologist is following these children along with you. So if a transplant becomes necessary, a renal transplant requires a reservoir and a bladder in which to empty. Whether a reservoir in turn is able to empty out is another question. So yes, a renal transplant requires a healthy bladder. But if that bladder is already a valve bladder, what are you going to do about those children? I want to say that bladder augmentation is extremely rare. It does have to be done in children with valves. A few are done, even at my institute that sees a high number of patients. We do a few over a few years, but it's a rare number. In my experience, I can count on my one hand how many transplants I may have done in a child with posterior urethral valves. in general, with proper initiation of therapy, proper intervention, we can hope to avoid a bladder augment. But we know that up to 20% of bladders are deemed unfriendly for renal transplant because of the thick wall of the bladder, because of voiding dysfunction, because of a valve bladder. So a pediatric urologist is really a critical part of this transplant team. So what are the chances? What are the challenges? Children with urinary diversions for bladder outlet obstruction have been undiverted prior to renal transplant. This was the past when we used to do different things such as an ileal conduit or other type of diversion for a child prior to renal transplant. We try to avoid that now. Timing and sequence of renal transplant and urinary tract reconstruction has been hotly debated. Should you do an augment if that child has a very poor bladder? Should an augment be done prior to the transplant or after the transplant? If you do it prior to the transplant, you put this child through a big operation, and the bladder's this augmented bladder might be empty of urine until the transplant is done. On the other hand, doing a augmentation after a transplant has a risk of immunosuppression, risk of infection, and dehiscence. So there are these things that we have to balance. Addition of bowel to the urinary system in immunocompromised patient carries increased concerns. Considering all that, we should know that in general, pediatric transplant does have a high chance of ureteral obstruction. So not only do you have those risks that I've discussed, just putting a ureter into a valve bladder carries certain risks. And what are those risks? Well, the incidence can be anywhere from 1%, and actual number is 10%. It is independently associated with graft loss. You can have UVJ strictures, you can have a short ureter, you can have local ischemia that develops, ureteral strictures. So there are multiple risk factors in these situations. For children with end-stage renal disease undergoing renal transplant, the question might be, are there pre- and post-operative risk factors that predict ureteral obstruction? And how effective are available conservative and invasive management options for obstruction in the pediatric transplant patient? We did a study some years ago where we did a retrospective review of the pediatric transplant database in Minnesota when I was there. The time period we looked at was 1984 to 2007. We looked at all the donor characteristics. We did a subgroup analysis of these children to see those who developed a ureteral obstruction after transplant, to see, can we know whether having posterior urethral valves is an independent risk factor for complications. And what we found is that of 449 pediatric transplantations, there were 41 ureteral strictures that occurred. It was 10% of the population that had a ureteral stricture. As you can see on the table, posterior urethral valves is the most common risk factor, and that made up 35% of the ureteral obstruction subgroup. So the incidence overall still sits at about 4% of all patients getting a pediatric transplant may develop a stricture if they have posterior urethral valves. And when we looked at a multivariate analysis for ureteral strictures, it was clear that the only statistically significant risk factor of all of these other issues was posterior urethral valves. If you had posterior urethral valves on a log rank test, you had a chance of developing obstruction in about 40% if you follow these patients long enough. That's a very significant population and a significant concern, and something that we really had to think about very carefully in how we're doing these reimplants of the ureter into a valve bladder. And sometimes those obstructions are functional obstructions. They're due to the bladder not emptying properly and being thick-walled, and so the urine is filling up. They have a low post-void residual. They have a high post-void residual, and so the kidney has a hard time draining into this, and that can cause the ureter also to be, if it's a tunneled reimplant or if it's a thick-walled bladder, it can increase the risk for stricture. We also found that stentings and dilations were not very successful in taking care of this, and ultimately, surgical reconstruction was really the best way of getting rid of these ureteral obstructions. So if we think about valves and transplant, we did another study looking at the graft success and graft failure. You had 418 transplants. This was our overall success rate. And 31 patients had posterior urethral valves. And we found that the graft failure rate was 32% in these patients. And what we found is that voiding dysfunction information was available. 55% had evidence of bladder dysfunction, including more than one complaint. Out of those boys, 33 boys that had voiding dysfunction. And 56% graft failure rate when bladder dysfunction was present, compared to 27% in those without bladder dysfunction. This to us really drove home the point that you have to take care of the valve bladder. Not only will it increase your risk for requiring a transplantation, but even if you have a transplant, it will increase your risk for transplant failure. So it's so crucial that we really pay attention to avoiding dysfunction in these children. And there was no risk for bladder dysfunction whether we had done a vesicostomy or a valve ablation. So the mode of taking care of this didn't alter the outcome in these patients. So what we've done here is talked about the various risk factors for a valve bladder. We've also talked about the risk for a valve bladder to renal transplant, to renal failure. And if you do develop renal failure and you need a transplant, we've talked about the risk factors to graft survival if you have not taken care of the bladder. So I think you've heard the word bladder spoken on multiple occasions during this talk. And if it's anything I leave you with is when you think about a child with posterior urethral valves, don't get caught up at looking at the kidney and the ultrasound and boy, that's a very dilated kidney and there's a dilated ureter, and start thinking in terms of obstruction and reimplanting these kids and oh, they have reflux. Don't worry about that. Think about why they have reflux. Why do they have hydronephrosis or hydroureter? It's likely a devolution of the bladder, and start thinking about valve bladder and how you can empty bladder emptying, get a good urodynamic, see what their post-void residuals are, and then base your treatment accordingly. Thank you, and we'll take questions.
Okay, now I'd like now to speak about cryptorchidism, what to do, what not to do. And I'm really going to base this on the AUA guidelines. As you know, there are not a lot of guidelines for pediatric urology because the evidence itself has been of a different level, shall we say, in pediatric urology, just by the nature of the specialty. But one of the areas where we do have guidelines, and one of my partners here at CHOP was on the key committee, Tom Colin, as well as Julia Barthold, people I know very well. And so I think this is important concepts that we can all go through. So let's understand the evaluation of the child with cryptorchidism, to understand when to refer the child with cryptorchidism, and when should diagnostic imaging be considered. And I think this is something you can also discuss with your own referring physicians. We all think we know cryptorchidism very well, which it is true. But really, let's try to do a guidelines-based talk and make sure that all of our practices are aligned when it comes to cryptorchidism. So in cryptorchidism, you have absence of one or both testicles, of course. That's the strict definition of cryptorchidism. Just going to read. And absence of one or both testes from the scrotum. The long-term risks, why we care about cryptorchidism, of course, is very clear. We do not want infertility, and we don't want cancer. These are two significant issues, of course, and both of them are intimately related to cryptorchidism. So what is our rationale when we're discussing this with the family, when we're discussing this with a primary care referral base? We want to hopefully improve fertility. We want that child to be able to perform self-examination for a testes mass. As we mentioned, you have an increased risk. We want to correct any associated hernia. We want to deal with the psychological effects of an empty scrotum. And we want to prevent testicular torsion. I just had a child last week with an undescended testes that had torque. And these are very late to present because the testes is outside of the scrotum. So when they start having pain, they first think of it in abdominal pain. Nobody sees a swollen ecchymotic scrotum. And so this diagnosis can be missed by pediatricians by emergency rooms until it is too late. So going by a case-by-case basis, if we have an 8-month-old healthy boy with a non-palpable right testes identified at birth, what is our management? Do we refer that patient? Do we obtain a renal ultrasound? If you have a 7-year-old healthy boy, you evaluate in your clinic since birth, you have an undescended right testes palpable at the pubic tubercle on the previous well child visit. On an exam a year ago, the testes was palpable. This is a child who needs surgery. Do we obtain imaging studies? So again, this is the cryptorchidism team that came together for the review that we're doing here. Two of my partners, I should mention, Gregory Tajan as well as Tom Cohen, and of course all the other folks that are very involved in this issue. So this is a systematic review, looked at primary source evidence extracted from the Agency for Healthcare Research and Quality. The AUA had a huge part, the AUA Education Office, in bringing information together, reviewing studies between 1980 and 2013, 704 studies that were reviewed. Went down a process then of rating the evidence strength. A-level studies are those that are well conducted, the randomized control trials, or exceptional observational studies. B-level evidence is randomized trials with observational studies but have some weaknesses, and otherwise observational studies that are inconsistent, difficult to interpret. That makes up the C-level of evidence, which unfortunately is the vast majority of evidence out there in terms of the literature. So the methodology for this study, we want to link evidence to statement type. And standard recommendation is when the benefits are greater or less than the harms. Level of evidence is A or B. This would be a high standard that becomes the new standard of care. A recommendation would be the benefits are greater or less than the harms. The level of evidence is lower. So benefits equal harm, level of evidence. These are all the things where we might say, hey, look, this is a new standard, or this is a recommendation, or this is an option in how we treat the child. So in guideline statements, a clinical principle is that a statement about a component of clinical care that is widely agreed upon by urologists, and that's different than expert opinion. So in cryptorchidism, guideline statement number 1, so this is a guideline statement, providers should obtain gestational history and initial evaluation of boys with suspected cryptorchidism. This is based on a B level of evidence. What we want to know, what do we want to know? B level evidence. Were the testes ever palpable? Did you see them before and now they're non-palpable? When the child is in warm water taking a bath, when you're giving a bath, is the testes descended? Did the child have prior inguinal surgery that might have increased the risk for an ascended testes? What's the family histories? Are cryptorchidism, hypospadias, disorders of sexual differentiation, infertility? All of these, of course, can be associated.
Shimon? হ্যালো সুমন, শোনা যাচ্ছে না?
সুমন, অডিও কই?
শোনা যাচ্ছে না
স্যার? স্যার,
হ্যাঁ সুমন,
স্ক্রিন ফিক্স হয়ে গেছে স্যার, অডিওটা শোনা যাচ্ছে না।
স্যার স্যার বলেন।
নেট সমস্যা হচ্ছে?
স্যার
ওদের
আমি
ওদের ওখানে কি নেট
আমি
সমস্যা
স্যার ওই
কিনা?
যে
সুমন,
নেট সমস্যা, একটু নেট সমস্যা আছে স্যার। আমি এই যে নেটের কাছাকাছি যাচ্ছি স্যার, এই
আচ্ছা
যে
ঠিক আছে, ঠিক
ওয়াইফাই এর
আছে।
কাছাকাছি স্যার। আমি পরে কথা বলছি স্যার। সালাম স্যার।
সুমনকেই তো শোনা যাচ্ছে না।
হ্যাঁ শুভ,
একটু
সুমন
একটু ওয়েট করো, একটু ওয়েট করো, নেট প্রবলেম হচ্ছে তো ওরা যাচ্ছে।
এতক্ষণ যে স্মুথলি চলবে এটাই তো অনেক স্যার। হ্যাঁ, নেটে
না
নেটে এত জাম, সারা বাংলাদেশে এখন নেটের উপরে চলতেছে স্যার, সারা ওয়ার্ল্ড, নট অনলি বাংলাদেশ।
তারপরে যে ফাইবার অপটিকে কিছু অসুবিধা হলো কয়েকদিন
হ্যাঁ
আগে আমাদের।
হ্যাঁ, অনেক সময় হয় স্যার। আমার তো কালকে রাতে স্যার বাসায় নেট ছিল না, পরে আমি ওদেরকে ফোন করে আমি এনশিওর করছি যে আজকে যাতে আমার কোনো ইন্টারাপশন না হয়। এই সুমন কি ব্যাপার, স্ক্রিন কই?
স্যার
ওকে
স্যার আমি
ওকে 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 ওকে
যে আমার মিসেস কে নিয়ে ঢাকা মেডিকেল থেকে দিতে স্যার আমি শুনতেছি স্যার।
হ্যাঁ রাব্বানি, ভেরি গুড ভেরি গুড ভেরি গুড। আর ইউ ড্রাইভিং?
হ্যাঁ জি স্যার, জি স্যার, ড্রাইভিং স্যার।
ওকে দেন নো টক প্লিজ।
ড্রাইভার চলে গেছে স্যার লকডাউনের আগে।
Okay, stay safe and drive safely. Okay.
And take care.
হ্যাঁ, থ্যাংক ইউ স্যার, থ্যাংক ইউ স্যার।
সুমন, আচ্ছা আসতেছে।
Contractile testes that may be very difficult to bring down. Is it a warm, relaxed child? What is the child in a frog-leg position? We want to look before we actually touch. Milk down from the iliac crest towards the scrotum. Slowly bring the testes down from the iliac crest towards the scrotum. Use soap or lubricant. Observe for the testes. Does it sort of pulse back up? Does it come back down? These types of things, putting a hand over the internal ring and then with your other hand, with a lubricated hand, popping over the testes will help you decide whether there is a testes or it's a non-palpable testes. So if you feel a testes, it can be non-palpable, it can be palpable, it can be inguinal, scrotal, ectopic. I just had one that was ectopic that was down in the perineum, or it can be retractile. And so providers should refer infants with a history of cryptorchidism who do not have spontaneous descent by 6 months of age. 6 months of age. It used to be when I was a resident, a year, 18 months, pediatricians would follow these children to see, hey, maybe the testes will come down, go home, come down. If it's not down by 4 to 6 months of age, it is not going to come down and they should be sent for evaluation. Because at 22 to 25 weeks, testes are located at the internal ring. This is gestational age. By 25 to 30 weeks, it's in the inguinoscrotal phase of descent. So if you're born before 30 weeks, they're not down, the testes, of course. But a baby who's born after 30 weeks, hopefully, if the testes are going to come down, they're down. Spontaneous descent of the testes is unlikely after 6 months of corrected age. So, Guideline Statement 4. Providers should refer boys with the possibility of a newly diagnosed acquired cryptorchidism after 6 months of age to an appropriate surgical specialist. So, the ascent of a previously descended testes and subsequent inability to manipulate the testes back into the scrotum is something you might see in acquired cryptorchidism. This is a child that the pediatrician is sure felt the testes, but the child is back at the 6-month visit and the testes has actually popped back into the internal ring. This can be seen in 1 to 7% of cryptorchid cases, and it peaks at around 8 years of age. So this is a child who you were able to palpate a testes, but as the child got older, got taller, as they get to 6 years of age, 7 years of age, that testes may ascend because of axial skeletal growth and the spermatic cord itself being short. It's more common in boys with proximal hypospadias. This is acquired cryptorchidism. Boys with a history of retractile testes may be at risk. Now, you have to be careful. If it is a easily retractile testes, this is a normal finding. They're not going to have acquired cryptorchidism. But that child who you had some trouble milking that testes down, you thought you were able to get it into the scrotum, that testes then went back up. This is possible in a case of testicular ascent, and it may be associated in those cases with retractile testes. It will have the same adverse histologic features. If you look at the 80 spermatogonia, the germ cells, these children are going to act like a true primary undescended testes. So we really need to be thinking about a primary undescended testes just as we would about acquired cryptorchidism. The providers must immediately consult an appropriate specialist for all phenotypic male newborns with bilateral non-palpable testes for evaluation of a possible disorder of sex development. You have an infant in the newborn nursery, bilateral, non-palpable testes, male phenotype. Of course, you need to be thinking about congenital adrenal hyperplasia. Certainly, if you were to look, you might find that these are ovaries, and this is a completely different situation. Hopefully, we won't even make this incision based on proper diagnoses. Guideline Statement 6, providers should not perform ultrasound or other imaging modalities in the evaluation of boys with cryptorchidism prior to referral, because they don't help. As you know, many people will get a scrotal ultrasound or pelvic ultrasound in cases of a undescended testes, thinking that this is going to help us. And in fact, 67% of pediatric surveyed, those pediatricians surveyed, ordered imaging in boys with cryptorchidism, when we as pediatric urologists feel that is completely useful. And when they did order imaging, 96% reported ordering an ultrasound. The most frequently chosen patient factor that influenced respondents to obtain imaging was a non-palpable testes, 80%. Bilateral undescended testes, a child older than 1 year of age, these are different situations. 86% reported the belief that the ultrasound reliably identifies a non-palpable testes. So people really believe that. However, despite those numbers, we know that the sensitivity of a ultrasound for cryptorchidism is only 45%, and the specificity is only 78%. So you can see your true positive and true negative rates overall are quite low, and so really should not be ordered. The increase and decrease in the odds of a testes actually being found in the position identified by ultrasound about 79%. So the likelihood ratios of a test providing a way to estimate the post-test probability of having a condition given a positive test result or a negative test result. You can look at different ways of thinking about this. I won't spend too much time with this Fagan plot, but what it tells you is that in general, the probability of an ultrasound helping you in diagnosing a testes that you don't feel or you might be worried about only sits at between 50 and 65%. So depending on the pre-test probability, the probability after a positive ultrasound or probability after a negative ultrasound really didn't change based on the pre-test probability. If your pre-test probability of an undescended testes was 90%, after positive ultrasound, 93%, negative ultrasound, 88%. It didn't help you, so no need to get an ultrasound. Providers should assess the possibility of a DSD when there is increasing severity of hypospadias with cryptorchidism. A distal hypospadias and undescended testes, the likelihood of a DSD is lower than if you have a penoscrotal or perineoscrotal hypospadias, severe chordee, and an association of undescended testes. Now, at least on a grade level of C, you might have a chance that you have a mixed gonadal dysgenesis or any of the other types of situations, PMD and persistent Mullerian duct syndrome and other things that you might need to think about. So, an increased possibility of DSD when cryptorchidism and hypospadias is present, and the risk increases with the severity of the hypospadias. Guideline Statement 8, in boys with bilateral non-palpable testes who do not have CAH, providers should measure MIS and consider additional hormone testing to evaluate for anorexia. So this now becomes interesting. You have non-palpable testes, you have your 17-hydroxyprogesterone level is low, you don't have a situation of CAH. In those patients, you can get an MIS, and then you can decide whether there is testes present or not. And in boys with retractile testes, providers should monitor the position of the testes at least annually to monitor for secondary intent. ascent. So retractile testes, the differentiation between a retractile and undescended testes can be difficult. Remember, the cremasteric reflex is weak or absent during infancy and most active in a 5-year-old. So in general, you shouldn't really have too much retractile testes in a 2-year-old, but a 5-year-old coming, in our practice, almost 70% of those that are referred for an undescended testes will actually just have a retractile testes. To really tell the difference, you want to grasp the testes. You want to feel the testes, maintain that position for about 30 seconds, because that will fatigue the cremaster muscle. And then if you release the testes and it stays in place, it's a retractile testes. If it immediately retracts back to the prescrotal position, you have an undescended testes. Guideline statement 10, do not use hormonal therapy to induce testicular descent, as evidence shows a low response rate and lack of evidence for long-term efficacy. And there's some evidence, this is not in the guideline, that it can actually cause abnormalities in those testes. So it's not something that we recommend. Guideline statement 11, in the absence of spontaneous testicular descent by 6 months of age, specialists should perform surgery within the next year. So if it isn't down by 6 months, move towards surgery. Now, why? Histologic data supports early treatment, okay? We know now, more than ever before, it used to be thought that, you know, an undescended testes is already a burned testes. What is it going to do to bring it down so early? We know that histologic data supports early treatment. You can have decreased testicular volume, decreased spermatogonia, smaller seminiferous tubules in these children. But bringing them down earlier can preserve the number of 80 spermatogonia and can reverse some of these occurrences. A popular, in the second issue is cancer. A population-based cohort study of 17,000 males who underwent orchipexy before 20 years of age showed that less than 13 years, you had in general, for all ages, you had a lower than 10 to 40 times increased risk for developing cancer. So you do have an increased risk of developing cancer. That risk, if you do surgery before 13 years of age, is much lower than it's almost double if you do surgery more than 13 years of age. And now there's data that if you do it less than 10 years of age, it's better, and perhaps even less than 18 months of age is even better than 10 years of age. It's not in the guideline statements, but that's emerging data. So in prepubertal boys with palpable cryptorchid testes, a scrotal or inguinal orchipexy is the way to go. The basic principles of the orchipexy: identify the testes, mobilize a cord, ligate the patent processus vaginalis, and relocate the testes. So when we think about surgery for cryptorchidism, success is highest for a primary orchipexy done through an inguinal approach, or a lap orchipexy that's done adhering to the principles of a lap orchipexy. Success sits at around 96%. A one-stage Fowler-Stevens, where you clip the spermatic artery, gives a success rate about 79%. I prefer a two-stage Fowler-Stevens, where you clip the spermatic artery and then come back 6 months later. If the testes is still viable, then cut the spermatic artery and bring the testes all the way down. Then your success is about 86%. Laparoscopy and open repair are equally effective in achieving testicular descent. It really depends on your preference. And this is the traditional open inguinal orchipexy. You've mobilized the testes, taken down the cremasteric attachments, taken down the internal spermatic fascia, repair the inguinal hernia that might be associated with it, and then place it into the scrotum. There's also the Bianchi scrotal approach, where you might make an incision in the scrotum, track up, get the testes, repair any hernia associated with it, and then leave the testes through that same incision. Guideline statement 13. In prepubertal boys with a non-palpable testes, surgical specialists should perform an exam under anesthesia to reassess for the palpability of a testes. Why is that? Well, if you look in general, the etiology will tell you that intra-abdominal, if you have a non-palpable testes, the chance that it's intra-abdominal is about 55%. that it's absent is about 15%, and that it's a nubbin is about 30%. So the question is there a testes present? You can often look at the other side testes and say, in general, the size should be about 1.2 to 1.4 centimeters. If the contralateral testes is 2.2 centimeters, you may, in fact, not have a viable testes on the other side. But contralateral hypertrophy is not good enough alone. You can't just look at that and say, hey, I don't have to look at the other side. In fact, you must look on the other side to be sure that there isn't a testes that's intra-abdominal or confirm that it's absent. So the accuracy of laparoscopy exceeds 95%. If you look and you see no vessels, you do need to explore because that testes may be up by the kidney. If you have blind ending vessels, that confirms a vanishing testes. If you have a blind ending vas deferens, you really do need to still explore for the vessels. And I've done one mistake in my life. I saw a blind ending vas, and I thought I saw a blind ending vessel, but in fact, there was a viable testes found at puberty. You'll never forget one like that in your career, so always look to be sure you see the spermatic artery and that it is truly blind ending. And if you see the vessels in the vas entering the internal ring, you do need to explore the inguinal canal to see if there's a testes that's present you think might be a nubbin, but in fact is a viable testes, or in fact there's a nubbin. So again, laparoscopy, here's a closed internal ring. You can see the vas, you can see the spermatic artery. Here, you have to open and make a groin incision because as just happened to me last week, in fact, you might think, oh, I don't feel a testes, I see this, we're done. No, you can have this child had a viable testes, but because of the way his muscles were, it was just hidden under the external aponeurosis, which is very thick, external oblique aponeurosis. And I would have missed a testes if I thought, oh, he just has a nubbin. I don't take out nubbins. So I always make an incision, look for a nubbin, and sometimes you'll be surprised when there's a viable testes. When you do the laparoscopy, if you see the vessels in the vas entering the internal ring, you want to explore the inguinal canal for a testes or a nubbin. Here's you have the open, you have an artery leaving. You can't quite see the vas, but you see an open internal ring. You're going to need to explore in those situations. If you see blind ending vessels, so there is no vessels going beyond into the internal ring, as you can see here, you see the vas, but you don't see any spermatic artery joining over here. This can confirm a vanishing testes because there probably was a testes which is now gone. But if you saw this, if you didn't see this, you really need to be looking to see if it's up by the kidney. When you see an abdominal testes, the vas and basal artery can be intact. Here's a one-stage Fowler-Stevens. You clip the artery, the vas is there. Now I'll come back in 6 months and we'll see, can I bring this testes down by cutting this or has the testes involuted? So treatment does not end after surgery. The child has to be reevaluated in 6 to 12 months for the location, the size, the viability of the testes. You want to tell the parents about the needs or the issues of fertility and tumorigenesis, just to have that in the back of their mind. In pubertal boys, we will begin monthly testicular self-exams once they hit puberty. So I have all of my children with this problem, with cryptorchidism, come back at around 12 to 13 years of age. I give them a sheet of paper explaining how to do a self-exam, and I demonstrate once to them how to do a testicular self-exam. So going back to that 8-month-old boy with a non-palpable right testes identified at birth, and that 7-year-old healthy boy that we talked about, now we know the treatment, and this is the classic table. You have a boy with an undescended testes. Are they bilateral? Are they non-palpable? Then you want to rule out DST. If not, are they older than 6 months of age? Yes, then you want surgery. No, you're going to reassess at 6 months, still undescended. You move towards surgery. If it's non-palpable, before I put in the laparoscope, I'm going to just check them under anesthesia the same day. You don't do a separate day. But once they're asleep, you might feel that testes pop. Then I might not need laparoscopy, and I'll make an inguinal incision. If I don't feel the pop, it's still internal, I'm going to proceed with diagnostic laparoscopy. And then I go down this And we talked about all of these issues. And you have this slide, and please take a look. And so I hope that I've convinced you about the proper workup of cryptorchidism, looking at the bifurcation between a palpable undescended testes and a non-palpable undescended testes, and the keys to diagnostic laparoscopy. And I'll look forward to taking questions.
I'm so sorry that I have to thank Dr. Shukla virtually, because he has given 4 outstanding lectures on 4 different topics of pediatric urology. One, he started with the antenatal hydronephrosis, then the UTI and VUR, the valve bladder syndrome, and finally the cryptorchidism. So I'm sure that not only the residents, all the urologists are also benefited from these all 4 wonderful lectures. And I'm sure that after listening to these outstanding points regarding the 4 topics of pediatric urology, more and more urologists will be interested in practicing pediatric urology as a subspecialty in large volume. So I request all our urologists to practice pediatric urology, at least some portion of their regular practice, and advance the pediatric urology in Bangladesh further. So from his 4 presentation, I've picked up a few key points to share with my viewers and share our experience regarding this. So when we start with antenatal hydronephrosis, so the next slide, we can see that it starts with the normal finding in the prenatal period, what we should know, because we are seeing that we can find mild hydronephrosis even at in 8% of cases at 24 weeks of pregnancy. And the bladder part, how many, what is the volume bladder should be at what time. So these are very important for regarding the follow-up, for counseling the patient and assuring the parents about the findings of their fetus. Next slide. So another important point Dr. Shukla mentioned about the amniotic fluid, because the amniotic fluid is very important, especially the oligohydramnios in our cases with hydronephrosis and the oligohydramnios, because oligohydramnios and hydronephrosis can lead to, next one, next slide, can lead to pulmonary hypoplasia, which is sometimes very incompatible with life, because sometimes we feel that we can, the hydronephrosis, the big kidneys are responsible for this pulmonary hypoplasia. But as explained by Dr. Shukla, we can see there are other reasons for these too. Next one. And when he talked about the fetal compression and how to decompress, but this is very controversial issue, as also he mentioned that not all the patients, all the fetus are benefited with this vesico-amniotic shunt that is done to decompress the kidneys. So we must be careful if we want to do this procedure. Only selected patients, very few patients can benefit from this procedure, as also I have learned during my practice with pediatric urology. Next one, please. So this is very important. So with the antenatal hydronephrosis, how to define the normal portion. So it starts with the anterior posterior diameter at the different part of the gestation. So when we see there is a cutoff value at 10 millimeter in the anterior posterior diameter. So next, when we are going to follow this fetus postnatally, we should have we should remember this value during the prenatal period. So next one, please. So why this normal value is needed? It is needed to stratify the risk. And why this stratification is needed, we will see in the next slide why we need to do this stratification. Because they provide a low risk to a high risk to intermediate risk. So this risk stratification will give us a clue or a guideline which patient will require treatment and which patient require vigorous follow-up. So next one, please. So in this, we can see only the AP diameter has been taken into account. All the other factors with the kidney, parenchymal appearance, thickness, ureter, bladder, all should be normal. So when all these findings are there, we classify them as low risk. So, next one. And after this, when the diameter increases more than 10 millimeter at 2 weeks and with parenchymal thickness abnormality, ureters are abnormal, especially the bladders are abnormal, and with unexplained oligohydramnios, the risk is increased. So these fetus has to be treated in a different way with a fetus with low risk. Next one. And this is the postnatal finding. So it starts with that it's a classification between 10 to 15 millimeter of diameter, AP diameter. So, but there should be no other parenchymal or ureter or bladder abnormality to classify them as low risk. So we should keep all this point in mind to decide the treatment postnatally. Next one. Next one, please. Yes, this is another part where we classify with the high risk cases. High risk cases are the AP diameter is more than 15, and there are other parenchymal and other uretral even and also bladder abnormality. So this patient requires very vigorous and very close monitor postnatally. So next one, please. These are same, all the intermediate risk, classifying all the risk factors. Next one. And also this high risk one, I told before. The next one, please. So why these are required? These are required to manage this patient because the parents are very anxious when they come with us. In our own practice, we see that antenatally detected hydronephrosis patient parents are very distressed and very anxious. They usually come very early and ask for any intervention, but it is very difficult to make them understand that not all patients with antenatally detected hydronephrosis require surgery. So when we classify according to his classification, risk-based management, we will be able to treat this patient more accurately and more scientifically and assure the parents about the outcome of each child individually. So next one, please. And this is very important. So when we should operate, as I told before, that not all patients in our practice, because in our department, we are having a thesis going on with antenatally detected hydronephrosis. What percentage of patients will require actual operation? So when we see these with a severe hydronephrosis with parenchymal thinking, keeping them in high risk factors and with no drainage on renal scan, when diminished renal function affected kidney, we should think of operating this child. Next one, please. And these are the cases where we should not operate. And it was clearly defined by Dr. Shukla that even in a very dilated kidney, there can be obstructive pattern of the renal slope. But actually, there may not be any obstruction. So we should be very careful when you decide, when you see this kind of graph in our DTPA or MAC3 renogram. So next one, please. So in conclusion, with the prenatal hydronephrosis is common, but not all will have clinical significance. The proper counseling is very important, and assuring the family is very important, and having a clear-cut understanding of the risk factors that are related for their treatment is very important for us to know. And the heroic, as you said, antenatal interventions are very dangerous sometimes, I guess. Not even to give benefit, but it may cause more harm than good to the baby. So with this, we have about the antenatal hydronephrosis. Next, we have the VUR and UTI. This is very important presentation because all these years, the changing pattern of VUR, of treatment of VUR, we are seeing. When I started pediatric urology many years ago, the VUR, the neocystostomy was very popular. You see VUR, you go for neocystostomy. But after all the understanding and all the factors taking into account, the definitive indication should be taken into account when you decide for neocystostomy. So with the here it shows the difference between white UTI present in different races, but in our country, we are homogeneous. I think the circumcision will play a very important role in detecting UTI in children in our country. Next one. And these are the risk factors for UTI. So when we see VUR, we should not rely on only VUR. We should try to find out the risk factor that should be associated with the renal damage and renal scarring. So here there are many factors involved with the non-black, but as I said, we are a homogeneous nation. We may not find this kind of difference, but our circumcision may play a definite role in as a risk factor for UTI, because almost all the boys are circumcised here. So our risk factor is diminished, I think, in this part. Next one. So these are one guideline, because he compared this with 1999 guideline, where VCUG was very much popular after first febrile incidents. But after seeing all the factors considering, it has been decided that VCUG is not compulsory. It should be hold on until it is actually required, because VCUG or MCU, we commonly call, is a very distressing investigation. And previously, when we used to do MCU without antibiotic cover, we could see many complications, even in children, even in adults also. They come with, even with severe orchitis in adult. We have seen that. So VCUG or MCU, we should try to avoid and truly prescribe when it is really indicated. Next one, please. And this has changed the whole scenario of VUR treatment for all these years, because VUR can resolve spontaneously with or without antibiotic prophylaxis. Because as he mentioned, the grade 1, 2, 3, even 4, 50 to 60% of the VUR can resolve within 5 years. So when we have to treat VUR and think about surgery, we should also keep this in mind, that VUR can resolve spontaneously, and how long we should try with antibiotics and wait to see that whether it resolves on its own or not. Next one, please. So these are the general findings, as he mentioned in his talk, because only VUR or only UTI don't cause renal scarring, because there may be renal scarring in utero, from utero also. So UTI and VUR together can cause renal scarring more. And also the BBD syndrome. So in our outpatient department, we really see many patients with voiding dysfunction, with severe constipation. They come with urgency, frequency, and also sometimes they drink plenty of water. So we have to take care of all these also when we try to treat VUR and UTI and all these symptoms they present to us. So not all with continuous prophylaxis may prevent UTI or renal scarring. Next one, please. So what recommendation he has given is to risk of renal scarring individual patient based upon clinical factors. This is very important. The age, grade or reflux. Grade or reflux is very important. And the BBD syndrome or dysfunctional elimination syndrome. These two are to be taken into account when we treat VUR with UTI or only VUR. So intervention should be appropriate to the risk profile. So this is very important point, as he mentioned in his talk. Next one, please. So what we should do, as I told before, that we should treat the BBD taken into account and also treat VUR. So aggressively, how do you treat BBD? We can teach the patient about the time voiding, about treating the constipation, about the dietary habit and hydrations. But in my experience, I have seen that there are many children that drink plenty. This is also a detrimental factor. There should be proper hydration. There should not be over or there should not be under hydration. So all this should be keep in mind when we treat this kind of children in our daily practice. So next one, please. So what are the goals of management of VUR? It's to prevent recurrent febrile UTI. This is very important because this can decide when to operate, when to stop prophylaxis, prevent renal injury, because it can lead, recurrent UTI can lead to renal nephropathy, as we all know. Minimize the morbidity of treatment and follow-up. The next one, please. So this is how he has described how he managed VUR. So in our practice, we can also follow this guideline and with a low-grade VUR prophylaxis. And there are many questions sometimes are asked, how long to continue this prophylaxis? As he has mentioned, until toilet training. But in my practice, usually I continue a little beyond that, because when I see that there is no breakthrough infection, the hydronephrosis is not increasing, or in DMSA, there is no new renal scar, I think we can continue antibiotic prophylaxis for a few more extended period. So after that, if it comes with all the other factors, a higher grade and a recurrent UTI with a breakthrough infection, we can decide for surgery, I think. Next one. Next slide, please. So that's with the VUR and the UTI. And next, I point out the key points in posterior urethral valve. Mr. Shubho, can you please share your screen? Shubho? কি হ্যালো হ্যাঁ 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 স্যার শর্ট করে দিচ্ছি হয়ে গেছে আর 5 মিনিট 2-3 মিনিটে দিচ্ছি শুভ share your screen please. So when it was a very good presentation on the evaluation of the valve bladder syndrome, because this is very important for children, for treating children with posterior urethral valve, because when we started doing pediatric urology, we thought that only valve ablation will cure everything. But as days went by, we could realize that no, it's not. Some children, they do benefit, but many others, they don't benefit. So the valve bladder syndrome should be kept in mind when we treat with these, even when we decide to go for renal transplantation in these children with valve bladder syndrome. About the cryptorchidism, he has given the American guidelines, what we should do, whether we should do ultrasound or not, and when we should continue other factors, like when we consider DST, what are the hormonal assay we should prescribe, or we should advise for the children. And all this, and due to constraint of time, I need to finish here. And I thank all the viewers for their patient hearing, and I hope that pediatric urology will flourish in Bangladesh in coming years. And I'll be very happy to see all the young urologists coming up and taking pediatric urology as a subspecialty. And thank our secretary, Dr. Tawhid Mohammad Saiful Hussain, for preparing such a wonderful lectures on pediatric urology. Thank you. And I now request Dr. Shudip to invite the moderator of the next session.
Thank you, Istiak sir. Thank you. I request Dr. Nurul Huda Lilin, Director, National Institute of Kidney Disease and Urology, to moderate the session on infertility. And this is the last session before the lunch and prayer break. And we will again start our session at 3 p.m. which will be moderated by Dr. Hakim Khurshidul Alam, and this session is on female urology. And tomorrow we have a session only for the residents, how to answer written questions in the exams. Hope you will join tomorrow at your time. Okay, Dr. Nurul Huda, Dr. Mohammad Nurul Huda, please. সুমন
স্যার হ্যাঁ স্যারকে আনমিউট করতেছি স্যার।
Okay. This session is on infertility, and we see that the topics are penile implants.
Mostly the session is on andrology, but they name it on infertility.
Infertility, yeah.
Mostly the topics is on andrology.
Yeah, testosterone supplement, origins and treatment of erectile dysfunction. And I see another topic, nothing beats a TURP. Okay.
Where is Lelin sir? Sudeep, Shuman.
He has joined. I see.
স্যার জয়েন করছে, ওই যে আনমিউট করছে।
Okay.
Okay, sir. Yes.
Okay, welcome, sir. Welcome, sir. Okay.
সুদীপ তোমার স্ক্রিন অফ করো।
না আমি স্ক্রিন শেয়ার করতেছি না তো। ওকে।
হ্যাঁ সুদীপ।
হ্যাঁ ওয়েলকাম।
হ্যাঁ কেমন আছিস?
হ্যাঁ ভালো। স্যার আপনার সেশন শুরু করেন। সেশন অন অ্যান্ড্রোলজি।
হ্যালো।
Yes,
আমরা শুনতে পাচ্ছি।
আমরা শুনতে পাচ্ছি লেলিন স্যার, নুরুল হুদা লেলিন স্যার, আমরা শুনতে পাচ্ছি। আমরা আপনার ইন্ট্রোডাকশন সকালে মর্নিং সেশনে ওয়েলকাম স্পিচে দিয়েছি ইনশাআল্লাহ।
আচ্ছা ওকে, অসুবিধা না। Now let me introduce the author who has written about the erectile dysfunction and BPH management and the sexual dysfunction and sterility regarding use of steroid hormones. He is Mr. Kohler. He is an eminent urologist in America. He has got his expertise on the erectile dysfunction, penile prosthesis, and BPH and sexual dysfunction. He is now working as associate consultant in this regarding these subjects in Mayo Clinic in Rochester. He has awarded his degree regarding the andrology and fellowship from Chicago and from the University of Minnesota. He has got academic practice in Illinois University for 9 years, and he has got 200 articles in peer-reviewed journal and lot many presentations both nationally, locally, and globally. And he is one of the active AUA member and member of the sexual medicine in America. And he is the co-author of Contemporary Treatment of Erectile Dysfunction, Surgeons as Educators, and Genitourinary Reconstructions. He awarded the Golden Cystoscope Award in 2015 and 2016 consecutively, and he is a master trainer of penile prosthesis. Now he is going to present 3 topics. Actually, it is not the infertility topics. It is some sort of sexual dysfunction topics. That is the erectile dysfunction and the penile prosthesis, BPH treatment, and the use of steroid, long-term use of steroid, and the fertility.
We can hear you, but we cannot see you, Nurul Huda sir.
Now we can. Hello.
We can hear you, but we cannot see you.
Oh, you want to see me? Okay, you will.
Yes. Share your video. Share your video.
Yeah, I am giving.
Yes.
Welcome.
সেভ করি নাই তো এইজন্য দেখাইতে চাচ্ছিলাম।
No, it's okay. Now you are looking nice in this pandemic. Okay, continue, sir.
Let's start the video presentation first. Then we are going to discuss about the topics after our presentation is over.
Okay. Thank you. Shuman, start video.
Well, hello, everybody, again. Toby Kohler, still sitting in Rochester, Minnesota. I'd like to talk to you about penile implants for this particular talk, what we've learned after about 1,000 tries of these. Here we go. So again, I'm a consultant for both Boston Scientific and Coloplast, and I'm on the AUA guidelines panel for BPH and priapism. My views are my own, not those of the guidelines panels, etc. Well, I'd like to talk to you about the tools for prosthesis success. And I will use the mnemonic prosthesis to go over all the ground that I'd like to cover today. So we've got patient selection, reservoir considerations, obstructive uropathy, setback strategies, taking out when in doubt, help is always available, equipment, size optimization, infection control, and scrotal consideration. So patient selection is probably the most important part of doing penile implants. Two take-home message would be never implant a stranger and under-promise and over-deliver. When surgeons first start doing any type of case, they're excited to operate, and they tend to exaggerate their success and minimize the results. That is exactly the wrong thing to do, especially with penile implants, a purely elective procedure. We want patients to totally understand what they're getting themselves into, and I like to use a most likely case scenario, worst case scenario, and best case scenario to deliver information to the patient is what they should expect. Never implant a stranger. This implies that you should know your patient well before you go ahead and operate on them. So Dr. Trost, a former colleague of mine, one of the smartest guys I know, he wrote a paper called The Cursed Patient. It was initially called The Cursed Penis, but he switched it at the last minute, and talks about the characteristics of men who get implants, or any surgery for that matter, that tend to be dissatisfied no matter what you do. And so this mnemonic means compulsive patients, unrealistic, revision surgery, patients who do surgeon shopping or entitled, they're in denial, or they have psychiatric disorders. So if any of these things come up in counseling the patients, you definitely have to do a better job of documenting and really setting the tone of the patient as to what a penile implant can and cannot do. So there's a little boy saying, just say no to the cursed penis. If a patient exhibits these criteria, and especially if you're first starting out, it may be a good idea to do this with a partner, so you can potentially have two people, delivering news, or just not operating on this person altogether until these various issues have been alleviated to your satisfaction. When we're doing consents, I like to use these mnemonic reliant limpers as the things that we will cover in both the positives and the negatives of a penile prosthesis. So the positives are it's very reliable. It can help with libido in that once men have the ability to have sex again, they all of a sudden, their cognitive dissonance, which occurs because they know their penis doesn't work, improves. It's invisible. At least in the United States, it's affordable as it's covered by Medicare. It's natural in that nobody knows that they have this device. It cannot be seen in a locker room. And it's transformative. There are many men who are depressed, who don't want to even engage in social situations because they're afraid that it may lead to a situation where they have to try to have sex. And they're transformed, and they start to lose weight, they stop smoking cigars, they buy new clothes, this kind of thing. So it's a powerful tool. On the other side of the coin, you have to talk to men about the fact that their penis length will not get better with an implant no matter what we do, and it may in fact be shorter, at least in their eyes. It can cause infection, which normally necessitates having to remove it. There are mechanical problems that can happen with the device. It's a permanent solution in which if injections work for them, for example, and then you get an implant, take the implant out, then the penile injections will no longer work again. There's always a risk of erosion of the device. There's a risk of urinary retention and problems with LUTs and
Hello? Hello?
অডিও পাচ্ছি না।
শুভ শোনা যাচ্ছে না? হ্যালো শুভ।
স্যার এক সেকেন্ড স্যার।
Okay.
Because A, by definition, Crohn's disease causes shortening of the corpora. That's why there's a curve, and so that will manifest in a shorter penis. And then B, after any kind of event that causes disuse of erections or lack of nocturnal erections, such as prostatectomy or radiation or diabetes, your penis does shrink. 70% of men who get prostatectomy will undergo 1 to 2 centimeters of length loss. Radical prostatectomy is indeed the most predominant etiology leading to penile implant in the world. What about the satisfaction rates? Well, of the biggest study that we have so far, which is the proper study, it's a study group that I'm a part of, basically had 1,000 patients enrolled, and you can see the attrition rates here. But after the first year, 92% of the patients were either very satisfied, or neutral about their implant. So the dissatisfaction rate was relatively low. You can see how the satisfaction rate continues to be high in the men that follow up, but obviously this attrition bias can make this data look overly optimistic. 10% of patients don't use the device ever. And that's because maybe they don't have a partner, maybe their health gets worse, that kind of thing. But most of these guys still say they would have gotten it again, just because they're confident now that they would be able to use it if an opportunity arose. 4% report a surgery or device problem across all time points, right? So about 1 in 25 will have some kind of issue. The most common complaints that men still manifest despite our best efforts to counsel them are concerns with penile length and the pump being able to inflate and deflate properly. Significant predictors of dissatisfaction or baseline depression, the girth of their penis, whether or not they had a surgical complication, and interestingly, previous LUTs or problems with urination. And we had a recent proper finding from the study group showing that indeed implants do improve depression. So that's tremendous. Okay, moving on to R and prosthesis, reservoir readiness. So the implant reservoir is by far the most dreaded part of the case for penile implanters, right? So some surgeons don't do 3-piece devices so they can avoid putting in the reservoir. So they use either a 2-piece, which has really fallen out of favor in my opinion, or a malleable device, which in my hands typically is just used for guys with very poor dexterity or as a placeholder in men who get infections. In general, when you talk about serious complications with penile implants, it's almost always having to do with the reservoir. There's a variety of colors that can come as a result of putting the reservoir into the space erectius. It can be red from bleeding. It can be yellow from bladder injury. It can be brown from fecal matter. So yeah, it's the most dangerous part. When you look at anatomic studies of the proximity of the structures that are at risk when you put in the reservoir, it really changes based on the position of the patient. So take home message, empty the bladder before you do a penile implant and keep it empty, and put the patient in Trendelenburg, which moves their external iliac vein further away and their bladder further away from the field and makes it less likely to injure. So some surgeons will use a sharp instrument to puncture through the transversalis fascia to put the reservoir in that space. I never do that. I only use this, my finger, and just like a foam finger for any kind of your favorite football team. That's a picture of the Minnesota Vikings. That's the football team that I follow. If you can safely puncture the fascia with your finger, you're very unlikely to get into the iliac or the bladder because this is a very sensitive instrument. If you use a scissors or a tonsil, not as sensitive, and you can get a disastrous consequence. Okay? So one of the biggest game-changing things that we've done over the last few years with the penile implants is to use reservoirs in a quote-unquote ectopic place. A better term would be submuscular. Here you see a picture of a intraperitoneal reservoir, obviously playing with the bowel here. You don't want to accidentally put it there, but often you will, by mistake. And so I encourage you to watch this video, which we don't have time to go over today, but basically shows you the different anatomy of placing the reservoir ectopically versus in the traditional space of Retzius. You can see what I'm talking about if you watch that video. Now, essentially what we do in hostile abdomens, defined as people or patients with a history of cystectomy or robotic prostatectomy, we basically take a ring clamp and we kind of push it up into this space right under the strap muscles in the midline, but above the fascia. So it's really difficult to injure anything using that strategy. Check out the video for more details. O in the prosthesis mnemonic is for obstructive uropathy. So there are 3 contraindications for putting a penile implant in. 1 is active infection anywhere in the body. 2 is a patient unwilling to go revision surgery. And 3 instruments after you have an implant in, because indeed you're at a higher risk for complications. So here is a picture of some implant tubing. There's a connector, there's a yellow tubing seen in the urethra after a green light laser. So the surgeon put in a scope, boop, all of a sudden that popped into the field because it's thin there. And so if you have any problems with BPH or LUTS, you take care of that first. Once you get that treated and you get their high PVRs addressed, or bladder neck contractures in the case of prostatectomy, then you can put the penile implant in. Also remember that the distal urethra is at very high risk for injury because that's the thinnest part of the corpora in relation to where the device sits. So if people do penile modeling, you can get this where a cylinder is looking at you in the face, that's a bad day. Or you're always supposed to do an irrigation test when you put implants in. And if you see this is taken with my iPhone here, you can see fluid shooting out of the tip of the urethra as I irrigate the corpora. That is not good. If that happens, you should abort the surgery, leave the catheter in for a few days, and come back and fight another day. Okay, so moving on to S, setback strategy. So again, this is an elective case. And you know, before you do any type of surgery, you want to think to yourself, and ask my resident or whatever learner is with me, what's the worst thing you can do to the patient? What's the worst thing that you can do to hurt me during the case in terms of medical legal risk? And how can we avoid that? So just like you wouldn't fly a plane without a flight plan, you should think about all the potential things that could go wrong ahead of time so that if they do happen in the operating room, you're calm, cool, and collected, and you can handle this, the complication or the situation with grace. Everybody can yell and throw instruments. It's only the best surgeons that never lose their cool and are able to take care of stressful situations. No matter how much training you do, no matter how much fellowship years you spend, no matter how many seminars you attend, nothing actually prepares you to become ultimately responsible for your patients. So it's normal to feel stressed when you first start to do surgery. And remember that if you operate enough, you will get complications. If you look at the literature, most of it's optimistic, and I have a slide about this in a second, but you know, most implant series have a very high attrition, and so it's normal to have more complications as you start. Don't get discouraged. Keep doing your best, and just be honest with the patient, and you'll be fine. And then if you think about involving risk litigation, at least in the United States, it's a good idea to call them. If anything comes up, don't obfuscate. That means don't hide stuff. Let your medical legal team know. Talk to your patient. And most of the time when we look at literature talking about surgeons who get sued, it's people who are poor communicators, not people who actually make mistakes that get sued. It's the people who kind of bury their head in the sand and they kind of wish it never happened. And that's when you get yourself into big trouble. Also, interestingly, and if you're interested in reading about this, there's Dr. Moulton out of Canada. She's a surgeon, and she writes about complications. Dr. Hilo, one of my partners, has written about this too. There's a predictable response to complications in all surgeons, which we're never trained how to handle. It's very, very, you have shock at first, and you have recurring themes. You get depressed, and most surgeons, when you ask them why they retire early, it's the cumulative effect of complications and being able to handle them. And it turns out that as you get older, it does not get easier to handle complications. It's still as lousy and depressing as when you're young. So anyway, that's a very fascinating field, which I encourage you to read about. Here's a slide that details why penile implant evidence is lacking. And I'll let you read that on your own when you go back and watch the video and pause it. But basically, it's tough to really collect good data on penile implants because we don't have registry data. We're working on that, but that's coming in the future. All right, so here's a scenario. You do a penile implant, and you're at home like I was, and you get a text with this image in a secure fashion on your phone saying, this is what the patient's penis looked like after they had a penile prosthesis put in. What do you do? So what's your game plan here for this? Well, for those of you who don't know, that is a very rare complication called gland ischemia, and basically that involves removing the implant. So I'm going to show you these pictures. So this is my patient who we put the device in, and he developed this very uniformly black glands, and he had pain under proportion to exam on the glands. And so he had ischemia. And the ischemia from this results from loss of the corporal arteries, which you've just compressed with the implant. So they have to rely on the urethral blood supply. Well, this guy was very young, but had a horrible vascular disease. He already had lost appendages. He had stents, etc. Excuse me, I'll get that off my screen. So yeah, he had true gland ischemia. So we ended up taking his device out, and then on post-op day 1, because it wasn't getting better. And so at post-op day 6, things starting to get better. Post-op day 11, much better. Post-op day 21, like nothing ever happened. And indeed, he later got an implant, and he did fine. Compare this to a different surgeon who had a very similar picture. There is, again, classic gland ischemia, uniformly discolored entire part of the glands. Here he has a blister. This is also a telltale sign. So this patient, they didn't take the device out because the patient convinced the surgeon not to take it out. He wanted to, but didn't. This is post-op day 12. This is post-op day 21. And this is a few months later. You can see how the penis just fell off. So if you've got this really dark glands, just take out the device. The same thing goes for very fast aggressive infections. If you put an implant and you have an infection within 2 to 3 months, and the patient is sick, pus, fire engine red, just take it out and come back, fight another day. There are some types of implant infections which will respond to emergent salvage procedures, or I should say salvage procedure, not emergent salvage procedures. But for the most part, if it's an aggressive infection, the better policy is to take it out and come back, fight another day. Here are risk factors for gland ischemia: smoking, peripheral vascular disease, history of radiation. My patient had essentially all these risk factors except for radiation. And yeah, that's how he got it. And I've done over 1,000 cases. I've seen this one time. Okay, moving on. Size optimization. So you have to talk to your patients about the fact that the size of their penis will not change with penile implant surgery. It certainly won't get longer, but in their eyes, it may appear shorter. That's along with all the other risks we need to talk about, which I talked about in the beginning. In addition, the SMSNA basically says you shouldn't do any kind of penile lengthening or girth enhancement surgery because it's unproven and high risk. When we look at data, penis size actually changed. The answer is pretty much no, although the subjective length loss was present in 72% of patients. So the patient thinks their penis is smaller, but when we measure before and after of the stretched penile length, it's pretty similar. The reason why the penile length perception may change is multiple. One, they don't get as good a gland engorgement. Two, if you get an unregulated device capsule formation around uninflated cylinders and the patient doesn't inflate and deflate the device for 20 minutes a day for the first year after their surgery once they're ready, they will get a shorter penis. That is true, because the capsule forms around the device will be around the smaller uninflated portion. And so yes, they will get shortening if you don't have them use it every day. If you have them use it every day, it helps that. And then remember that often when guys need penile implants, it's because they've had prostatectomy or they have Crohn's disease. And so as we talked about before, their penis is by definition already shorter, because led to the problem. And so yeah, their penis is going to be shorter as compared to when they were 18. If you have the patient use a stretching device like a vacuum or a Restorex or any other kind of stretching device prior to surgery, you can sometimes regain some of that lost length and get in a little bit bigger size. So that's what I do in men that complain of length loss before I operate on them. When we talk about penile length, most guys who think their penis is too small actually have normal sized penises. And so there's penile dysmorphophobia, where this is a psychiatric problem, just like bulimia or anorexia. When patients look in the mirror, they see something different than what reality actually is. And so the truth of the matter is, after good studies, the average penis length is 5 inches. There it is. And here's the flaccid and erect length. The flaccid and erect length don't necessarily correlate. You can have big variance, or you can have little variance in that statistic. So what tools do we have to maximize penile length size? Well, we do use stretching the penis pre-procedure. We use proper cylinder sizing. If you have Crohn's disease, which is severe, we can use grafting to improve the length of the penis to some degree. We can correct hypermobility. We can use scrotoplasty. There's all these different tricks we can use, but at the end of the day, it's better just to get the patient to think, I'm getting a penile implant to have on-demand intercourse, which is reliable, and just to throw the penile size issue out the window. I tell my patients routinely, if I could change the size of the penis, I'd be operating nonstop. I wouldn't have time to talk to you because everybody would want their penis lengthened. But the fact of the matter is there's no way to safely do that, and we're simply restoring a hydraulic ability to have intercourse. Help is always available. So when you first start out, you should have questions. In the operating room, you are going to run into situations where you're going to question what you do. Your first impulse will be to just say, it'll get better on its own and close. To fight that impulse. It takes much more courage to ask for help and call somebody to do the right thing than it is just to kind of, again, put your head in the sand and close. So for any type of surgery, if you have any doubt as to what to do next, ask for help. The people that you ask will feel appreciated, they'll feel valued. And if somebody comes in from outside the operating room, they have perspective. They're not already traumatized. They can think clearly, which you cannot when things go wrong. It's always better to have 2 surgeons in the medical legal record, and they can help you out of a stressful situation. Myself and my cell phones at the end of this talk, I'm always willing to talk to anybody at any time in the middle of the night. Call me if you want help. If it's not in the operating room, call me when I'm awake, please. But please, I'd love to help you. And there's many other high-volume implanters, maybe your mentors that you can call to ask for help with penile implant surgery or any other type of surgery. All right, moving on for iron infection. The current infection rates are probably somewhere in the all-comers 3 to 10% range. Virgin cases are 1 to 3%, and maybe in the best hands that decreases to 0 to 1%. And the main thing that's improved infections is penile implant coatings, either coming with a coating or being able to dip the device in a coating to prevent infection. That has decreased infections by 50% definitively. Another big risk factor for implant infections is penile revision. If you're doing revisions, we know the risk is much, much higher. And if you irrigate, that's very, very important to irrigate during the surgery to get the old bacteria out of the space. Currently, the best published series are 0% in the proper study for the first 466 patients and 0.5% in the EAD study. It turns out that both of these studies are flawed. The first one is flawed because as we waited longer, infection rate normalized. And as EAD's data, this is in an era where he didn't use antibiotic-coated devices. So this includes knocking down infections that are with wimpy bugs. Now that we use antibiotic-coated devices, which EAD wasn't using in this era, the infection rate tends to be with more aggressive bugs, and so it's a little bit higher. Okay. I will not belabor these points, but this is from a forthcoming publication in IJIR in Steve Wilson's kind of implant corner, I think it's called. So this is just some data tables in which here are preoperative factors which you can address, and there are various levels of oxidative evidence here in the preoperative time to help control infection. Here are intraoperative factors stratified the same way by decreasing risk, no effect on risk, increasing risk, or controversial, and their level of evidence as to things you can do to help prevent infection. And I'll go over kind of the most important ones in a second. And so if you want to look at these closely, I encourage you to look at this publication and the references that we accumulated for this. If you use a systematic approach and a checklist, you will have better results. So this is true with any type of insertion of central lines. You have a standard operating procedures, your infection rates will get better. So this paper demonstrates how they had kind of an outbreak of infection cases, which they weren't able to find the source of the infection ever. But then they standardized procedure, they did all of these things, and lo and behold, their infection rate went way down. Just proving that if you do something systematically, you can minimize error and prevent infection. Here's an interesting study talking about how experience really improves both reoperation rates and infection rates. So just like anything else, the more you do of something, the better you get at it. I clearly am a better penile implanter now than I was 1,000 cases ago. As a matter of fact, the first case I ever did, I got an infection. But interestingly, look, when you stratify volume of cases by reoperation rate for all causes, indication of infection or non-infection, you see when surgeons do 0 to 2 per year, they have a much higher all-cause reoperation rate for both non-infectious and infectious reasons. If they do 3 to 7 per year, it gets a little bit better. 8 to 31 seems to be the kind of target. So if you're doing 2 implants a month, I think that's pretty high volume. That's pretty good, and you can expect to have better results than somebody who doesn't do that many. And then we see, interestingly, the guys who do really high volume, greater than 31, you see a little increase in non-infectious complications. And I explain this by virtue of the fact that the guys who are doing these types of surgeons these are the hardest cases where they're doing the 8th surgery on the penis kind of thing. And so you can have a higher complication rate because of erosion or mechanical failure because they've just had so many surgeries previously. All right, so here's kind of the take-home message for infection inhibition. I use the mnemonic be pacified. So perioperative antibiotics prior to incision is very, very important. I use vancomycin and gentamicin. You look at your hospital susceptibility charts to optimize these antibiotics. I use vancomycin because it has better intercoccal coverage. So you have to really know which antibiotics to give. There are recommendations in all the major guidelines that talk about these. Use Avogard hand sanitizer instead of the 10-minute brush scrub. The Europeans were much better about using alcohol-based hand prep before the Americans were, and indeed this is just as good, it's a lot faster, it's reliable. ChloraPrep for skin prep is a game changer. It's much superior to using betadine soap. So we used to use a 10-minute soapy wash. Compared to ChloraPrep, it's not even close. So when you take skin cultures of the area after you scrub the abdomen with betadine, the culture positivity rate is around 32%, which is just astoundingly high to me. And if you do it with ChloraPrep, it's much lower. It's 8%, but it still isn't 0. So pretty interesting. So switch to alcohol-based skin prep. Irrigate during surgery. We talked about why before. You want to clear any other infections, whether it's a fungal infection, whether they have dental problems, if they have UTI, get that all taken care of. Use devices that come with infection retardant coatings is very, very important. Here the double glove, because frequently when you're trying to put that reservoir in, you'll puncture the outer glove. So it just makes sense to double glove. And we see a lot of micro tears in gloves. There's a lot of interesting research about how often the gloves get contaminated and tear. And finally, efficiency. You want to be deliberate, efficient, but not too fast. There's great data which now shows us that every bonus 20 minutes you spend doing operation in orthopedic cases, hips and knees, you increase the risk by 15% or so. Here it is. We saw a recent ortho study of 17,000 knees and hips, 25% increased risk of infection for every additional 20 minutes over a standard 60-minute operative time. So based on my experience of doing implants for many years now, I think by far the most important risk factors are if the patient is diabetic, yes, no. I haven't had an infection in a non-diabetic patient in a Burson case in my career, including residency, whereas I get diabetic infections probably about once a year, once every other year, doing about 100 or more a year. So for me, diabetes is a pretty clear-cut risk factor. It's unclear if hemoglobin A1C has anything to do with it, in my opinion. There is one study here which shows a cut point of 8.5 seems to be the magic number. So the tighter the patients can get their hemoglobin A1C and glucose control, or their perioperative glucose control, maybe it's more important, the better you'll be. But the other thing is to be as fast as possible, but be safe. If you go so fast that you cause more complications because you're rushing, that's clearly counterproductive as well. So those are the things that I think are important. Finally, closing in on the last few slides of this talk, scrotal considerations. You know, this is the last of the prosthesis mnemonic. Sometimes we can do a scrotoplasty to help improve the external penile length. You have to be careful with this approach because I found that if they're diabetic, they tend to have poor wound healing, that's known. But I've actually had an infection of a case where, because I did a scrotoplasty and the wound was under a little bit of tension, it broke open and the device got infected. So if you're going to use a scrotoplasty, make sure it's not under tension. Along that same line, in general, do not, there's a tendency to do the implant portion of the case, put the device in, and then as you're closing to let your guard down a little bit. The closure is very, very important for the implants. You want to get as many layers between you and the outside universe. So I always close in 3 layers with as minimum tension as possible. I will use Vicryl for deep stitches, but Monogrill for more, layers closer to the outside world. And that helps prevent wound breakdown. And then I use a mummy wrap and a drain in all my patients to help prevent hematoma, which is fine. I also use this drain fastening stitch at the end of the case so that the pump doesn't move around, because I found that's a reason for revision a lot of the time. Okay, well, that is everything in 30 minutes that I think is super important based on doing about 1,000 of these or more of these cases. Here is the mnemonic to remind you. Here's my cell phone. Here's my email. Please, please, please email me or call me if you have any problems in the operating room. Do me a favor of making sure I'm awake if you're going to call me for non-emergent reasons, but I'm happy to wake up if it helps your patient. And I will look forward to the next talk with you in a little bit. Until then, bye-bye.
Toby Kohler here, coming at you from Rochester, Minnesota, Mayo Clinic. This talk is going to focus on the long-term sequelae of supraphysiologic anabolic steroid abuse. So I'm a consultant for both Coloplast and Boston Scientific, and I am on the BPH and priapism guidelines. I am not a spokesperson for the AUA, and so the views of this talk are my own, and also for the next talk about BPH. So for this talk, I'd like to inform the audience of the occult practices, motivations, lifestyle of anabolic steroid abusers, and the overlap of these practices with the available scientific literature. So meet my friend Chad. There's a picture of him when he was 16 years old. And he said, "You are too skinny to play football at a competitive level." So the coach said, "You need to gain 25 pounds. And so Chad was a little bit different than most kids in school. He, instead of having school books in his book bag, he actually liked to read weightlifting magazines, and he He idolized about Arnold Schwarzenegger, these kind of things. And so he took that goal seriously to gain 25 pounds. So here you can see some changes to Chad. And over about a 6-month period from April to August, he went from 128 pounds to 160 pounds. That's 32-pound weight gain through only eating 6 times a day, mind you, and lifting weights for a couple hours a day, 6 days a week. Now, he focused on eating pretty well, and so he ate a lot of calories, like 5,000 calories plus per day, but it wasn't junk food. It was mainly peanut butter, eggs, bananas, clean food, protein powder, that kind of thing. So he finally got big and strong enough and fast enough to join the varsity football team, which he played a few games, and then he unfortunately got hit in the knee and had to have total knee reconstruction, and so he was never able to play football again. But instead, he joined a bodybuilding gym. So pausing Chad's story for a moment, the problem is if you need steroids to get bigger, stronger, faster, you're not really talented enough in the beginning to advance to the next level. So just because you're good enough to play at the college level, because you now take steroids, that doesn't mean you're good enough to become a professional. So in other words, you have to have enough innate talent without steroids to become a professional athlete. And that's the mistake that many, many people who use steroids fail to recognize. The other thing is if you need steroids to actually become a very, very good player and then get to a circumstance where you can't take steroids because they test for it, then you're not going to be very good. Another reason why people start steroids is to look good holding a beer bottle. That's what Chad tells me. Essentially, you're in the corner and you have your muscle shirt on and you're flexing. And so that's why you would start steroids. But of course, you can get to have a pretty good physique with just natural training and good nutrition. Another reason why people use steroids is the instant gratification reason. They don't want to have to put in the necessary work and dedication to accomplish goals. The problem is if you use these quick approaches to accomplish your goal, as soon as you stop these things, they wear off and you start to get fat, etc. Some people start steroids to pursue a career in bodybuilding. This is the extreme minority, as it's an extremely tough lifestyle and only very few will make it. Bigorexia is an interesting term coined by bodybuilders. Essentially, just like anorexics see themselves as fat in the mirror, even though they're skeletally skinny. People who use steroids see themselves in the mirror, even though they're enormous, they have tons of musculature, they view themselves as too small. And so that's a bigorexia. And so it's kind of on the same spectrum for women with weight loss. For men, it's kind of more about weight gain and muscle. And finally, to sustain performance when older and rehabbing from an injury. So most of the time when you hear about professional athletes getting caught using steroids, it's not the young guys, it's the guys that are in their mid to late career trying to maintain their level of excellence or rehab from injuries, which there's pretty good data saying that steroids do help the healing process. So back to Chad. Remember, he was he joined a new gym, age 17. And he was pretty responsible, and so he was given a job and he was left in charge of the place. He then became apprenticed to become certified as a personal trainer. And that personal trainer that he was apprenticing under offered him Dianabol, or D-bol, which is methoxydiasteone pills, for free. I said, well, if you want to get bigger faster, go ahead and try these. And so Chad took the bag of oral medications home and was very conflicted about taking them for the first time. And he tells me about kind of sitting on his bed and having the pills on the cushions of the bed. And finally, he looked at Arnold Schwarzenegger magazine and said, okay, I'll do it. I'll try it. But it was really a tough step for him to actually start taking the pills. And he had explosive gains of primarily muscle. In about 6 weeks, he gained anywhere from 10 to 15 pounds, as he recalls. Compare that to the previous weight gain or the last 6 months. This is much faster, and this was on top of already a very strong physique. So pretty impressive. So what are some of the steroid side effects that you get? We'll discuss some other of these harms later. Well, Chad described back spasms because of dehydration. So whenever you're taking steroids and you're building a lot of muscle, you're breaking down a lot of muscle and rebuilding, a lot of anabolic activity, and that requires a lot of water. People get dehydrated pretty quickly. So when you see people in the gym carrying around these mysterious plastic milk gallon jugs with like a oddly yellow or orange tinted liquid, this is one of the reasons, because it's very easy to get dehydrated when you're taking high dose steroids and you're doing a lot of muscle building. Also, there's something called test flu from high dose injections. So sometimes you can get a flu-like 24-hour symptoms where you feel horrible just from the absolute dosing of very, very high doses. Roid rage. So this is a very kind of widely publicized in the media. And we don't know if roid rage is actually a thing. Chad didn't think it was real because he thought it was just kind of an allocation bias, where if you see a guy in the gym throwing a 45-pound barbell across the gym, you can attribute that to roid rage. Whereas if you see some business guy getting mad at the water cooler, you're not going to attribute that to roid rage. So he says, roid rage is like teenagers. When they don't get their way, they jump up and down, huff and puff, and they make a big scene. And so it's controversial whether or not that's a real thing that affects your behavior. That being said, Chad does report one time where he got so angry he ripped a fence out of the ground and threw it across the yard. So maybe there is something to it. One thing that we do know is real is testicular atrophy. If you take uninhibited testosterone, then the body will shut down LH and FSH production, and the intrinsic testicular function will go way, way down. And the factories are shut down, and the testicles will get very, very small. But Chad never actually worried about this because there's always post-PCT, which is known as post-psychotherapy, a way to trick the body into not shutting down the factories. And indeed, we take some tips from the bodybuilder literature in modern fertility practices, which I'll get to later. Gynecomastia does happen with certain forms of steroids, for which bodybuilders will readily take Arimidex to take their aromatase testosterone to estrogen conversion, block that, and prevent gynecomastia. So these aromatase inhibitors are the best treatment for gynecomastia in men with or without steroids. There are some men who do get erectile dysfunction from certain types of anabolic steroids, and so they will supplement with PDE5 inhibitors like Viagra or Levitra. Balding and acne does occur at higher rates, and again, it does tend to speed up muscle gain and strength by about tenfold compared to natural training. So if you are doing a good job and are very dedicated and are really eating well, you can expect 5 to 10 pounds of muscle gain in a year, and you can speed that substantially with steroids. So let's talk a little about fertility concerns. So in a big study to assess regret in steroid abusers, only 15% expressed regret that was directly related to fertility impact. The reason, of course, for this is that most of them are smart enough to either stop the cycles when they're trying to get pregnant or use Clomid or different types of therapy. One often quoted study of urologists is that 25% of urologists actually use testosterone for male infertility treatment. This is, of course, exactly the wrong thing to do. If you take testosterone for infertility, you will, again, shut down the testicles, and they will be neither able to produce testosterone or sperm. So that's exactly the wrong thing. So do not treat infertility with testosterone. A different study showed of 97 men attempting pregnancy while taking steroids, fertility rate was 93%, with 83% achieving pregnancy within 1 year. Infertility treatment was sought by about 13% of a certain cohort that the study was done with, and 2/3 of those ultimately got treatment. Finally, HCG in combination is really effective in many men with azoospermia or severe oligospermia while taking exogenous testosterone. So if you have a guy that's starting testosterone therapy and he's worried about his testicles shrinking, you can give some HCG at the same time in small doses to prevent testicular atrophy. So in modern day United States, probably like the rest of the world, how does one get steroids? Well, previously it used to be you would go over to that really big guy in the corner of the gym and basically ask, where you could get these things. And so you'd ask these strangers how to get steroids. Now, pretty much you get steroids amongst a circle of friends over the internet. And with a credit card, you could go online right now and order illicit steroids pretty easily with just a few clicks and some searching. So that's kind of the modern day way to get steroids. And I asked Chad, who is basically right now a consultant for guys who he himself doesn't use steroids anymore. I'll get to that later. But he gives advice on how to take it properly and safely. And so he says, very rarely do people get arrested for using steroids. The only time that typically happens is when you try to carry it across the border and they catch you. So sometimes people go into bodybuilding competitions, that'll happen. But, there are a lot of, I'd say, police officers, firefighters, prison workers who actually use steroids themselves to gain an edge. So maybe that's one of the reasons why it's not as, you don't see as many arrests and this kind of thing for this. Anyway, more on that later. So the real deal. So after Chad had initially started steroids and had that 10 pound of muscle gain, he actually got scared off because of his horrible back pain, and he stopped for 4 years. And then he won a bodybuilding competition, which was a clean competition where they tested before and after. And he kind of got the taste for winning. And he came from a very athletic family. His father was a professional baseball player. And so he said, man, I want to go professional. And so then he knew that in order to become a professional bodybuilder, he wasn't genetically gifted enough, it wasn't good enough on his own to compete at that level. And so then he actually moved to Europe and made contacts there with Mr. Holland, Mr. Belgium at the time, third strongest man in the world. And then he made the decision to get hardcore. He relays the story of going with some of these guys into like a back room of a gym, and the guy like opening up a suitcase filled with just all these different medications and pills. And so that's when he really started taking a lot of these combinations of pills. He continued to eat tremendous amounts of food, 5,000 calories a day, 300 to 400 grams of protein per day. It's amazing how much these people have to eat to maintain their body mass. And indeed, he gained much more weight, got to greater than 200 pounds. Actually won some bodybuilding competitions in Europe doing that regimen. So when I was asking Chad about, abuse and stuff in the clinic whenever I saw him when he was my patient, most of the time he's teaching me much more than I could offer him. But so one day I asked him, well, listen, if I wanted to gain 10 pounds of muscle, what would I need to do? So he kind of looked me over, said, well, you're pretty small now, pretty scrawny. So, you could gain 10 pounds of muscle in a month pretty easily. And I'm like, wow, that doesn't seem that difficult or hard. He's like, how much would it cost? He's like, oh, probably about $200. you know, if I helped you get the medications, if a dealer would give you those medications, it would cost twice as much or even more. And I said, well, what would the meds be? He said, well, here they are. You take the oral medication, $1 per pill. You take IM testosterone and nandrolone a couple times a week, some Arimidex to prevent the estrogen side effects. And then I'd say, well, how much would I have to train? You know, expecting him to say, you know, several hours a day. He's like, well, yeah, 45 minutes for 5 days a week. So really amazing how these medications can amplify the natural gains. And again, if I wanted the similar results, it would take me a year to gain about 5 pounds based on my current condition. So here's a table that Chad and I published in an article here. So he and I are both authors on the paper. Basically talks about all the medications that different bodybuilders use. We covered some of them just now in the beginning regimen, but this is for, you know, this beginning, which we just covered. This is the advanced regimen, where you see that the doses that I just went over are 2 to 3-fold what I just covered. And then it starts adding things like T3 for weight loss, clenbuterol for speed up metabolism. This is used in racehorses. Again, IGF, which is very expensive, but that's added in the mix. Lasix and thiazides to get rid of water weight before competitions. Clomiphene to help with testicular atrophy. HCG also help restore natural T production when you're off cycle. And so it's a very kind of elaborate system of medications that the bodybuilding community kind of does the experiments to themselves, and then they publish their outcomes kind of in underground books to kind of get to different regimens. You know, it's interesting when you go to dealers, you know, they tend to, they are disincentivized to give you the best way to get bigger faster because you buy less stuff from them. So, you know, that's another interesting point to think about, is that they want you to come back for more and more medications. Okay, so there's a picture of Chad. Compare that to the initial pictures I showed before it was going to a competition. So he would talk about how part of his bodybuilding training would be just to get huge, and then towards the end or close to competitions, then he would stop heavyweight training and go into lighter weight training, take more diuretics to kind of sculpt and help with definition and musculature. Interestingly, you can see here that he's got quite a bit of you know, definition of his brachiocephalic veins here. If you get down to about a 10 to 12% body fat in men, that's when you'll start to see these veins. And as you start to see veins in different parts of the body, it corresponds pretty well with percent body fat. The same can be said about women and body habitus. So you can look at some pictures on the internet and kind of figure out what your percent body fat is based on how people look and their vascularity. So how and what testing do steroid users obtain? Man, there's a lot of variation here. Most gym rat types, the guys who just kind of experiment short-term with steroids, they don't get anything checked. So that's a problem. You know, people willing to take health risks with unknown substances typically aren't going to check their, you know, lipid panel or their liver function test, that kind of thing. You know, because misinformation is rampant and people seeking the easy method to get big fast, you know, they're pretty easy prey for dealers, which we referred to earlier. Now, most serious bodybuilders will check chemistries, LFTs, thyroid levels, and CBC. They don't check PSA, interestingly. They're not worried about prostate cancer risk, that kind of thing. They are worried about liver perturbations, thyroid levels, because, again, often they're taking thyroid medications. They don't worry about sleep apnea, which we often talk about for, you know, higher T levels, whether or not we should put them on it. And they don't worry about MIs from testosterone. So there's Chad coming in second place to an open contest. You can see ginormous trophies in the back. And so after this, he was going to start to go compete in professional events where he'd get cash prizes. And he wants some stuff. And then suddenly, in 2009, when he came to see me for the first time, his dad died. And he relates to me a story about how he had this kind of understanding that anytime his dad would ask him if he was on steroids, he would say no. And that was the end of the conversation. But they both kind of knew that it wasn't true. Dad died suddenly. He kind of looked at his life, and he looked at how hard the lifestyle was to be a bodybuilder. And he said, this isn't for me anymore. So he stopped everything. He was on 2 to 3 grams of various steroids per week. Remember, a normal testosterone dose is once every 2 weeks, 200 milligrams. So he's on 3 grams per week. I did my best to kind of resuscitate his very small testicles, and it was not successful. And so I gave him HCG, Clomid, all without any luck. And now he's on lifelong maintenance dose testosterone. He's on pretty high dose, I think 200-300 milligrams Q week, but that's what he needs to feel well and to support the current level of muscle mass that he has, which is quite high still. He still is very strong, fit, and big. So if we look at a study here and kind of the use of medications and factors involved with decreased libido, you can see some very interesting trends of why men get decreased libido or not. Of those that use post-psychotherapy, only 50% complained of that kind of thing. All right, so getting to the real question at hand, what is the real risk of steroid abuse? So this is a website headline. Over a quarter of the field from WrestleMania 7 is dead. So you go back and you look, and these professional wrestlers are dying at rates much, much higher than they should be, considering that they're athletes and in very good shape. And so there's been some work done looking at the relative risk and the relative risk of death between athletes who don't use steroids and these bodybuilders or these wrestlers who obviously do and admit to that. And it turns out that it's most of the time cardiac-related stuff. And also it's weight gains of obesity combined with a history of steroid use. Remember, these humans are taking steroids and taking in all these calories. Then if they stop steroids and they continue eating like they did previously, they get fat very, very quickly. So obesity was very predictive of a 15-fold increased risk and 122-fold sudden death risk compared to the general population. So you do some work on the internet. You can go on, this is an article that I found which says big dead bodybuilders. So all these people here listed on the screen in red are all people that died at a very young age and that were known steroid abusers. You can see some very recurrent themes here. MI. It's always the heart. And then sometimes kidney failure. Every once in a while, stroke. But those are the main issues. And there are some papers written about how you can get focal segmental glomerulosclerosis from anabolic steroid abuse. But the average age of death in this particular cohort was 42, way too young. So again, when we look at age-matched cohorts, consequences of androgen anabolic steroid abuse, mortality 3 times higher than non-users when you control for other things. Very interesting papers there. Looking deeper into the cardiac cause of death, there seems to be something to this where you get a little bit of cardiac hypertrophy and then have problems with electromechanical conduction. So a lot of the autopsies from steroid abuse deaths seem to not be plaque-related or MR-related, but rather arrhythmia-related. So people go to VFib and then die in the gym. And so that's one of the problems which may account for this difference in death rate, which is not very well understood, but clearly there's something there. Again, cardiac abnormalities. when we look at thrombotic risk, supported by many case reports, some epidemiological studies, anabolic abuse is associated with increased risk of thrombosis. However, causal relationships still are not there. So we don't really know, again, what the risk is from if it's a thrombotic risk or like a conduction risk. So if you ask Chad, the steroid abuser, historically, what he thinks the real risk of steroids are, he has some very interesting answers. One of them is chronic pain. So if you grow your muscles to these enormous sizes, your joints, your tendons, your ligaments have problems keeping up. And so it's pretty rare to not have professional athletes develop knee problems. They can't walk. They have hip problems because they do this tremendous workload, and the joints long-term can't keep up, and they develop osteoarthritis. And so chronic pain leads to abuse of pain medications, and that leads to further problems of other hard drugs, which lead to a very hard lifestyle. So again, these professional wrestlers, it's kind of rock and roll lifestyle. And so, they're at much higher risk of having these other problems because they're taking narcotics, taking high dose NSAIDs, they're using illicit drugs. All these things together probably add to this much, much higher risk of death prematurely. We talked about kidney problems, liver problems, extreme weight swings occur. And then another very interesting thing to think about is when you ask a steroid abuser to rate his erections once he stops steroids, it's never 10 out of 10. It's always 6 out of 10. When you ask him to rate his energy level after he stops the steroids, it's 5 out of 10. It seems like there's a new set point, a new normal from taking these super therapeutic doses, which really affect people long term when they stop these medications. And so if you're used to an 11 out of 10 erection, yeah, you're going to want injections or PDE5 inhibitors to get back to a 10 out of 10 erection, because without pills and whatnot, it's not there. The other thing that happens is the cost of these medications is so great is that, it's hard to hold down a job that pays for stuff. So that leads to more illicit behavior, i.e. you start dealing drugs, steroids, etc. Or you end up being a bouncer, the guy at the door doing this kind of thing. And that has probably a higher risk of doing shady stuff. All right, there's structural brain changes in people who do anabolic androgen steroids. So that's a fact. And so, where do you get money to pay for steroids if you're going to use them? Well, not surprisingly, some become dealers. Prostitution is actually very common for both men and males and females who abuse steroids. Sponsorship, if you're lucky enough to be good enough, you'll get some money from the magazines. Again, secondary jobs like bouncer security, and then we're starting our own supplement company. So if I were to ask Chad, now, what's your opinion? Should people take steroids? He's like, if you're a child, absolutely do not take it. Your testosterone is super high when you're going through puberty. You can be a natural athlete for at least 5 years before you need to even think about doing steroids. And the reasons to start them are pretty low. A gym rat who wants to look good holding a beer bottle should focus on just good training and proper nutrition, which is sustainable long term. And the place where he thinks steroids should be legal or considered is for professional athletes in the rehab setting. You're asking athletes as they get older and older to still compete with these young guys with higher T levels. And so he thinks it's reasonable, especially for injuries, to help use steroids. Now, I don't have an opinion on this matter, but this is his opinion. And indeed, there is some data which talks about how joints heal faster with anabolic steroids. Here's a rabbit that was tested in some orthopedic trials, and indeed the rotator cuff got healed faster. We've learned from the bodybuilders. We learned about HCG, preventing infertility, from them. And this is published, in 2013, but bodybuilders have been doing this for 30 years. Testosterone causes weight loss. So it's one of the few things that can cause weight loss without recidivism, that is weight gain. And so it's interesting to think, we justify bypass surgery for people who are morbidly obese, which has a high risk. What about testosterone for people who need help losing weight. Something to think about. So what can we learn from this story as I finish with my last slide here? Number one, antibiotic steroid abuse is common with multifactorial origins and at least partially should be viewed as body dysmorphic disorder. Experienced steroid users discourage general public use, especially for athletic enhancement and vanity, especially because if you need steroids to get good enough, you're not good enough in the first place. The literature linking antibiotic steroids abuse with adverse events is sparse and of low quality, and much more work needs to be done here, but clearly there seems to be some kind of cardiac link. And many of the antibiotic steroid abusers have done many of the experiments, and you know, I think it warrants further research and talking to some of these individuals to do some, you know, well-done trials, talking about fertility and T adverse effects with management of common steroid abuse, wound healing, muscle fat ratio, weight loss. These kind of things are all historically things we took from the bodybuilding, you know, folks. So we shouldn't just dismiss them. We should try to get an understanding of where they're coming from and maybe do some, you know, some good randomized trials to test some of the things that they speculate may be occurring. With that, thank you for your attention, and we'll see you for the next talk.
Well, hello, everybody. I'm Toby Kohler. I'm coming at you from Rochester, Minnesota. I'm a urologist here, and I'm excited to talk to you about a couple different sexual health-related topics. The first one we're going to cover is canaries, giraffes, and a little bit of Zen, origins and treatment of ED through vascular mechanisms. Here are my disclosures. I'm on the AUA guidelines panels for both BPH and priapism. Today, I'd like people to think about the link of erectile dysfunction and systemic vascular disease, and try to understand the corollary relationship between the two, and then talk a little bit about pudendal artery stenting and its potential use in treatment of erectile dysfunction. So erections are a neurovascular event. It requires intact nerves, arteries, and veins. In this picture here, you can see the different components of the erectile mechanism. And off screen, there's some kind of stimulation occurring, which is triggering the brain to send a signal down the spinal cord into the arteries for them to dilate, to accommodate blood. And then in a healthy penis, that blood gets trapped. So all three of these segments of the system have to be intact, otherwise erections will not work. When we talk about causes of erectile dysfunction, i.e. what parts of the mechanism fail, the most common etiology is vasculogenic. So what do I mean by that? Well, cavernoso smooth muscle relaxation, the artery has to be able to dilate efficiently. Arterial inflow, there has to be adequate arterial pressure and blood getting to the penis. And finally, venous leak or trapping of the blood in the area. When we look at the other 20% of etiologies of erectile and this is the erect portion. So what I'd like you to pay attention to is the fact that you can see how this potential space of the penis is much more dilated in the erect portion. On the outside is this lining of veins trapped between the corpora and the tunica albuginea. So if an intact penis is working, the arteries expand and these blue veins are compressed passively. And that passive compression actually traps the blood. And so what I like to talk to my patients about in regards to the erectile function is I compare their penis to a bike tire. And indeed, the bike tire analogy is one that the person pumping air into the flat bike tire, that's the arterial inflow, but then the integrity of the bike tire itself reflects the venous competence. So if men have venous leak, the analogy is that it's like pumping air into a tire filled with holes, and the air just leaks out as quickly as it is, instead of being trapped. For counseling with penile implants, I tell men that essentially what I'm doing is I'm replacing the inner tube, so now that they can maintain a fluid, although normal saline this time, in their penis for sex. Okay, so here is see-through artery naked man, and he says heart health equals penis health. Back in the early 2000s, we started coming up with theories as to why the penis and the heart and the vascular system were interrelated. Clearly, we know that problems with erections and other vascular problems share risk factors: age, hyperlipidemia, high blood pressure, diabetes, smoking, sedentary lifestyle, et cetera, et cetera. But it was Montorsi back in 2003 which started to propose this relative obstruction of different sized lumens in the body to help explain why problems with erections would predate heart attacks, strokes, or claudication. And indeed, when you look at the caliber of the vessels in the human body, the penile arteries are 1 to 2 millimeters relative to the coronary arteries, which are 3 to 4. The internal carotids are 5 to 7, and the femoral are 6 to 8. So it makes sense that if you are getting occlusion at similar rates throughout the body, that the smallest vessels would manifest symptoms first. And typically you need about 50% luminal occlusion before the patient even notices anything. So by the time you see this person's gonna have problems with erections, they still don't have enough blockage in the heart, the neck, or the legs for them to experience symptoms there yet, but it certainly is occurring. So more early evidence that, the endothelium of the penis is not independent of the endothelium of the rest of the body. So they took men, normal controls, and they compared them to men with erectile dysfunction. And what they did is they had a device that measured the change in vasculature of the arm. And so they'd apply a stimulus, a blood pressure cuff to the forearm, and then measure how well things vasodilated in response. And it's supposed to vasodilate when you cut off the blood supply to help blood flow to the area. But indeed, we saw that guys with ED, their dilatation was blunted. And this was also demonstrated in response to nitroglycerin. So again, problems with penis predicting problems in blood flow in the arm, which makes sense because the endothelium is an organ that is in the entire body, not just in the penis. Further data comes from Thompson et al. 2005. This is the ED cohort risk data from the prostate cancer prevention trial. I won't belabor the study, but essentially what they did is they followed men over the course of a long study period, and that developed incident erectile dysfunction. And indeed, we saw that men that had incident erectile dysfunction developed significant increased risks of angina, MI, stroke, or any cardiovascular event. The relative risk factors, spanning from 1.4 to approximately 2, are on par to that of men with a strong family history of myocardial infarction or active smoke. Here we see a picture from one of my favorite studies from Mayo Clinic Proceedings in 2009. This was a study in which 1,400 men were enrolled at the beginning of a trial, and they were followed for a 10-year period. At the beginning of the study, the men had neither problems with erections nor problems with baseline heart disease. Over the course of the trial, several of the men developed incident erectile dysfunction. And when you look at the relative risk factors of the men who developed incident erectile dysfunction versus the men who did not, this is the risk for cardiac disease. And you can see that men aged 40 to 49 were 48-fold higher risk for developing, in this study, either sudden death, MI, angiographic abnormality, or angina. So incredibly powerful predictive capacity, particularly in young men. The relative risk tends to get attenuated as we get older. And this is because as men get older, they have competing causes for their erectile dysfunction, such as increased medications, etc. So this response gets blunted. But in 40 to 60-year-olds, you have this crazy increased risk if you develop incident erectile dysfunction. And so you better consider them heart attack waiting to happen until proven otherwise. So there's John McEnroe saying you cannot be serious, because indeed this is one of the more powerful risk increases that I know of in the literature. And so here is the slides specifically relating to the study, which I just referred to, basically recapitulating what I just said, and the incident density, again, being very astounding there. Okay, what about the relation of erectile dysfunction and coronary artery disease timing? So on average, looking at different types of trials, it ranges anywhere from 3 to 5 years before men will have their first heart attack after they have their problems with erectile dysfunction. So if men read the textbook and they follow what the textbook says, then it's erectile dysfunction, 3 to 5 years heart attack, couple more years stroke, couple more years claudication. Sometimes people behave like the textbook says, most of the time they do not. But again, this is the window of opportunity which we need to take advantage of to help prevent preventable death, sudden death. So a lot of the work in this field comes from Graham Jackson. He was a cardiologist who did a lot of work in this area, who passed away a few years ago. But I still love to quote his work because it was a game changer for all of us. And so he says the recognition of ED, or said the recognition of ED as a warning sign of silent vascular disease has led to the concept that a man with ED and no cardiac symptoms is a cardiac or vascular patient until proven otherwise. I basically said the same thing a few minutes ago. That's Dr. Jackson talking. ED should be considered the 10th modifiable risk factor, accounting for over 90% of cardiovascular disease. The others you see listed there. Men less than age 60 with erectile dysfunction should be considered intermediate risk using the Framingham risk classification system, and I'll talk more about that in a second. And then clearly, the more severe the ED men have, the greater the risk of CV morbidity and mortality that they will experience. So this is from an article in the Journal of Andrology, basically stratifying what you are to do with patients when they present to you with erectile dysfunction. And the bottom line is that if they're young, you need to consider them intermediate risk, and you should do these kind of studies. And at the end of the day, doing some kind of exam that looks at the coronary vasculature is advisable if you don't have a good explanation as to why they have ED in the younger ages. Now, it is true that some men have performance anxiety when they're younger, and that is induced by adrenaline and anxiety that the first time they didn't get good erections leads to this kind of self-fulfilling prophecy of not getting good erections the next time. However, if the patients have good erections, or they don't have good erections with masturbation, for example, when they don't have pressure on them, and this is a persistent problem, then I strongly encourage you to refer these types of patients to cardiologists or physicians that specialize in preventative heart health, because these are, again, heart attacks waiting to happen. So in summary then, erectile dysfunction, or ED, also stands for endothelial dysfunction, early detection of problems in the vasculature. It should also stand for exercise and diet, things that we need to counsel our patients to do to help fight the risk of early death, which again, ED also represents. So this is a picture of a coal mine worker who has a little canary in a box. And what they used to do when the workers went down to the coal mine, they'd have the canaries, and indeed, when oxygen levels got low because of the higher metabolic rate and the requirements of oxygen of the canaries stopped singing and died, then the coal miners knew that they better get out of the mine quickly, otherwise they too would die of oxygen deprivation. So I tell my patients, if your penis stops singing, look out, you're at high risk, you need to go see your physician about potential heart disease. That being said, in modern medicine, with absolute definitive evidence that the penis and heart health are related, if you're on a jury and you're litigating a case where a man who was given sildenafil or Viagra by a urologist, and that urologist just gave him that medication but didn't ask about cardiac risk factors, and all of a sudden this guy suddenly dies of a heart attack at age 55, is that urologist medically legally liable because he didn't check for cardiovascular risk factors? I don't know. However, you probably can make a strong case that they need to at least have sent the patient to their primary care doctor to rule out heart problems, or maybe check a baseline, hemoglobin A1C, lipid panel, that kind of thing. My recent reaccreditation test here in the United States had questions about checking lipids and sugars in men with ED. So something to definitely think about. Safe for them to have sex, you can enjoy sex without the risk of dropping dead. You're at much higher risk of dying from doing intensive exercise like shoveling snow, for example. I'm sitting in Minnesota right now and it's a beautiful day, but half of our year it's very cold, there's a lot of snow, so there's always a bunch of heart attacks that happen for people who are stressing their heart because they're shoveling snow. Okay, so what can we do in terms of lifestyle modification that helps both the penis and the heart? Well, clearly stopping smoking is a huge thing that we can improve with. Follow a healthy diet, exercise regularly, and weight loss. All these things provide significant benefit to both organs. And indeed, I always think that the cigarette packets should have this as the warning, as opposed to some some risk that says, you're increased risk for blood pressure on the cigarette card. Nobody cares about that kind of, imaginary risk in their minds. But if it says your penis is on the line, I think less people would start smoking, particularly young men. So daily exercise is incredibly powerful in a number of different mechanisms. It increases nitric oxide levels, which is needed for PDE5 inhibitors to work. It's just the answer to do exercise. And indeed, if we do exercise, there's many meta-analyses now that show that you can have improvements in the penis that are on par with medications. So here is a study that showed men who exercised 160 minutes for 6 months had better erections, and they also had obviously overall better health because they improved all these other cardiovascular risk factors, etc. So, which brings me to the second part of the talk, because here's a picture of a patient asking the doctor, "Give it to me straight, doc. How long do I have to ignore your advice?" We can tell the patients to exercise and eat right and do all these kind of things, but my experience as a surgeon and provider who talks to most of my patients about lifestyle changes, I haven't been very successful with that approach. And so what else do we have to offer besides lifestyle change for vascular-induced problems with erections? Well, here pictured is a giraffe. And the giraffe has a claim to fame because it has the highest blood pressure of any animal in the animal kingdom. If you think about it, it makes sense because they have this really, really long neck and they have to drive blood up to their tiny little brain so that they can eat the leaves that are on the really tall trees, right? So that carotid artery in the giraffe has some very special and unique properties because it has to be able to account for this extremely high blood pressure in these vessels. It's pretty interesting. The actual giraffe heart is not bigger than most mammals in the animal kingdom. It's about the same size of similarly sized animals, but it has a much thicker wall of the myocardium, so it's able to deliver a much stronger stroke volume for similar radius. And it's got to drive it all the way up to the neck for that really high blood pressure. So there is one blood vessel in humans which is also highly specialized and has a lot of specialized properties, and that is the pudendal artery in humans. So the pudendal artery, if you think about it, has very rare kind of rare properties in that in the audience right now, I would estimate that 95% of pudendal artery blood flow is about 5 centimeters per second. For a select few in the audience, at random, that blood flow is 80 centimeters per second, because indeed the variant in arterial pressure between flaccid and erect penises is pretty big, right? There's really no other vessels that have that kind of crazy swing, and that low arterial blood flow state is about 95% of the time, right? So you have to have this blood vessel that can accommodate these big, big switches. And indeed, that's the pudendal artery in humans. And when Dr. Adams, a Canadian researcher, looked at the pudendal arteries in rats, he found that they had a tremendous ability to remodel and really improve the luminal capacity and the strength of their walls to accommodate these different blood pressures. And so they really reacted oddly to different stresses applied to them, like hypertension and such, those kind of things, when you compare them to renal arteries or other arteries throughout the body. It also turns out that the pudendal artery dominates the blood flow to the penis. Okay, so of all the different, where you measure resistance to blood flow, the pudendal artery is the gatekeeper. So if you wanted to systematically take out blood flow to the penis, your pudendal artery would be your most logical target. Which brings us to the ZEN trial. So the ZEN trial was a first-in-man safety and feasibility trial, which I was lucky enough to be part of. And this was performed by Medtronic. And so they decided, well, hey, if we can make stents that go in the heart and improve blood flow, why can't we put stents in the penis? Specifically because if the pudendal artery, I should say, why can't we put stents in the pudendal artery, not in the penis? If we put stents in the pudendal, and that's the master blood flow regulator, then things should improve and guys should get better erections. And so I was a big part of this trial and enrolled many patients. And it turned out that it was very difficult to find the optimal patient, because we had to find patients that had suboptimal response to PDE5 inhibitors, but also didn't have venous leak. So I'm going to show you a few pictures here of patients that this is one patient that we enrolled. So this is an angiogram, and you can see here that the pudendal artery is coming down here. And first of all, when we first started doing this trial, it was very difficult for us to find the pudendal artery. So here it is right here, and you can see this obvious area of narrowing. So that's the type of narrowing that we were looking for in this trial. And then with the help of the interventional cardiologists, we passed a wire, which you can see the wire kind of going through here. And then we applied a stent, and it's kind of hard to see, but there's kind of a checkerboard pattern between here and here, and we've just completely opened up that lumen. And you can see now, as we shoot more pictures, you can see the outline of the penis is very obvious right here. And so we stented that pudendal artery in total in the trial in about 30 to 35 minutes, as I recall. And in concept, it worked pretty well. Whenever we stented these guys, their erections got better. So the main endpoint of the Zen trial was to figure out, is this safe? And so indeed, no penises exploded nor fell off as a result of this trial, which was a good piece of news. So yes, it works. It's feasible, I should say. And then our primary endpoint was to see, a percent improvement of erectile function at the 3-month mark. And so the average 3-month improvement in the IEF was about 12.5 points in the intention to treat analysis, which is pretty robust. But that's a clever time point, because if you remeasure things in a year, then you start to account for things like placebo effect and restenosis. And indeed, that is exactly what happened in many of the patients, is as they get further and further away from having their stent placed, the stent occluded and their problems with erections returned. So in concept, this works very well. But what are the key issues to get this ready for prime time, so to speak? Number one is to identify the proper patients. So remember, we talked about venous leak at the beginning of this talk. So if you hook up an air compressor to a bike tire, it doesn't matter if the bike tire has holes in it, because that air is going to leak out as fast as you pump it in. Same thing with the penis. We can optimize pudendal artery blood flow, but if these patients have definitive venous leak, they're not going to get better, because the blood's going to leak out as fast as we put it in. So you have to be able to exclude men with venous leak before you can enroll them for a stent. And that's actually not as straightforward as you think it is, because you have to do a penile Doppler, and that's a little bit trickier than most people think. And really definitively stating that somebody has venous leak is not as easy as one would believe. But that's not even the biggest problem. The biggest problem is finding men with treatable pudendal artery lesions. The way we found patients in this study was by doing angiography in men that had met the first gauntlet of the Doppler. And indeed, it was even a more difficult thing to, even if we found problems with erections, it was hard to find men with discrete pudendal artery lesions, because we were only stenting the pudendal artery. So if they have narrowing of other vessels, more terminal vessels, more proximal vessels, yes, it would help some, but it might not help completely. So this study was done in 2012. And since then, I think things have come a long way with CT imaging and perhaps even MRI imaging to help identify guys who would benefit from a pudendal artery stent. And if we use that imaging, then we can rule out venous leak next. But the next problem, of course, is restenosis. So again, getting back to the fact that the pudendal artery has very low blood flow 95% of the time, that is much, much more likely to restenose than in the heart, where you have constant turbulent blood flow. Whereas the penis, you have low blood flow most of the time. So I think that's more likely to occlude. Indeed, we put these men on Plavix post-procedurally and to help keep it open. But guys who didn't change their lifestyle, who didn't stop smoking, etc., their disease reoccluded. The best patient we had was a guy with severe erectile dysfunction. We put in this pudendal artery stent, and he had great erections. As a matter of fact, he got priapism the time we injected him with the intracavernosal injection after he got the stent. And then the stent reoccluded, and then his erections went totally away. And then we were able to redilate that stent, open up again, and his erections returned. So definitely works proof of concept for the right person, but not quite ready for prime time based on many of the problems I talked about. I know there are current trials going on right now where they're talking about stenting not only pudendal artery, but more vessels downstream and upstream. And we'll have to see how those trials turn out in the future. Okay, so in summary for this talk, I think the main message to take away is that heart health equals penis health and vice versa. Anything we can do to improve erectile function will improve the heart health. And so we got to get our patients to exercise, eat better, lose weight, be active. All these things are going to help with longevity and sexual function. In young men, you have to really worry about patients with ED, particularly if they have a strong family history of coronary artery disease, like a heart attack at a young age, or if they have any kind of perturbations. And this is the type of ED that is both with partnered sex and on their own masturbating, and is not, psychogenically induced. So a penile Doppler is actually a great screening test. And if you have low arterial inflow based on Doppler, depending on which textbook you read, less than 25 centimeters per second or less than 30 centimeters per second, if I do a Doppler on a young man and they have low arterial inflow, I send them to a cardiologist, and a lot of times they'll get heart x-rays and then end up getting heart stents. And then finally, speaking of stents, the pudendal artery is an interesting notion that works at least for a little bit, but not quite ready for prime time. All right, well, thanks for your attention for this talk, and I look forward to discussing penile implants in the next one. Bye-bye.
Mayo Clinic, and today this talk will cover, does nothing beat a TERP? Here are my disclosures. I'm a consultant for Coloplast and BAUS Scientific. I am an author of the current BPH guidelines for the AUA, and I am also an author for the future priapism guidelines. And I'm not a spokesperson for the AUA, and specifically for this talk, I am summarizing some of the guidelines in my own words or voice, and the views of this talk are my own. Okay, so when you talk about the question, nothing beats a TERP, you have to first define, well, what are the considerations that will have you have the best BPH treatment outcome? And so I try to put down on this slide everything that potentially could affect the treatment outcome for BPH. So I'll briefly run through them, and you'll see these blue ovals show up throughout the talk when I feel like the slides are kind of supporting or about these various subjects. So starting with durability and efficacy, clearly when we're doing a treatment for prostate obstruction or urinary symptoms, we want something that works well, so that the patient notices a difference and we're able to actually come with objective findings that the flow is improved, the PVR is less, and the patient's happy. So that's the first part. But then the second part of that is, so how long is it going to last for? Is it a treatment that only lasts for 2 years, or is it 10 years? And that's actually a pretty tricky thing to answer, which we'll get into later. But at the end of the day, we want to do, as well as we can and have the treatment last as long as possible. The other thing they have to consider when picking the best treatment is how big is the prostate and how is it configured. Treating a 100-gram gland is quite different than treating a 30-gram gland. And if there's a giant median lobe versus no median lobe, that makes a big, big difference. Anesthesia risk matters, right? So some of these procedures or medications, there is no anesthesia risk, or we can do them in the office. Others require full anesthesia, and so clearly that makes a difference. What about the perioperative experience of the patient? How much dysuria is he going to have? How long does he need to keep the catheter for? Obviously, guys don't like to keep catheters for a very long time, and so this is something we need to think about. Cost is an important thing. Can we even provide this treatment reasonably? Is the insurance going to cover it, etc.? Surgical reproducibility and learning curve. How difficult a procedure is it to learn? Clearly, something may be a great, excellent surgery, but if only 5 surgeons in the world can do it, well, you're not going to be able to offer it because you yourself can't do it. And then how long does it take to get really good at something? Patient preference, obviously, you want to follow what they want to do in a shared decision-making model. And then other things to consider are, what are the type of symptoms the patient is having? Do they even need a surgery, or do they have irritative symptoms that would get better due to the medicines? Or something, Botox in the bladder, for example. Bladder decompensation. How long can patients go without getting treatment, without causing permanent damage to the bladder? That's the million-dollar question. We'll get into that later as well. Anticoagulation, can you do the procedure on blood thinners? What's the risk of bleeding? What's the risk of stress urinary incontinence? And what's the risk of TR syndrome? Transmural resections syndrome, where patients can go blind, right? And finally, what are the sexual side effects of the modality? So sexual side effects has been the big determinant in pushing the field forward towards kind of more minimally invasive treatments. And so we'll get into that in a little bit. So here are the 2018 AUA guidelines, which were then updated in 2019 and then again in 2020. So I'm going to go through each of these individually because they're important. Number one, clinicians should take a medical history and utilize the AUA symptom score to evaluate bothersome LUTs. This AUA symptom score is a great tool which gives the patient something to do while you're late for clinic. And it's a great way to chart progress. If you have a before and after, you do something. All right. So as long as you do these questionnaires, which you should, you can really have a good sense of how much you're helping, how much improvement is occurring. In addition, you're going to want to do some studies, that is, assess the post-void residual volume, check a uroflow test to see how strong their stream is, and maybe consider pressure flow studies to get an idea of the relative strength of their bladder versus the relative obstruction of their prostate. Okay, that's number one. Number two, clinicians need to now consider assessment of the prostate size and shape via imaging or cystoscopy or looking at pre-existing CTs or MRIs before you can decide what the best treatment is, right? If you've got a 100-gram gland, that's going to take some treatments off the table, as opposed to a 30-gram gland where pretty much everything is maybe fair game. Perform a PVR assessment. So I would argue this is probably the single most important test you can do in the BPH patient, where you assess how much urine they're leaving behind in their bladder. This is one of the main drivers of surgery versus non-surgery for me personally, and we'll talk about this more in a little bit. Uroflow test. How strong is their stream? And in combination, how much do they leave behind? And then finally, if there's any confusion and you need more information, get some pressure flow studies. Get a better idea of the relative efficacy of the bladder squeeze versus prostate resistance. Now, new to the guidelines this year was Guideline 6. Clinicians should inform patients of the possibility of treatment failure and the need for additional or secondary treatments when considering surgical or minimally invasive treatments for LUTs secondary to BPH. That is to say, we have to be sure that when we're helping patients decide what's best for them, we talk to them about how long these things are going to last and how effective they're going to be. And as always, we want to utilize a shared decision-making model. So here is a AUA symptom score. And this is a picture of, probably don't know this if you're in Bangladesh or India, but that's a sunfish, a very common panfish in the state of Minnesota that people fish for, and then they do fish fries and put them in batter, and it's a tasty little fish to eat. But anyway, I use the word sunfish as a mnemonic to help remember the various things that are tested for in the AUA symptom score. So you should pretty much know everything that the AUA symptom score asks about, because if you don't have it, you can ask specifically about these various components that it's featured. So straining with urination, urgency, nocturia, frequency, intermittency, the stream itself, how weak is it, and then half empty, how well do they empty their bladder. Here's that one. So that's the only way I could get it to fit in the sunfish mnemonic. All these AA symptom scores are diagnosed with this questionnaire, where the patient is supposed to ask, over the past month, how often have you had the sensation of not emptying your bladder? 0 through 5. And so ultimately, you'll have 7 times 5 as a possible total. So you'll have 0 through 35, 35 being the worst score, severe, and then anywhere from less than 8 are mild symptoms, 8 through 19 are moderate symptoms, and then severe symptoms here. Why does this matter? Well, when you start talking about improvement, when you improve from an 11 to a 9, the percent change, or let's make it easy, the percent change from a 10 to an 8 is a 20% improvement, right? If you go from a 35 to a, let's see, 30, yeah, that's a 20% improvement as well, right? Or somewhere in there, that math. So where you start at the beginning, the relative improvement shifts. So when you talk about improvement with procedures, you need to know the relative changes and where the scale starts. So something to think about. The other thing, part of that scale that's important, is that nocturia is a different question. You do not answer it this way. It's specifically how many times are you getting up in the middle of the night? 0, 1, 2, 3, 4, 5. Most guys, when they're young, get up 0 to 1 time. And as you get older, that changes to 2 to 3 times. That is because antidiuretic hormone decreases, amongst other reasons. And so it's normal to get up a couple times in the middle of the night, and that's nocturia. So be sure to recognize that. And then the important thing here is the quality of life score. If you were to spend the rest of your life with your urinary condition just the way it is now, how would you feel about that? Well, 0 through 6 is 0. You're delighted with your urination. 6 is terrible. Most people are going to come to you when they're in this range, right? And we're trying to move them down a couple notches on the ladder. Okay, so when we treat BPH, clearly not everybody needs surgery. And there's some things that you can think about that makes it easier to pick which one. And this relates to patient bother and symptom type in our initial picture. So consider the concept of urinary chief complaint. So this is a concept popularized by Kevin McVeary, and Chuck Welliver is the first author on this paper. Basically, what is the most bothersome symptom that you have? So they asked a group of patients, what bothers you the most? And the answer overwhelmingly is nocturia, getting up in the middle of the night. People don't feel rested. People are bothered by this. Whereas if they have a weak stream, they're like, don't really care that much. Sometimes they care, but more often than not, it's nocturia that bothers them. Nocturia is very complicated, and I argue warrants its own guideline. Nocturia is multifactorial, and sometimes it's related to sleep apnea. It's also related to increased night volume and frequency, etc. So, yeah, nocturia is something that we have to address. And in this study, when they looked at which of their patients got better, not surprisingly, the guys with nocturia as a chief urinary complaint, despite the best efforts of board-certified urologists who write the guidelines, they didn't get better in the nocturia patients. The other patients did. And so along that same line, I like to separate the type of voiding symptoms into classically described obstructive versus irritative symptoms. Now, those are old terms, and now we use the terms voiding and storage symptoms. But basically, does it have to do with the physical strength of the stream, not being able to empty, pushing, straining, versus I have to go often, I have to run to the bathroom, I get up in the middle of the night often. Clearly, there's an overlap between these two, right? If you don't empty your bladder well, you're going to go more often because you never empty the bladder well. But if you have somebody that empties their bladder well, this is to me a strong indication that they have more irritative symptoms than obstructive symptoms. And so I would push heavily to favor medical management and lifestyle management, whereas the guy with a high post-void residual, weak stream, those are the guys I feel much more comfortable doing a procedure to because I feel like they're going to get better. Again, if you're ever in doubt with whether or not you should operate on somebody, because there are risks to doing operations, Sometimes you can give patients a trial of alpha blockers. And so if they get better with medications, that's indication that they're probably going to get better with a de-obstructing procedure. As always, if you have a patient coming in purely with irritative symptoms and the picture is not making sense, with or without hematuria, think carcinoma in situ. It's just one of those things where you don't want to miss because the morbidity and mortality is so high for that misdiagnosis. So keep that in the back of your mind. PPH testing. So we talked a little bit about this previously, but flow studies are very important. So having the patient having an urge to go on a scale of 0 to 10 with an urge of at least 8, 9, or 10 is very important. If somebody has an urge to go of 9 or 10 out of 10 and they only empty out 50 milliliters and they have no PVR, clearly you're dealing with a small capacity bladder and irritative symptoms, right? But if you have somebody who doesn't have the urge to go, you can't really glean a lot from the study because you're not getting a real world picture. So make sure they have a high urge to go. And then typically the accepted amount in the time where they don't have a strong urge to go is 150 milliliters. If they put 150 milliliters in the device, it's trustable data. If it's less than that, it may or may not be legitimate. The flow study of a Qmax less than 10 centimeters per second is very predictive of having problems that need to be addressed. Anything higher than that gets a little bit hazier. Post-flow residual volumes, interestingly, we use the number of about 300 milliliters as kind of the cut point of, we start to worry about them with retention, maybe they need something procedurally, etc. Unfortunately, PVR is not very predictive at urinary retention, but a volume of 300 milliliters is typically a cut point that a lot of us will use as a cut point. Another thing to think about is when you're considering anticholinergics in men with irritative symptoms, but also high PVRs, typically less than 300, less than 250 milliliters is considered safer to give these medications, and they rarely will go into retention with a PVR less than 250. But if the PVR is higher than that, then the risk for retention is real with anticholinergics being added on. Pressure flow studies, again, get a little more data now as we're plotting force of the urine, the strength of the urine, along with the bladder squeeze. Now, there's a new test called UroCuff, which is not in the AUA guidelines, but I'm editorializing about here, where we just published a paper on where this is essentially a form of urodynamics where the patient will have a blood pressure cuff or a little penile cuff placed on the penis while they urinate. And what that does is, as they're urinating, the cuff squeezes down and stops their stream at the peak pressure of the bladder. So now you can start to plot flow against the cuff pressure, which is that where the stream stops. And so we recently published a paper with Dr. Kaplan, who's also on the guidelines, was the primary author, in the Journal of Urology, where we had 50,000 patients that went to urologists or urology clinic and were getting this UroCuff test, right? So this is not a general population. These are urologists, urology patients. And we see that the UroCuff divides patients into these 4 categories. And I think when you think about what can happen to the bladder over time, I think this is a very reasonable model. So this is the first zone, zone 1. This is everybody's happy. There's high flow and relatively low pressure needed by the bladder to empty well. So this is unobstructed. And of the 50,000 patients that were tested in the urology clinic, about a quarter of them, 24%, were in this state. So if you have this kind of picture, clearly you don't want to do surgery on these guys, right? It'd take a lot of convincing to convince me to do surgery on this type of guy. Zone 2, this is where we're starting to move into the obstructed zone. Zone 2 is kind of in between. 32% of this total 50,000 patient cohort were in this high pressure, high flow. So now the flow is still good, but the bladder's starting to work a lot harder to get the urine out. As the bladder gets weaker with time, now you still have this high output, but now the flow starts to slow down. So this is the obstructed red zone, when this is the zone where I feel much more comfortable doing a procedure in. And 29% of this 50,000 patient cohort were in this zone. And then the last zone, this is the much too late zone where you have very poor bladder squeeze in a very low pressure, low flow situation. Now, this Eurocuff test, I would say is not as good as formal urodynamics. It does not give you as much information. But I think it's a reasonable test to start to stratify patients into these different types of risk categories. So maybe in the future, these will be analyzed in AUA guidelines. For now, they're not in the AUA guidelines. Only, pressure flow studies and formal urodynamics are. The other thing is we can talk about in BPH testing is, again, imaging. Because some of their new treatments involve the ability to do it if the gland is a certain configuration. If it's, there's less than 80 grams or less than 100 grams, it makes sense that you got to obtain the gland size to know if you can do which treatments you're going to pick. And indeed, if somebody has a big old median lobe, the current prostate guidelines still say it's probably not a good idea to do certain types of therapy. So if patients come in with mild symptoms, it is very reasonable to do watchful waiting. And it's only when you start to get moderate symptoms counts as doing something. And the need to intervene is black and white based on renal insufficiency, which is rare, acute retention, recurrent infections, chronic retention, and refractory prostate bleeding. So these things you should do something for. But when we look at studies in which we kind of follow patients expectantly versus being TERP, we see that there was a price to waiting in a very often quoted study by Flanagan, where the men who got treated earlier with surgery received a level of happiness that was never achieved in the patients who were put on watchful waiting and then crossed over into a surgical cohort later on in life. So there does appear to be a price to waiting in delaying care. And that's the million-dollar question. Many men will surgery, and by the time they need surgery, sometimes it's too late, and they're going to have to do self-cath the whole time. So figuring out which men are going to progress to needing more procedural solutions, that's the million-dollar question. And indeed, we only used to have TERP as an option. But in the 80s, medications came and the pendulum swung, rightfully so, to many men getting medicines because TERP caused incontinence, TERP syndrome, bleeding, hospitalization, blood transfusion, all these bad things. And so if we can get away with doing less surgery and less bad side effects by giving medication, great. But now the pendulum has swung too far, I would argue. And now there are men that are on pills much too long, or they're just lost to follow-up because they're not good at taking care of themselves. And they come to us with bladders that are kaput. And so there are papers written about the patients we tend to see now who are on medical management are older, heavier, they have more comorbidities, they're more likely to be on anticoagulants, and they have larger prostates. So these things themselves predict a higher surgical risk, right? So, and we do know that if insufficiently treated, bladder outlet obstruction can lead to irreversible bladder dysfunction, rendering later bladder obstruction treatment less effective. So we got to get to the patients at the right time. So in the era where we only had TERP, where it would cause problems with erections and ejaculation, all these other bad things, it made sense to switch over to medications. Now we're having new treatments which can minimize some of these other bad outcomes, such as incontinence or erectile dysfunction or bleeding. So maybe the pendulum needs to switch back to more aggressive treatment earlier in life. And that's my opinion. So BPH medical management, I won't belabor this, but remember that lifestyle change is very important. So bladder irritants such as caffeine or alcohol should be minimized. Many times in clinic, we'll find patients are drinking excessively, many liters of water a day. There's the saying that you need to drink 8 glasses of water a day. I'm not quite sure where that came from the medical literature. I speculate maybe it was somebody who was selling water at the time. But unless you're a stone former, you don't need to drink that much if it's making you miserable and you have to pee every 30 minutes, right? So I think as the Greeks said, sophrosyne, everything in moderation, including fluid intake. And the thirst mechanism of humans is very sensitive. I would argue that if you are drinking a certain amount and getting thirsty often, you're not drinking enough. But if you're drinking enough not to get thirsty, that's probably good enough. That's my opinion. Other lifestyle changes, people can double void before they go to bed. They can elevate their legs to get rid of lower body edema before they go to bed. And so that's an option. Alpha blockers, 5-MRIs, a combination thereof are a good treatment option. Daily tadalafil is a new player on the block. It requires a 5 milligram dose daily, not 2.5 milligrams for it to be effective. And I found that this works very well with irritative voiding symptoms. Interestingly, these medications don't improve flow, but they do improve AOA symptom scores. So thus, it must be the irritative components that are improving with daily tadalafil, and I use it for that a lot. Anticholinergics and beta-3 agonists are a good adjunct, and there's no rule saying that you can't give a beta-3 agonist in combination with an alpha blocker. The data shows that you don't get much bang for your buck by combining some of these, but you can do it, and it may help some. And here's a word of caution. There's a study by Giona et al. In April of 2018, and it showed very poor understanding of the sexual side effects of both medications and surgical treatments for BPH. So if you're going to have a shared decision-making model, you have to have a good understanding of what those sexual side effects are. Here are your options, okay? So I'm not going to belabor many of these treatment options, but all of these different treatments have different side effect profiles, different anesthesia risk, different perioperative experience, bleeding TR syndrome, surgical reproducibility learning curve. I will call out a few of these things. So monopolar TERP, this is the gold standard which the guidelines were used as a comparator group. It's still okay to use monopolar TERP if you're more comfortable with it, but obviously you have a risk of TR syndrome with prolonged TOR, and so many providers have switched to bipolar TERP, which is very similar in its delivery, its action of the surgery. And so this is probably a little bit safer approach, but it's still legitimate to do both. Whatever you're better at is fine. For large prostates, what do you call large? Greater than 100 grams, greater than 120 grams. Open prostatectomy, laparoscopic or robotic assisted is a great procedure and still should be utilized if you're comfortable with whichever approach. TUIP, transurethral incision of the prostate, I think is underutilized, is good for small glands. It tends to confer a little bit better erectile dysfunction. Advantage has less ED, less ejaculatory dysfunction. TUVP, vaporization of the prostate. This is where you use different forms of energy, like the button, for example, typically a bipolar-based energy using a roller ball or a button configuration to vaporize the prostate. Also very good compared to TERP, bipolar TERP. PVP, or green light laser, very effective in the right hands, has similar outcomes to monopolar and bipolar TERP. And HOLEP, another excellent treatment approach if you're good at it. The problem with this one is it has a high learning curve, but this is probably, if I had to pick one that's the most effective to remove tissue transurethral, this is the one that I'd put my money on. And I think they have very good improvements in flow and PSA reduction, etc. Aquablation, new player on the block. Using water as your TERP source as opposed to conductive heat. And then prostate artery embolization, still regarded as experimental in the current AUA guidelines should only be done in the context of a clinical trial, although this is pretty controversial based on who you ask. So I have a few more options here, which I talked about. The two very common players are prostatic urethral lift. This is where you use little clips to clip open the prostate. And so you see this beautiful defect. And then there's Resume, which you use convective steam therapy to create a defect by inserting this probe into the prostate. A fang is deployed as this video fires up, and you deliver several treatments in a row to essentially deliver a steam ball to various areas in the prostate, as you see here. Here's a picture in the bottom of a before and after a Resume procedure. You can see that this prostate really improved, and this median lobe went bye-bye after doing the Resume convective radio treatment. So this is one that I do a lot in my clinic and have a lot of experience with. But you know, these two treatments, both UroLift and Resume, I think have a lot to offer because specifically of sexual side effects. So where do sexual side effects come from with TURP? Well, there's two things we worry about: retrograde ejaculation, which happens in about 65 to 70% of TURPs. And the better you are at removing tissue, the higher this number goes up. And ED. And there's about a 14% de novo ED rate if you look at good TURP trials. There's a 5% de novo ED rate from hernia and cholecystectomy. So there's probably about a 10% net de novo ED rate after using a conductive heat source. All of this varies in the literature. These studies are underpowered, but at the end of the day, if you have capsule perforation, concomitant CV disease, you use a lot more energy, you deliver your energy at the apex where it's a little bit thinner, you're probably at higher risk for ED. The risk of ejaculatory dysfunction is not entirely understood, but probably is related to resection at near the veru, although some experts argue it's the bladder neck. I think my money's on the verumontanum. The minimization of resection there helps spare ejaculation. And UroLift and Resume clearly have an advantage in this capacity. Durability. This is a lecture in itself, but it's very difficult to compare the durability of these minimally invasive treatments to the standard TURP because they didn't really assess durability in the earlier trials like we do now. We're very strict. We're very hard on these new approaches where if they start a medication after a few years, boom, failure, retreatment rate. They didn't even assess that for TURP or green light, PVP, etc. So it's hard to compare these things. But the data is coming out that, you know, these treatments probably have a reasonable 3-year retreatment rate. And if you look at large data sets, retreatment rates for TURP and green light, 10% in a big Canadian study. So, you know, listen, the durability of these treatments is going to be highly variable based on the patient perception, the surgeon's motivation to act. It's complicated. But obviously we're striving to make this as durable as possible. And in order to get the greatest durability, I think the more tissue you remove, the better off you are. And this is probably why HoLEP is probably the best, or simple prostatectomy is going to give you the most durable response, but at the cost of retrograde ejaculation, maybe higher ED rates. So this is my last slide as I finish up here. And so, you know, when you look at the BPH surgical management guidelines and the soon-to-be-released medical management guidelines, you know, you can look at these pictures here and look at the assessment of prostate size, which you talked about. If it's very large, consider simple, HoLEP, THULEP. That's both enucleation techniques. For average size, you know, kind of dealer's choice. Small prostates, you know, you have TUIP in there, which I think is underutilized. And so again, the AUA guidelines call out both Resume and UroLift for being better at sparing sexual function and ejaculation and ED rates. Clinically complicated patients that are on anticoagulation, it cites that HoLEP, PDP, and THULEP should be considered. I have some personal experience doing a lot of cases of steam treatment on anticoagulation. I have some published AUA abstracts showing its equivalent, and so more work needs to be done there. But this is potentially something that can be done on anticoagulation. We'll see how the others pan out in the future. And so, again, look at the entire picture to figure out what treatment is best. So does nothing beat a TURP? Clearly things beat a TURP at this point. It all depends on patient perspective, surgeon perspective, which side effects you're trying to minimize, etc. Be sure to do an adequate workup, including history, physical, flow tests, AUA symptom scores before and after. Use a shared decision-making model, and then pick with the patient the best treatment for them based on their level of symptoms and their situation. That can be very reasonably, can be observation with follow-up medications alone, minimally invasive procedures, or standard TURP, operating room procedures, or combinations thereof. So there is no one right answer, but if you talk to your patient about it, you can help him make the right decision. With that, I'll end my talk on BPH. Thank you for your attention and listening to me drone on in these various lecture topics. See you again next time. Bye-bye.
Thank you, Dr. Kohler, for his nice presentation. I think there are supposed to be question answer and question section, but because there is a shortage of time, because another speaker will speak in another session, I think. Sudhir, किसी बोलवा?
Sir, you can conclude. Yes, you can conclude.
I think
by adding some
nicely
comment.
presented about the topics he declared. About the erectile dysfunction, he has told out that the vasculogenic cause is the 80% cause. It is in the Western countries, but in our countries, I think it is the psychological aspect of the people is concerned about the erectile dysfunction. Because our club very hardy and laborious, and the atherosclerotic changes are much less than that of the Western countries. But the vasculogenic cause is concerned, the fan should be intact. That means, vein, artery, and if these three are intact, then the vasculogenic cause is not supposed to come at all. But if the vasculogenic cause is not there, you should go for an angiogram to see whether the pudendal artery is intact or not. If it is not intact, then you should go for the vascular dilated peripheral pudendal stenting of paramount importance for the treatment of the vasculogenic cause of the erectile dysfunction. And plus, there should have a lifestyle modification and appropriate anticoagulant therapy for 1 year at least for preventing the recurrence of the blockage of the stent at the pudendal site. And about the penile prosthesis, it must be warranted that you use it only when it is essentially needed, and choice of penile prosthesis should be on the basis of patient's education and the consultant's option and the proper consent to expertise and the position of the patient and is of paramount importance, and the prevention of infection. So for any form of procedure, the prevention of infection is of paramount importance for the success of the surgery. And here the surgeons, patient's factors, surgeon's factors, and the antibiotic is also a factor for prevention of infection. And retention areas must be avoided and treated before going for any sort of penile prosthesis. And the length and pump is of great issue, and it should be discussed in a separate set. And the redo cases are really absolutely difficult for the treatment of erectile dysfunction. Regarding the long-term anabolic steroid use, the chronic pain, testicular atrophy, erectile dysfunction, infertility, gynecomastia, and baldness of the skull, focal segmental glomerulosclerosis, and microinfarction and hepatic progress, all these sorts of things it can happen. So my comment is, if you want to be stronger unnaturally, according to your sweet will, in a on side, then the nature will jeopardize you in the natural side. And another is the last paper is transurethral resection of prostate is the gold standard. But you should mind that it is a gold standard treatment for the prostate, benign enlargement of prostate, but it should be in a golden hand. But it may be a dangerous situation in a sudden hand. So there should be a very long learning curve between converting a sudden surgeon to a gold surgeon, and must be achieved going for a TURP. TURP, you must have a perfect assessment of the patient as a whole. Because if the patient has got only negative symptoms, that patient will not also respond to TURP. Detected and treated before going for TURP, otherwise the patient will hang on your shoulder. So assessment and operation of TURP are both equally important and very important for the surgeons who are going for TURP. Thanks to the organizers, Secretary General of BAUS, Dr. Tawhid Muhammad Saibul Hassan Bibu, and the President of BAUS for organizing the seminars in such a corona situation where my mind is blowing towards anything like this, and they are refreshing our mind, not only our students, our members, and the urologic BAUS family. They are refreshing our mind with knowledge, and the attitude of the society should be like that. I must thanks to our BAUS and President BAUS and the and last but not the least, the Scientific Secretary of BAUS. Thank you all. The next
Thank
session
you.
will be
Thank you.
chaired by
Thank you,
Professor
Dr.
A.K.M.
Nurluda
Alam,
Lilin.
Chairman.
Yeah, thank you for nice conclusion of an
Thank you.
important session. Yes, sir. Thank you. Thank you for nice conclusion. And you summarized the session very well. That helped our resident and all the members. And I give my thanks to all the participants. Our next session is at 3 p.m. on female urology. Before that, you can take your lunch.
Another point is,
Yes, sir.
if the Dr. Sudhir, if the residents
Yes, sir.
and the members have any question regarding these three papers, as because there is shortage of time, we cannot answer, we cannot give the question and answer session. They
Yes,
can
sir.
write it in email, and we can send their answer to their email. Okay.
Yes, sir.
Thank you, Lelin sir. Thank you very much.
You just tell them to do that.
Thank you, Lelin sir. Thank you.
So what about our next
Dr.
session?
Bibu.
Okay, जी ललिन सर.
Hello.
जी सुनते.
If there is any questions about this, about the three papers, because there is shortage of time, they can ask the question through email, and we can send their answer to their email. And
Okay,
because there is shortage of time, we cannot give them a scope. You just tell them.
Thank you very much. Thank you very much, sir. So there is a short break of lunch and prayer. Just strictly, we will start the next session at 3 p.m. Dr. Sudeep, okay?
Okay, we are coming again. At
Okay.
3.
Okay. Thank you, sir. At 3 p.m. we will again
We will
restart.
start at 3. Okay.
Okay, sir.